cool blue light, like the cool blue light.
Stereophonic sound for the home is recorded on two separate tracks, each one giving special emphasis to certain sections of the orchestra, as heard from those positions. Now, when played back simultaneously on two separate systems, the sounds are blended together to achieve a new dimension in sound, impossible to obtain in a monaural recording.
Good afternoon. Welcome back. We are going to start the main conference. We had an excellent session in the morning on genetics and kidney disease. And now we would like to proceed with the debate. Topic: disease donation after cardiac death will abolish the waiting list in India. And we have speakers Dr. Shruti Tapiawala and Dr. Nivedita Kamath. And I request Dr. Vivek Kute sir to chair the session. Dr. Vivek Kute, Professor, Unit Head, IKDRC ITS Ahmedabad, Secretary, Indian Society of Organ Transplantation, Member of Apex Technical Committee, NOTO, Member WHO Task Force Transplantation, Associate Editor, Indian Journal of Transplantation, who has publications of about 230, including 66 on COVID-19. Sir, we request you to chair the session and introduce the speakers. Thank you, sir.
Thank you, WIN team, for arranging this important session on donation after cardiac death, whether this can abolish waiting list in India. My co-chair is Dr. Ashish Sharma and Dr. P.N. Jikki, and we have two eminent speakers today to talk on DCD donation in India. For pros, Dr. Shruti Tapiwala, and for cons, we have Dr. Nivedita Kamath. So I request Dr. Shruti Tapiwala to start his viewpoint on disease donor organ transplant after circulatory death in India. Over to Dr. Shruti.
Are we playing the video or I have to talk? I was told that the video is going to.
Your slides are visible, but we can't hear you.
Living organ transplantations in the case of kidneys and livers have taken precedence in our country over deceased organ donation, which is not the case in countries abroad. So let us see why this is happening, what we can do, and how we can abolish the never-ending waiting list. So the WHO has estimated that there is approximately 1,47,000 organ transplants performed annually, which meets just 10% of the identified global need. This is a global need, not even India. Studies of global burden of disease reveal that this need is probably several-fold greater based on the toll of disability and of premature loss of life that could be prevented by organ transplantation. Even in countries with robust transplant programs like us, thousands of patients die or endure a poor quality of life while waiting for an organ. This shortage is also a proximate cause of organ trafficking and transplant tourism practices that violate the fundamental human values and pose a risk to individuals and public health. As noted by the WHO and the TTS and other stakeholders such as the International Society for Organ Donation and Procurement, expanding the deceased organ donation pool increases an opportunity to help patients in need by donating organs after death, when this is consistent with their intention and value. While in some countries, the number of organs from deceased donors far exceeds the number contributed by living donors. As of 2018, 10 WHO member states of more than 80 with transplantation services still have solely relied on living donors in their liver and kidney transplants, which is a big burden or an emotional burden on a patient. In countries where deceased organ donation is practiced, most of the cases involve donation after neurological determination of death, that is, donation after brain death by physicians who are caring for the donors. This is the predominant type of organ donation which happens after death. So what is the transplant activity in India? So if you look till 2019, we have seen that there has been an absolute increase in the organ donation activity and the rate per million population has gone up. But it is not still enough to reach all the people who are suffering from organ failure. That was of the country. I'm from Mumbai. I can tell you from Mumbai what has happened. 1997 to 2022 July, that is the recent most statistics, we have had 176 heart transplants, 949 kidney transplants, 439 liver, 34 lungs. There are a few bowels, there are 5 hand transplants in this, but these are all only deceased organ transplant data. So you see what dismal values we have from spanning from 1997 to 2022. So this is so dismal that we are hardly reaching any percentage of the population who is suffering from end-stage organ disease. And what is the waiting list? So I'm giving you the ZTCC numbers. The NOTO list is a different list, but this is the ZTCC, that is the Zonal Transplant Coordination Committee Mumbai numbers from 1997 till July 2022, that we had total 11,000 patients registered for kidney, out of which 3,000 patients are currently on the wait list and only 951 people have got transplanted. So imagine so many others have been lost in transit. They have lost their lives because they did not get organ transplantation. Similarly, you see the 4,500 which were registered for liver, 383 are currently on the list and 440 out of the 4,500 have gotten transplanted. Heart, out of 401 which are listed, 44 are currently on the list and only 179 transplanted. Pancreas, very small numbers. Hand, bowel, these are small numbers registered because the awareness that these transplants can be done is rising now. But you look at the kidney and the liver, majority of the people who were on the list did not get kidneys and they have passed away. So why India needs more organ donors? 4 lakh people die every year waiting for a transplant, and transplant has now become a norm. It is now a modern science which can reach common man, and if we cannot deliver organs, it is even more bigger a problem. So what is the progress in organ donation in our country? In India, the process of donation after brain death or a neurological determination death is well established with maximum number in 2019, but the donation rate still remains below 1 per million population, which we are nowhere in comparison to countries like Spain and Holland. Organ donation after cardiac death or circulatory death more recently has been called as a donation, which has successfully expanded the donor pool in many countries, accounting for 20 to 50% of deceased donors. In India, where the concept of circulatory death is universally understood, DCD, that is donation after cardiac death, may be an acceptable pathway to increase organ donation. And the Toha Act 1994 does define a deceased person as one in whom permanent disappearance of all evidence of life occurs by reason of brainstem death or in a cardiopulmonary sense at any time after live birth has taken place. So our constitution, our law covers donation after cardiac death, but it is not being implemented for various reasons. Brain death can be diagnosed in 30% of patients with devastating brain injury before the heart stops. On the other hand, if the brain death only accounts for 2% of all deaths, while in donation after brain death, organ donation is authorized planned after brain death. In DCD, the donation needs to be authorized when the death is anticipated before the death or after the death, which poses a new ethical, medical, legal, economic, and procedural and logistic challenges. The Maastricht system classifies the donation of cardiac death based on the circumstances, and it has protocolized things for us. So whenever a patient has a devastating brain injury, it may be that the patient may have a cardiopulmonary arrest even before the brain death can be diagnosed or processed, and that can amount to a loss of organ. So a decision for withdrawal from life support systems is derived by a conclusion that further treatment will not enable the patient to survive or will not produce a functional outcome with acceptable quality of life that the patient or the legal surrogate and the treating team regards as beneficial. Although many hospitalized patients die under such circumstances all around the world, the DCD programs have been developed only in a few countries like Australia, Austria, Belgium, Canada, China, Czech Republic, France, Ireland, Italy, the Netherlands, New Zealand, Norway, Spain, Sweden, Switzerland, UK, and the United States. So these are the only few countries who have successfully taken the program ahead because they realize the impact of a person being an anticipated death and can take over to see that it becomes a potential organ donation situation. So donation after cardiac death can be of two kinds. Just briefly, uncontrolled, where a death or a cardiac arrest has happened, an asystole has happened, and then the protocol starts, which is category 1, dead on arrival, 2, unsuccessful resuscitation, 5, unexpected cardiac arrest in a critically ill patient. So these are uncontrolled because these have happened before you even think of organ donation, and you are taking control after the arrest has happened, asystole has happened. Whereas in a controlled situation, you are anticipating that there is going to be a cardiac arrest in a situation where this patient is not going to be able to survive qualitatively due to the illness or a devastating brain injury, which has not yet led to a brain death, but can lead to a cardiac arrest. And these are considered that patients will no longer benefit from any kind of life-sustaining treatment. And these are Maastricht category 3 and 4, which are awaiting cardiac arrest or cardiac arrest in a brainstem dead donor. So this is a potential where you can have a control system in your hand and you can bring it equivalent to even a donation after brain death or a living donor. So these are the situations where you have a devastating brain injury, there is a circulatory arrest, and even before reaching ER, there is a category 1 and 2, and there is organ donation. You are in the ICU and there is a patient where there is the ventilatory or there is a circulatory arrest in front of you, where you know that the situation is dismal and there has been a devastating brain injury or a medical situation which has no hopes of survival, and there is an end of life care and a withdrawal of life support system which is planned. Here, the futility of care is assessed. It meets the criteria. You decide to go ahead with the Maastricht protocol of resuscitation once the cardiac arrest happens, and you do the resuscitative procedures to keep the organs functioning. So that is known as a controlled DCD. So a decision to withdraw the life-sustaining treatment is derived by a conclusion that further treatment is not going to enable us or is not going to be beneficial to the patient. And these are the potential people who can have a controlled DCD organ donation. There are variations worldwide, there are registrations, there are guidelines, procedures, protocol. There's an opt-out consent system coupled with a robust emergency and resuscitation services, because you imagine that when there is a cardiac arrest and if you are contemplating a controlled DCD, you need the intensive care, you need the extracorporeal circuits, you need the perfusion, everything in sync to see that the protocol is taken ahead and the organs are preserved well. So there are various protocols all over the world with a little change here and there, where you have a no-touch period which changes from 5 minutes to 10 minutes. There's a consent system, opt-in, opt-out. There are anti-mortem measures which are allowed, not allowed. But overall, when you have a DCD protocol in place, it does increase the pool of organ donation. And the more the hospital, which is a transplant center, does these DCDs, the more the organ donations occur. So DCDs have been increasing worldwide as seen in the European and the non-European countries. In the European countries, more than when you see in the non-European countries. So if you see, Spain is the highest, Spain followed by United Kingdoms, followed by France, Portugal, Belgium, Czech Republic, Netherlands, Austria, Sweden, Switzerland, Ireland. In the non-European countries, you have USA, China, Canada, Australia, Japan. So these are the countries who have successfully adopted the DCD protocols and are carrying it forward with a successful outcome, which I will show you later. Now, this is a UK statistics where they have shown trends of deceased kidney donation in UK over 13 years. And if you see the graph A, you are seeing annual number of deceased kidney donors in UK in 13 years, highlighting the progressive increase of donation after cardiac death, which is the red bar, and donation after brain death remaining in a similar bar. So that means DBD is not reducing, but DCD is increasing your donor pool. And maybe people don't have to look forward to living organ donation, and they can be waitlisted and given organs faster. Similarly, if you see the age group, more than 60 years, 40 to 59 years, 18 to 39 years, less than 18 years. All age groups are contributing to the disease, to the donation after cardiac death. And if you see the last part, the proportion of deceased organ donors, donation after brain death, cardiac death that fulfill the criteria of extended criteria donors have been consistently increasing, because if you go to see, I will outline later that there are a few controversial issues or maybe medical technical issues which we have to handle when we are handling a donation after cardiac death. So what are the worries? DCD transplantations program, there is sometimes a reluctance on the clinician's part to accept donation after cardiac death kidneys, because there is a continuing concern that the outcomes may be poorer than when there is a donation after brain death. Moreover, many clinicians are uncertain about the selection criteria from kidneys from DCD donors, particularly when the donors are old or have multiple comorbidities and when the kidney ischemia times are prolonged. So the conversion rates from potential DCD donors varies from 40 to 80% compared to the controlled DCD. Uncontrolled DCD is more labor intensive and has a lower conversion rate and a higher discard rate, because clinicians are not sure if the quality of the kidneys is good. The super rapid laparotomy technique involving direct aortic cannulation is preferred in many centers over in situ perfusion in controlled DCD donation and is associated with lower discard rates, shorter warm ischemia times, and higher graft survival rates. DCT kidneys have shown a 5.73 increase in the incidence of delayed graft function and a higher primary non-function rate compared to donation after brain death in kidneys, but the long-term graft function has been equivalent between the two categories. The cold ischemia time is a controllable factor that significantly influences the outcome of allograft, for example, limiting it to less than 12 hours, markedly reducing the delayed graft function. DCD kidneys from donors less than 50 years function like standard criteria kidneys and should be viewed as such. So what are the technical considerations in short? So in situ perfusion versus a super rapid laparotomy, both of these have been shown beneficial effect, but a laparotomy, a super rapid laparotomy is shown to be beneficial to decrease the WIT and the CIT, and it is associated with lower discard rates. So you might be beneficial if you want to set up a system where once you anticipate a DCD, you have your team ready for an urgent laparotomy and aortic perfusion to start. Extracorporeal support, ECMO has shown to be of a greater advantage when you use in the DCD circumstances, and we have done it practically at Global Hospital in 2 patients, and we have been successful in a DCD with ECMO care. And the organs are well preserved with this and has to be inserted in time. Chest compressions. Now, what happens is when there is a cardiorespiratory arrest and you have a no-touch time of 5 to 10 minutes, post the 4 to 5 to 10 minutes, it is noted that if you continue the CPR, to continue the circulation, it gives a better outcome. Now, these are the unadjusted death-censored graft survival, and if you see in all the grafts, donation after brain death, donation after cardiac death, the percentage of graft survival remains similar. percentage of graft survival when you look at the cold ischemia time. When you have the CIT less than 12 hours, it is the best. More than 24 hours of CIT, it is the most inferior. But still, if you see, the survival is good. When you look at donor age group, more than 60 years of donor age becomes an extended criteria donor, and the allograft survival is slightly inferior to when you have a young donor, which is intuitive even in the case of brain death, donation after brain death. If you have a DBD SCD or a DBD ECD, the DBD ECD and the DCD ECD remain in a similar line, and the donation after brain death standard criteria, donation after cardiac death standard criteria remain superior. So if you see that if the technique used is good, if the protocol used in the controlled setting is optimal, you get an optimal allograft survival, which is what is the need of the hour and which is what is the worry from the DCD point of view. So when you compare the transplant outcomes from DCD to DBD, there is no inferiority. Again, the percentage of graft survival in transplant era, as the transplant era has improved, the medications have improved, the techniques have improved, the infrastructure has improved, we are getting more and more successful rates. So the conclusions of the UK study were that the use of kidneys from controlled DCD donors has markedly increased the number of transplants performed in United Kingdom and has helped reduce the number of patients on the waiting list. DCD kidneys have a higher incidence of DGF and a long CIT, which is more detrimental than the DBD. However, over longer time, there has been no difference in the survival rates. Importantly, the renal function at 5 years and 10 years are similar. Contrary to the expectation of many clinicians, the transplant outcome from kidneys from older and ECD, DCD donors is no less favorable than older ECD, DBD donors. The decision regarding selection of donors from kidneys from older donors and donors with major cardiovascular disease and other comorbidities still remains challenging, so selection remains a criteria which every center has to build. Available incidents suggest that we should encourage donation after cardiac death. Now, these are the comparisons in various countries, and it is showing everywhere you see there is equivalent or similar comparative graft survival. So we are in a situation where DCD can be successfully implemented. How practical, how doable? So now in most of the countries, the organ donation rate has increased because of the implementation of the DCD programs. In USA, Spain, Australia, Croatia, well-developed DCD programs with 2.1 to 3.8 DCD per million population has been achieved. So many countries who do not have DCD donors or a DCD program will benefit because it will increase the organ donation rate many-fold. That was a world statistics where it has increased. Now, what about India? In India, 2 or 3 centers have attempted to do it. One is IKDRC, where they have found good results, acceptable delayed graft function, and comparable results with donation after brain death. You have a single center study from Dr. Mins, which also is looking at DCD donors, but it was again a controlled situation, and they have used laparotomy, urgent laparotomy versus in situ perfusion, and they have concluded that continuing CPR after declaration of death seems to be helping the outcomes, but DCD is a definite do for our country. Then if you see the PGI, Chandigarh has also published the initial experience of 9 kidney transplants where the recovery was early in the grafts where donors underwent a CPR. So you follow the message protocol, no touch technique, and then you go ahead with the organ donation with a CPR continuing. And what is that poor program reason in our country? It is because these situations are very rarely identified. Patients go Dama or Lama where death is impending and nothing can be done. We have to have sensitized teams and infrastructure which is already there to be sensitized and put in place so that no anticipated death, irreversible situation is left alone. To conclude, DCD kidneys provide a valuable and increasingly important source of kidneys for transplantation. Implementing organ recovery from emergency department, setting up the process is important. Improving family consent is important. Use of technology, which is available. I would like to thank Good afternoon, everyone.
Thank you, Dr. Shruti, for your excellent presentation on DCD donation. Is there any question from the panel or audience?
Dr. Vivek, I think we'll have the questions later. This
Okay,
being
madam.
a debate, we will let Dr. Nivedita, put
Okay, madam. I
counterpoint.
request Dr. Nivedita Kamath, madam, to have her viewpoints on the DCD donation.
Thank you, sir, for the opportunity. Will you be playing the video, please? Good afternoon. I'm Dr. Nivedita Kamath, and I'm speaking against the motion, deceased donation after cardiac death will abolish the waiting list in the Indian scenario. After listening to my worthy opponent talk, I was wondering if the topic had been changed to, does donation after circulatory determination of death expand the donor pool? The answer to that, as you and I agree, is a resounding yes. The question, however, is not if DCDD will increase the donor pool, but will it abolish the waiting list in India? And thank you. No, I'm not concluding the debate and conceding defeat at this point. What I'm trying to say is that I'm very thankful to the organizers and the audience for giving me this opportunity to put things into perspective and in context, because I believe that context, not text, not data, not graphs, is everything. For example, if someone asks you how many people does it take to change a light bulb, you may say 1 or 5, but the actual answer is it depends on the context. And even in the case of deceased donation after circulatory death, we need to put things into the context before we jump to the conclusion that it will abolish the waiting list in India. If a picture is worth 1,000 words, then context is certainly worth 1,000,000. We also need to look and scrutinize at some of the data, the numbers, and read the fine print, read in between the lines before we jump to conclusions. The newspaper headlines said in 2019, India had 12,666 transplants, second only to the United States and China. Wow. So what? Are we being the uncrowned prince of the transplant world, the transplant capital of the world? No, we are far from that. We are, in fact, becoming the non-communicable disease capital of the world. Unfortunately, our prevalence of diabetes and hypertension is on the rise, and we are going fast to be the winners of a race we don't want to win. In the absence of robust registries, we don't have excellent data on the trends of kidney failure, but the estimate prevalence is about 129 per million population, which accounts to about 175,000. And of these, 12,000 odd patients have been transplanted in 2019, coming to a dismal 7%. Not only is the prevalence high, but also it accounts for a large number of deaths and reduced quality of life. And this is shown by several studies. Let's look at the real picture from the GODT data. Where is our country number 3, India? Oh, there it is, way down on the list. Because when we remove the denominator and equalize it per million population, we find that our rates of transplant are less than 10 per million population, and deceased donation accounts for only 0.3 per million population. As compared to country number 1, the United States, which has 10 times more than 100 per million population transplants with 20 deceased donation per million population. China also suffers from the same problem that we have, but has a more robust deceased donor program. If we look at the deceased donor program list itself across countries across the world, we see that India comes way down on the list. This graph also shows us data on the DCDD programs, and you can see that though DCDD is prevalent in several countries, they are all present in countries that have a very strong, large deceased donation program. And even in those countries, it accounts for less than 30% of deceased donors. Let's come back to our own data. And this is a very heartening graph in one way, because the good news is that our transplantation rates have doubled in the last decade. But the bad news is that deceased donation is still going at a snail's pace. In 2019, where we were the third highest number of transplants across the world, we had only 875 deceased donors, accounting for less than 1 per million population and accounted for only 7% of all donations. So if Vetal was to ask King Vikramaditya, this is the dilemma, the scenario in India of kidney failure and the prevalence of live-related and deceased donor. Where would you think your time, energy, and money should be invested? Speak now, or your head will burst into 1,000 pieces if you know the correct answer. And I think we all know the correct answer. The correct answer is that we have a huge number of we have a huge demand for kidney failure to be transplanted, and we have a very small living and deceased donor program. Our focus should be on our transplant program as a whole, focusing both on the living donations as well as the deceased donation. Of course, since our topic for today is DCDD and our deceased donor program has a huge potential, I'd like to focus on that for now. It's time we look at the bigger picture. Again, coming back to the status of transplants, in the last few years, our total transplant rates have definitely gone up, almost doubled. So has our deceased donor program, but it is far from what its potential is and what the need is. There is still a huge demand-supply imbalance. But is this only in our country? What is the scenario worldwide? This is a very representative graph of what is happening world over. And you can see that in the global north, the so-called developed world, deceased donation accounts for a major proportion of their donor program. Whereas in the global south or the developing world, we still rely heavily on live-related donors. So the question today is DCDD the new panacea, the lakh dukon ki ek dawai? Is it going to solve everything? Is it going to miraculously abolish our waiting list? I don't think so at all. Even in countries that have a robust deceased donor program and a DCDD program going on for several years, only about 9,000 DCD donors have been recorded in 2019 of all these countries combined, and they account for about 20 to 25% of deceased donors, saying that even in countries with the maximum number of resources, with a good established deceased donor program, DCDD is difficult to conduct. In Europe, which has been having a robust DCDD program, and this has been told by our previous speaker, there is still many countries that don't have a national legislation that is legally binding. Some important aspects like the no-touch period have not defined uniformly across countries. Who qualifies for DCDD is also different in different countries. Of course, all countries include devastating brain injuries, but then there are different other disorders that are included in different countries, including euthanasia. But this is probably the most important table that I'd like to draw your attention to. If you look at the overall utilization rate, DCD looks comparable to DBD. But if you look at the number of organs recovered and transplanted per donor, it's definitely shows us that DCD is inferior to DBD, and uncontrolled DCD is almost 50% of DBD, saying that we are not only wasting organs, but also donors with a DCD program. The number of the percentage of kidney transplanted look comparable, but that's not true with the livers and also with the heart, which does not exist in this data sheet. If you compare controlled and uncontrolled DCD, there's definitely data to say that uncontrolled DCD has inferior results. A comparison of transplant outcomes from the United Kingdom comparing DCD and DBD showed that other than DGF, all the other things were comparable, including the 1-year, 5-year, and 10-year survivals. But if you look at the actual graphs, you know that the numbers after 5 years of transplant are fewer. And hence, probably it's too early to commit to that statement that the long-term outcomes are comparable between DCD and DBD. Even in countries, this is a study that shows the temporal trends of the quality of deceased donors, and it was found that the kidney donor risk index, which is an important aspect that predicts the long-term outcomes, was higher in countries that had a DCD program as compared to those that did not. So though the short-term outcomes are not significantly affected, the long-term outcomes are not known. A systematic review and meta-analysis showed that definitely, though we don't know about the long-term outcomes, definitely the short-term outcomes are also at risk, because there is a very high risk of DGF, of primary non-function, and overall graft loss in DCD versus DBD donors. Another meta-analysis and systematic review also supported this, which said that graft loss at 1 year, death-censored loss at 1 year, risk of primary non-function, and delayed graft function were all against DCD and highly in favor of DBD. This is an interesting study that showed that by introducing a DCD program, the number of DBDs also increased. But what is important to know is that the organ yield, mean per donor, actually decreased, not only overall, but also in the DCD program. The DBD program. This increase in the DBD donations may have happened, but the number of organs retrieved per donor were definitely lower. And it's not known as to what the quality of these organs were and what the long-term outcomes were. Now let's take a step back from the kidney and look at other organs, because we want to use the donors to the maximum potential for donation. So donation after cardiac death was the most important risk factor for non-use of organs, with an odd ratio of 25 among liver donors. So our hepatology friends are not going to be happy with the DCD program. Often a reason cited is that it is easy to make the public understand, and it's donation after cardiac death is more accepted because the concept of death is easily understood as opposed to DBD. But this study that is done in the West, of course, showed that there was no significant difference, and the reasons for not authorizing donation were similar. They found a difference in DCD versus DBD in that the DCD families that were approached for a DCD donor felt that they had been through enough, suggesting that fatigue and emotional weariness were important aspects, and the procurement process took too long. Fortunately, in the West, mistrust of the health system and feeling dissatisfied with the hospital were very low on the list of reasons for not donating, but we don't think that would be a scenario in our country. Also, deceased donor programs have been very robust in countries that have either an opt-in or an opt-out program for a donation program. For now, there is no data to say which one is better, but there's definitely a trend to say that the DCD programs are higher in countries that have an opt-out. In India, of course, we have neither an opt-in nor an opt-out, and this is certainly one thing that we should think of as a method to increase our deceased donation. When it comes to time and resources, we know that DCD would take more time and is more resource intense than a DBD program. The economics also say that these are the things that were significantly higher in DCD: the number of post-operative dialysis sessions, post-operative stay, and the number of readmissions in the first year, accounting for almost 1,200 pounds increase in the transplant costs. An interesting study on the beliefs of intensive care professionals and organ donor coordinators as to what were the barriers and enablers for DCDD found that the lack of education among healthcare professionals, lack of standard screening processes, lack of practices for communication with families, multiple physicians with ambiguous roles, and lack of resources were important barriers. And if we to put this into the context of our country, definitely all these barriers are highly prevalent. The enablers, the personal and public opinion about donation, and the presence of resources, both of which we don't have favoring us in this context. So advertising for DCDD as the new panacea, as the solution to our long waiting list, is like advertising for Coca-Cola to solve the waiting list of these pots and pans for potable water. So what is the way forward? The way forward is to strengthen our donation programs. The live donation, of course, but mainly the disease donation, because there is a huge potential. Without a strong foundation of a disease donor program, going into DCD is like expecting a toddler to understand trigonometry. What then ails the disease donor program in our country? This is an excellent graph that shows us that the disease donor program has been initiated and expanded in southern and western parts of the country, but in the rest of the country, it's still in an infant stage. Is it because of a lack of donors? I don't think that's true, because if you look at the data worldwide, every 23 seconds, unfortunately, one person dies on the road worldwide. And what is the scenario in India? We may not be the transplant capital of the world, but we certainly are #1 in the world on road traffic accident deaths. It is very unfortunate that we have 226 deaths per million population. And if you remember, we said we have 129 kidney failures per million population. Most of these most of these accident victims are in the younger age group, and 50%, in some states, it is up to 70% of these deaths are brain deaths. Even if a 50% of these brain deaths could be potential donors, our problem of the demand-supply imbalance would be solved. We have two unfortunate scenarios, two tragedies of very high prevalence of kidney failure and unfortunate very high prevalence of road traffic accident, which of course we need to make our roads safer for our youth and our people. But in the current scenario, can we put these two tragedies together to have a triumph story? To enhance disease donation, we need other things: policy, perceptions, and practice. The policies need a better definition of brain death in the form of a robust national protocol that can be used across the country. Brain death should be identified as a cause of death in the birth and death registry. Currently, the donor pledge does not have a legal status, and this, I think, is a huge priority. Withdrawal of life support guidelines are also a must before we go into niche areas like DCDD. Of course, large steps have been taken, important steps have been taken in the last couple of years with the ICMR guidelines, the ruling from the Supreme Court, which declared the right to die with dignity as a fundamental right. Withdrawal from life-saving devices can be asked by an adult human with competent mental faculty, and you can also execute an advanced medical directive. The guidelines for end-of-life care also have been published, and these are important steps in the direction of enhancing disease donation. Working next on the perceptions of the public as well as the medical fraternity. This is a combination of data from different studies which showed that a large percentage of the lay public did not understand what brainstem death meant. They were willing to donate, but very few registered. 90% felt that they needed to have trust in the healthcare system. So building up on that, especially in today's world, is very important. Lack of awareness, religious beliefs contributed to a huge number. Fear of disfigurement, procedural delay, inappropriate counseling, non-acceptance of brain death, family decisions, dissatisfaction with the hospital were important reasons. And you can see that by having the only way to get rid of this is by creating awareness. So handling perceptions of the public about doctors and the medical treatment or hospitals, and educating them so that they can take an informed decision whether to donate or not to donate is the way forward. Education, education, education. Involve healthcare workers, volunteers, social media, leaders of all religions, key opinion leaders, create awareness programs, voluntary donation campaigns targeting the youth. Linking donation to the driver's license, which is mandatory in many countries, can be easily implemented in our country so that you can opt for organ donation at the time of creating or renewing your driver's license, and of course, non-financial incentives. Perceptions of the medical fraternity, medical and paramedical. So 80% of the nurses in a study were found to be aware. And if they had taken care of a brain death patient, they found that it influenced their decision to donate. Only about a third or 2/3 of the students were aware of organ donation, which says that probably organ donation should be included in the curriculum right from the beginning in the undergraduate days. Though this study was not related to transplant, breaking bad news and death declaration by healthcare personnel was found to be suboptimal. And doctors felt that they had no formal training in communication skills, which led to emotional stress in this scenario of breaking bad news and death declaration. So awareness, attitude, and communication skills are important for the medical fraternity. Coming to our practices, like we have a baby-friendly hospital initiative for promoting breastfeeding in children, why can't we have a transplant-friendly hospital initiative? Because after all, transplantation is a huge team effort. So educating all doctors, nurses, and paramedics and students that work in a hospital, having a mandatory grief counselor in every ICU, delinking the decision on brain death and withdrawal of life support from transplantation. And this is one important aspect that we probably need to focus on as a priority. Having facilities to take care of potential deceased donor, because across several ICUs, which are very resource constrained, they feel that allotting beds to a brain dead patient is not ethical when you have several potentially salvageable patients waiting in your emergency. So can we earmark a few beds, at least in public sector hospitals, to take care of potential deceased donors? Transplantation must expand to public sector hospitals for it to be accessible to the general public. We need nationwide registries and green corridors. So has DCD never been done in India? No, absolutely not. We have 2 publications of a series of DCD that have been done in 2 premier institutes of the country, and we have found that they have good results. This is an important step forward of organ donation after circulatory determination of death, a joint position paper put in together by a big team of doctors from various specialties and aptly published in the Indian Journal of Critical Care Medicine this year, which gives us the step forward. But before we jump into a niche area like DCD, we need to enhance our deceased donor program and build strategies to enhance our living donor program as well. Until then, DCD will have to wait in the wings for its time to come, and it is not the panacea for our woes. Thank you.
Dr. Shruti, your comments.
So, Dr. Nivedita, that was a good awareness program on organ donation, but DCD is organ donation after death. And I would just put it across that if I am a patient, I do not want to ask a living donor to donate. I want to get an organ with a deceased donor because it is emotionally straining for a patient to keep asking for organs. If we are strong on our deceased donor organ donation program, be it donation after brain death, be it after cardiac death, we will not have people wanting to ask for living organs. Donation after cardiac death, if done protocolized, if implemented, if it can be done in IKDRC, why it cannot be done in a tertiary care institute of our country? It can be done. We have implemented it at Global Hospital. I can see that it helps. It is just a matter of sensitization. It's just a matter of awareness. The outcomes are good. People die on dialysis. The survival rate on dialysis is dismal. Dialysis adds to the burden in the country. Liver patients die waiting for livers. And the era which was showing where livers and hearts are thrown away and discarded was till 2014. If you see the recent literature, the organs are now well preserved. See, a super urgent laparotomy is the best way and the cheapest way to just get into the system and start perfusing. So if we want, we can add organs to our deceased organ pool, and which is an important HLA incompatible transplant, very costly. ABO incompatible transplant, very costly for our country. Deceased organ donation, yes, it is the way to go. And I will only close to any organ available. We should see to it that we use it. And we cannot say that DCD is very far away. It's not in the wings. It is with us in our hands. We are not using it. I would just close the comment.
Yes, Dr. Nivedita, do you want to add on something?
No, I'd like to thank Dr. Shruti for telling whatever I wanted to say. And that's exactly what I wanted to say, that we need a strong deceased donor program.
But DCD cannot be thrown away. It has to be added to the pool. We cannot say that The moment we say, no, it cannot be done, we are not economically down. If SGPGI and IKDRC can do it, why cannot a global hospital or a Yashoda hospital or a Nizam's Institute do it, or a AIMS do it? It can be done. It is a willingness to be done. Willingness is not there because everyone feels it is not legal, it is not. No, everything is there in the TOHA Act. We are not implementing it. If we talk to the family, if we sensitize the emergency department, we sensitize the intensive care team, our job is done. And which is what we have seen, that the moment you have a death on arrival, and if it's a recent arrest and you start resuscitation, it helps. But if you have a controlled situation, that is the thing which is missed most of the times. So if you see one of the slides which I had presented, brain death can be diagnosed in 30%, but cardiac arrest happens before that. Brain death can be converted only in 2% of patients. So a DCD, a controlled DCD, can be done in so many patients who are actually admitted in our ICU, and they go unnoticed, they go unidentified, and we are losing on this. So we can never say that, oh, we will look at it later. No, we have to take DCD and DBD along and work.
Yes, there are challenges for both DCD transplant and DBD transplant. So we need a dedicated team efforts to expand deceased donor organ transplant in India. Fortunately, India is number 3 in the world for absolute transplant numbers. But in terms of deceased donation, India come in the last 10 numbers. So we should have a dedicated team to expand both DCD and DBD. Our center, that is Kidney Institute Ahmedabad, has published data of around 35 DCD transplants, and Dr. Ashish Sharma from PGI Chandigarh has also published data from the DCD donation, around 9 DCD donations. So if the DCD are performed in these 2 public sector hospitals, obviously with dedicated team work, it should be performed in other public as well as private sector hospital, because 80% of the transplant services in India, they are in private sector hospital. And this disparity is higher for organs like heart, lung, pancreas, and heart transplants, where 95% transplant services are in the private sector hospital. So we should, all transplant professionals, all members of transplant related society, they should overcome the challenges, and we can easily expand the deceased donor organ transplant from DBD and DCD as well in the coming year, so that the family member need not to come forward to donate organ to save the life of their loved one. Is there any other comments from the panelists or audience? As Dr. Nivedita Madam has pointed out, the Indian Society of Organ Transplant, along with other transplant related society, has formulated the consensus statement on the DCD donation. As on today, more than 99% deceased donor organ transplant are from DBD donation. But if we see the Spanish data and USA data and Croatia data, 20 to 50% of the deceased donor organ, they came from the DCD donation. For example, the road traffic accidents are very common in India, and they always happen in the young population. So since we can get more organ donation rate if we try dedicated efforts. At present, the disease donation rate in India is less than 1 per million population, and estimated need of kidney transplant is more than 1,75,000. Estimated need for heart, lung, pancreas, liver is around 50,000 per organ. So to achieve the self-sufficiency, in organ donation and transplantation, we need 124 deceased donation per million population. So we need a huge efforts, combined efforts from public and private sector hospital, combined efforts from all transplant professionals, all transplant societies to expand the disease donation in India. Recently, 2 years back, we started training of the ICU doctor, neurology, neurophysician in the trauma center at Civil Hospital, Ahmedabad. And in a short span of 2 years, there is a 84 organ donors and more than 200 organ transplants from single civil hospital Ahmedabad. So I think such model can be replicated in the all public and private sector hospital so that we can expand our deceased donor organ transplantation. I will also hope that the transplant facility should be available in all medical colleges, in all the public sector hospital, so that the various government schemes can be utilized for the transplantation for the poor patients, because many times the government schemes are not applicable in the private sector. So we should do a dedicated efforts to expand our deceased donor organ transplant. Any other comments from the audience or panelists?
Dr. Urmila has something to say.
Yep. I mean, from Vivek and people who have done DCD, most of our donations are from cardiac death. And cardiac death in a hospital is actually not from the neuro ICU. It is from ICUs where you have septic patients and patients who are in the CCUs. So I would like to know, have you ever audited the kind of donors that you are getting for DCD? And besides kidneys, how suitable are these organs like heart and lung or liver in such a situation? The DCD organ quality and the DCD organ source is important. What Shruti says is very important. We sort of declare brain death, but then before the organ retrieval happens, we have a cardiac death. There, the situation is easy. The patient has already agreed for a DBD. So it's easy to get a DCD out of that DBD. But what about DCD from other ICUs? What is your experience, Vivek, on this?
Madam, we have performed only controlled DCD, and when patient is in our ICU. And
Which ICUs?
Our transplant hospital ICU. And if, for example, many times the first apnea is done and before the second apnea, the patient collapsed. At that time, we have retrieved the organ for the DCD donation. That is one of the common scenario.
Yeah, I think that is the scenario which we should all work on. And it's easy. Anyway, the DBD has been consented for. So why should
there are a lot of population. So 30% of brain dead individuals, only 2 to 3% conversion happens because of the cardiac arrest happening before we can even proceed with the second apnea test. So I would think, and we have done this at Global Hospital, I have done it at Hinduja also before, that, you know, when we know there's an imminent cardiac arrest, we know that there's a large IC bleed, nothing can be done about it. We try to counsel the patient's relatives earlier in time that if you have a cardiac arrest, would you like us to go ahead with this perfusion? And we have the perfusionists, we have everything ready, even say 4 or 5 hours before that imminent arrest happens, that we know anytime anything can happen. And we are all ready with everything in hand. I mean, that sensitization is what is important. And like Dr. Vivek says, that if IKDRC can have a good model, and I would congratulate him, because I'm working at Global with a multi-organ transplant, pancreas, hands, bowels. Last few of these organs have come from IKDRC, because the nearest Roto Soto is Mumbai. And Global is listing hands, pancreas, and there is so much awareness on organ donation that almost all potentials are being converted. So I think it's the level of sensitization of the team which is important, the enthusiasm of the team that yes, we can do it. And we will land up abolishing the list, adding DBD and DCD together. Yes. Vivek, what do you say?
Yeah, when the brain dead declaration is not happening and relatives are willing for organ donation, in that scenario, the DCD is commonly used, and most importantly, a dedicated, passionate teamwork is required, because we have to respond very fast in case of DCD donation.
Ma'am, I'd just like to add one point at this state. That is, in most countries in Europe, especially, which have huge DCD programs, the common base for accepting DCD is devastating brain injury. That need not be just road traffic accidents, but it could be stroke or anything else that do not qualify for brain death. So even among road traffic accident victims where they have brain injury that is not reversible and is subsequently going to lead to death, but do not qualify for brain stem death, these are also a potential that has to be explored. So that's why I brought that point of saying that we have so many road traffic accidents, which is so unfortunate. But for so many years, we have not been able to utilize it to do something good. Neither have we improved road safety because our numbers are worsening every year, nor have we made use of the people who are unfortunately dying on the roads to save some other lives. So that, I think, is what is there, about the huge potential is about.
Thank you. Thank you so much, Dr. Vivek, Dr. Shruti, and Dr. Nivedita. It has been a great discussion, an amazing discussion. And you have put the discussion fire and opened the Pandora. Since we are little to be on the schedule on time, so I request the chairperson, Dr. Vivek Kutte, to close this session so that we move to the next program. Over to Dr. Vivek. Please close the session.
Thank you. And I will just conclude that there are challenges for both DCD and DBD transplant, but with dedicated teamwork, we should overcome all the challenges to increase access to transplantation. Thank you, speakers, chairpersons, and audience. Over to organizers.
Thank you, esteemed speakers and chairpersons. After an excellent debate session, we now move on to the next discussion. It's a panel discussion on the topic, making inherited tubulopathies easy. So we have Dr. Priya Pais as the moderator, and we have in our panel, Dr. Pragna Ranganath, Dr. Nivedita Girmaji, and Dr. Alpana. We request Dr. Sanjeev Gulati, Dr. Mehul Shah, and Dr. Hitaishi to chair the session. The CVs, please, on the screen. Dr. Sanjeev Gulati, who doesn't need any introduction. He is the President-elect of Indian Society of Nephrology, ex-Vice President ISOT, and Chairman Nephrology and Kidney Transplant Fortis, Delhi. He has around more than 150 publications. He has received various awards, ICMR Award for Research in Nephrology, Kuller Oration Award by ISN. And next we have Dr. Mehul Shah, consultant pediatric nephrologist from Hyderabad. Sir has done his fellowship in pediatric nephrology from Texas, USA. He is American board certified in pediatrics and pediatric nephrology. He has authored several articles in national and international journals, and he has special interest in renal tubular disorders. So we'll be looking forward for his presence. And Dr. Hitaishi, she's a consultant nephrologist from Mansa Kidney Center, Tirupati. So I invite on behalf of Win India, all three esteemed chairpersons to start the session. Over to the chairpersons.
Yeah, thank you. And good afternoon, everyone. At the onset, I'd like to thank the organizers of this WIN session. And also congratulate them for a very excellent scientific program. Tubulopathies, as you all know, I think is one of the toughest. These patients are very uncommon. Quite often they are missed, underdiagnosed. I'm eagerly looking forward to learning from these team panelists as to how to simplify our approach. Mehul is there, I think, at the venue. So Mehul, you can take over and get it going. Thanks once again. Yeah.
Right. Yeah. I need to Thank you, Sanjeev, and good afternoon to seniors as well as friends. Again, as Sanjeev mentioned, it's a great privilege to be a part of the maiden annual conference of women in nephrology. We have some interesting discussions on inherited renal tubular disorder cases. I would like to first invite Dr. Priya Pais, who's going to be the moderator for the session, and my co-chairperson, Dr. Hitashi from Tirupati. Dr. Priya Pais is an associate professor of nephrology in St. John's Medical College Hospital in Bangalore. She has special interests in hypertension and ethical issues in nephrology. She's done research interests. She has had some research in ambulatory hypertension, CKD outcomes, and health economics. And she's a member of multiple societies. I would like to invite Dr. Priya Pais as the moderator for the session. The three panelists whom we have today are Dr. Pragnya Rangnath. I think she has already been introduced and she had a wonderful lecture this morning. She's an additional professor and head Department of Medical Genetics in NIMS, Hyderabad over here. Our next speaker, next panelist is Dr. Nivedita Girimaji. She's done her transplant fellowship at University of Chicago in the section of nephrology, and she'll be joining us from Chandigarh. And our third panelist is Dr. Alpana Ori. She's a pediatric nephrologist and in charge of the division of pediatric nephrology at Jayarbai Wadia Children's Hospital in Mumbai. I invite all the three panelists as well as Dr. Priya Pais and hand over to Dr. Priya Pais to initiate the discussion. Dr. Priya Pais, please.
Thank you very much, sir. Am I audible to everybody? If I can ask our panel to
Yes, ma'am. Yes, ma'am. Very much audible.
Okay. Yeah. Okay, great. So thank you very much on behalf of all of us. I would start with for inviting us to have this panel discussion. I don't know how easy we can make inherited tubulopathies, but we look forward to trying. And thank you very much, esteemed chairpersons, for your introductions as well. And we are very happy to have you, especially Sir Dr. Mehul, to join us for this. And
thank you.
Please feel free to share your wisdom with us as well. So I'm going to begin by sharing my slides. Are my slides visible?
Yes, ma'am.
Okay. So before I begin, I'm going to just begin with a very brief introduction to inherited tubulopathies. I'd like to just say that we have a very diverse set of opinions and wisdom to be shared with us this afternoon. Dr. Pragnya, you all know, will share her wisdom about the genetics in tubulopathies. Dr. Alpana Ori is a pediatric nephrologist and has also conducted series of seminars in nephrogenetics. Dr. Nivedita, when I talk, I call her an adult nephrologist, but of course she's a nephrologist trained in PGI, but she's actually joining us from Chicago. It's very, very early in the morning. And she will give us the perspectives from the older age group. And Dr. Jaya is our senior DM resident, and she'll be presenting some cases for you. I'm trying to make. So our learning objectives will be to discuss the clinical relevance of inherited tubulopathies, to discuss the classification and some common clinical features that occur with inherited tubulopathies, to discuss the role of genetic testing. We'd like to put forth a very practical approach to beginning to make the diagnosis. We have some interesting cases for you all, a journey along the tubule. And throughout these cases, we'll be taking breaks, having a question and answer session with the panel, and presenting both pediatric and adult perspectives. And we'd like to conclude saying how important it is to follow these patients through the childhood age, all the way through adulthood and beyond. So I'm sure everyone is familiar with the importance of homeostasis or maintaining the internal milieu as has been put forward, the homeostasis refers to fluids, electrolytes, and acid base, and it's imperative for life itself. The primacy is in maintaining volume status, and therefore the most important really is the role of salt, and along with salt reabsorption, water is reabsorbed. And so the tubule is really set up to reabsorb as much salt as it can, and it uses different mechanisms all along the nephron, which I'll briefly show you. It also fine-tunes the reabsorption and secretion of various other electrolytes and anions and cations along the way. And so briefly, an inherited tubulopathy is a dysfunction of the kidney tubules caused by defects in reabsorption due to a genetic abnormality. There are very many inherited tubulopathies. We will briefly be touching on just a few, mainly to do with salt wasting. Okay, so I'm sure everyone here is very familiar with the parts of the tubule. This slide is just to remind everyone that the mechanisms of absorption along the various parts of the tubule are really complex. It involves, for example, in the proximal tubule, the reabsorption of multiple cations, anions, and organic anions, and primarily is involved with reabsorbing bicarbonate through the sodium hydrogen exchanger. As we move downwards to the thick ascending limb, we have an even more complex set of channels. The sodium potassium 2 chloride, the ROMK channel, which recirculates potassium back into the tubule, and a very important mechanism on the basolateral side, the chloride channels that are present in both the thick ascending limb as well as the distal convoluted tubule. The DCT, as you all know, has another sodium chloride co-transporter. The same chloride channels transport the chloride into the blood, and the collecting duct, the alpha intercalated cells, are responsible for acidification of the urine through extrusion of H+ ions that combine with ammonium to form ammonia to form ammonium, and are detectable in the urine as chloride because of ammonium chloride excretion. The other cells, the principal cells, are involved in sodium and water regulation through the ENaC channels. So if we were to look at a very simple classification of inherited tubulopathies, we could classify them by phenotype, or what the patient presents with, the site of the nephron involved, and then much more complex, genetics. So by phenotype, most inherited tubulopathies result in salt wasting, though there are a few that result in salt retention and hypertension as well. So when there is salt wasting, the patient will have polyuria and polydipsia. They could also present with disorders of acid base, so metabolic acidosis with hypo or hyperkalemia, and metabolic alkalosis as well. And a very important other phenotype is hypomagnesemia. So if we look at classification by the site of the tubule, metabolic acidosis could occur due to defects in bicarbonate reabsorption in the proximal tubule. It could occur due to impaired acidification of the urine in the collecting duct. The thick ascending limb is involved in significant reabsorption of chloride, sodium, and potassium. And therefore, when there is chloride wasting, the patient will present with metabolic alkalosis and hypokalemia. And to a lesser extent, abnormalities in the DCT present with metabolic alkalosis and hypokalemia as well, along with hypomagnesemia. So if we have a phenotypic picture with labs and the patient's clinical presentation and some basic imaging, we can form in our minds a mental map as to which part of the tubule may be involved in situations where it is straightforward. However, it's not always quite so straightforward. So this summarizes. I'd like to briefly mention that in the principal cells, the inherited tubulopathy, where there is increased reabsorption of sodium and water due to the activating mutations of the ENaC channels are a separate group where patients present with metabolic alkalosis, some hypokalemia, and importantly, hypertension as well. So if we look at the classification by genetics, in blue, you see the genetic abnormalities involving the proximal tubule. These include, right on top, isolated proximal RTA, which is associated with eye anomalies, and then various causes of the renal Fanconi syndrome, which is a generalized proximal tubulopathy. Cystinosis is an important cause of Fanconi syndrome in children that has lifelong consequences. Low syndrome and dense disease also involve inherited tubulopathies of the proximal tubule. Metabolic acidosis could also occur due to distal RTA, and these are some of the genetic abnormalities that result in a distal RTA. A Barter's phenotype, or hypokalemic metabolic alkalosis, usually with nephrocalcinosis, is due to abnormalities in the genes encoding channels of the thick ascending limb. In the DCT, if there is an anomaly of the sodium chloride co-transporter, Gitelman syndrome results, and there is often a little bit of overlap between Barter's and Gitelman's, and it's important to differentiate between the two. This slide is just to show the complexity of the anion reabsorption and channel mechanisms in the thick ascending limb. And if we look at how the sodium-potassium 2-chloride co-transporter works, it involves not just one transporter, but the NKCC2. It involves recycling of the potassium back into the luminal fluid to the potassium or ROMK channels. It also involves reabsorption of bicarbonate to 2 different chloride channels, which require a subunit called Barton. And it requires adequate expression of the sodium-potassium 2-chloride. And therefore, any problem in these mechanisms could give rise to a Barter's syndrome. However, they are all phenotypically rather similar. So what are the clinical presentations of inherited tubulopathies? They all sound very different, but in fact, clinically, they may present quite similarly. Polyuria and increased thirst is common to all salt-wasting tubulopathies. This occurs due to a concentrating defect of the tubules, especially when there is an osmotic diuresis, loss of electrolytes in the urine. When there is polyuria and dehydration, there is an ADH-driven thirst mechanism that results in polydipsia. Patients who have hypokalemia tend to present with symptoms of muscle weakness. In infants and children, they present with delayed motor milestones, head lag, etc. And they may also present with vomiting. Failure to thrive is a very common pediatric presentation of inherited tubulopathies. This occurs due to several reasons. One is that they're always drinking water because of the polydipsia, and therefore they actually don't seem to have the space to take in adequate calories. They're always full of water. Another important cause is acidosis. Acidosis results in protein catabolism. It results in a resistance to the effect of growth hormone. It also results in rickets or bony abnormalities as well. So why does rickets occur? Rickets occurs because bone hydroxyapatite is actually a buffer, and in the presence of metabolic acidosis, there is leaching or release of calcium from the bones and a stimulation of osteoclastic activity. Rickets, if we remember, is a disease of growing bone. And so therefore you will hear about the corollary of rickets in adults because they also get bone abnormalities as well. Nephrocalcinosis occurs in various inherited tubulopathies. This occurs because firstly, there is sodium or salt wasting, which results in hypercalciuria. This results in deposition of calcium in the parenchyma of the kidney. And if there is concomitant reduction of citrate excretion in the urine, this promotes calcium deposition in the parenchyma. And lastly, rarely in diseases like Liddle syndrome, there may be hypertension, but most other salt-wasting tubulopathies have normal or low normal blood pressure despite variations in the renin-aldosterone status. With regards to investigations, so this is a very practical approach that we pediatricians take. The first line investigations are quite simple. It involves the venous blood gas, electrolytes, checking the serum creatinine, because one can't diagnose an inherited tubulopathy when there is an abnormal serum creatinine. Urine pH, urine electrolytes, looking for a urine anion gap, and assessment of urinary calcium excretion, and a simple ultrasound. So if there is acidosis, our second line investigations would be to look at a urine anion gap. A urine anion gap is a test to see whether in the presence of metabolic acidosis, there is appropriate acidification, distal acidification of the urine. And so in the presence of acidosis, the urine anion gap should be negative, indicating that there is H+ secretion or a large amount of chloride being excreted. If we are suspicious that the proximal tubule might be involved, to rule it out, we'd look for evidence of generalized proximal tubulopathy, such as glucose in the urine, proteinuria, beta-2 microglobulin, hypophosphatemia, etc. And lastly, we would look for systemic other abnormalities, organ system. For example, distal RTA may be associated with sensory neural hearing loss. An isolated proximal RTA may be associated with cataract, and renal Fanconi syndrome usually has multiple other systemic abnormalities. We'll move now on to alkalosis. So I'm sure you're all familiar with this, that if a patient has metabolic alkalosis, the first thing to do is to see if they are chloride sensitive. That is, if they've got losses, but if we replete them with IV fluids and chloride, they will actually recover. So in most non-renal causes of alkalosis, the urine chloride should be low. If the urine chloride is high, then checking a blood pressure will help. If the blood pressure is high, we are looking more at activating mutations and salt retention, which we will not focus on this talk. Instead, if the blood pressure is normal or low, we would look at diagnoses such as Barter's syndrome, Gittleman, and in adults to consider surreptitious diuretic use, though we don't see that in children very often. Diuretic use is not an inherited tubulopathy. We do some specific tests to assess tubular handling of electrolytes. The TMP-GFR is a test for whether in the presence of hypophosphatemia, the proximal tubule is reabsorbing the phosphate adequately. If the TMP-GFR indicates renal phosphate wasting, then we consider this a sign that there may be generalized proximal tubulopathy. If there is an abnormality of potassium and we want to test whether aldosterone is, the response to aldosterone is appropriate, we could do a TTKG. Similarly, we could do a fractional excretion of magnesium as well to look for magnesium wasting. In inherited tubulopathies presenting in young children, usually there is not much confusion with regards to incomplete tubular diagnoses. And so therefore, these functional tests for urine acidification are not routinely done by us, but I'll mention them. If we want to look for urine acidification in a patient who has very mild metabolic acidosis, we have to stress them out a little bit, either by giving them an acid load through ammonium chloride or by triggering the collecting duct to secrete H+ ions through the effect of stimulation of aldosterone. And this is done through the furosemide fludrocortisone test. I won't go into the detail for these particular tests. If we want to look to see whether there is an abnormal threshold for reabsorption for bicarbonate in the proximal tubule, then we do a bicarbonate loading test with urine pH monitoring. If the threshold should be set at least at around 20 to 22. If the patient begins to spill bicarbonate, showing an alkaline urine, when the serum bicarbonate is only around 15 or 16, then we know that the proximal tubule is not reabsorbing bicarbonate appropriately. So I'm going to end my little introduction here and request Dr. Pragnya to please share with us a few slides on genetics and the role of genetic testing in inherited tubulopathies.
Thank you, Dr. Priya. Would you be sharing the slides as well?
I can do that, yes.
Yeah, thank you very much. So this morning we've had a session on genetic testing in renal disorders on the whole. And I think we've already gone through these slides. So I'll just do a quick recap of what we've already discussed in the morning. So most of the inherited tubulopathies are single gene disorders. They're caused by mutations within genes. So therefore, when we are doing a molecular testing, when we are looking for genetic testing for inherited tubulopathies, we would be doing mostly the molecular genetic tests, which include Sanger sequencing, MLPA, or next generation sequencing based testing. Sanger sequencing, of course, would be done if you want to look at a specific gene, which is small, less than 10 exons in size, or when you want to look for specific variants. MLPA would be the test of choice when you want to look for large exonic deletions and duplications. But most of the time, what we do are NGS-based tests. And NGS is preferred because we have to look at multiple genes most often, because the same phenotype can be caused by any one of many different genes. Also, there can be a significant overlap in the phenotype, especially for the tubulopathies, as Dr. Priya nicely summarized. Most of them have very overlapping features. So clinically, and even with the serum biochemistry values and all your other investigations, you may not always be able to decide that it fits into this particular diagnosis. And therefore, you have to go with testing of multiple genes. And that's where your NGS-based testing approaches help you. So again, as was discussed this morning, if you have very specific phenotypes in mind, a very clear differential diagnosis, you could just go with a multigene panel testing or a clinical exome sequencing. But if you're looking at a more diverse phenotype, or where you're not exactly sure what it might fit into, on the whole, it probably fits into a tubulopathy or NSRNS or something like that, or for that matter, even a CKD of unknown origin, where you do not really know the etiology. In such cases, where you do not have a definite diagnosis in mind or a definite set of differentials, whole exome may be the test of choice, because the cost is comparable between these three different panels, not very significant difference in cost. And even in terms of coverage, the coverage is more or less good for all these three. As in, by coverage, I mean the depth of coverage, the number of times that particular gene gets sequenced. So nowadays, most of the whole exome panels have as good a coverage in terms of depth of coverage when compared to the multigene panels and clinical exome. So you could go for whole exome also. And yes, it's very important to, if you're going for just a panel or a clinical exome, it's very important to convey to the lab that these are the different genes. This is the phenotype you have in mind. These are the different genes that need to be included in the panel. And only when you're sure that that panel includes all those genes of interest, you need to go ahead with that panel. Otherwise, whole exome covers most of the genes and all the other genes also. And as was discussed in the morning, sometimes you may have new monogenic causes which are not already included in the existing panels. So those again would be covered through whole exome. And then finally, whole genome is reserved for only a specific set of cases where, because whole exome covers only the exons and the intron-exon junctions, it doesn't cover the deep intronic regions, the promoter regions, and it can miss the large exonic deletions and duplications because it's not really well standardized for those larger exonic deletions, duplications, and copy number variations. In those select few cases, you can go ahead with whole genome sequencing also. Otherwise, whole genome sequencing as the first line of first line testing is definitely not recommended, not just because of the cost, but because you get lakhs and lakhs of variants in whole genome sequencing, and many of them are difficult to interpret. So that's about the testing approaches. And yes, why we need to test is again already covered by Dr. Priya, because you have so many different inherited tubulopathies, so many different genes, and it's not always possible to clinically diagnose them and pinpoint exactly which gene it might be, which particular condition. And therefore, you need to do the testing to get a clear diagnosis, which will help you further. Thank you. So I think this is probably something that we can cover after your case,
Sure.
Dr. Priya.
Okay. Thank you, Dr. Pragya. So, Jaya, are you there?
Yes,
Jaya,
ma'am, I am.
so what I'll do is I will share the slides of the cases, and if you could just tell us about the cases, I'll share the slides. Okay, so.
Good afternoon, all. I will be discussing few of the cases that we have encountered in the recent past in our center. So the first case was a 3-year-old girl child born at term to third-degree consanguineous marriage. She was brought with complaints of generalized weakness and abdominal distension since few months. She was evaluated outside, and in view of signs of dehydration and severe hypokalemia, she was treated with IV fluids and IV potassium. When she presented to our center, she was found to have failure to thrive with a weight of around 8 kgs. She has extreme floppiness. She has all the signs of all the features of rickets in the form of frontal bossing, binding of rickets, rachitic rosary, Harrison circles. She also had loose skin turgor, but there were no other signs of dehydration. On further evaluation, she was found to be polyuric with a urine output of around 8 ml per kg per hour. Coming to our investigations, so as we discussed, we have an algorithm which we usually follow in our center. So she had severe metabolic acidosis with hypokalemia and hyperchloremia with a normal anion gap metabolic acidosis. She had normal renal functions. Her urine showed some mild proteinuria, but there was no glycosuria. USG abdomen showed bilateral medullary nephrocalcinosis with the urine calcium creatinine ratio, which was very high of around 0.9. She underwent hearing evaluation, which was normal, and she was discharged on bicarbonate and potassium supplements. So we also underwent a genetic testing for her, which shows homozygous variation in exon 19 of SLC4A1 gene, which codes for the anion exchanger 1, which is present on the basolateral surface of the intercalated cells, and it is basically a bicarb chloride exchanger, and it ultimately leads to potassium secretion from the potassium ATPase protein, which is available, which is present on the luminal surface.
Okay, thank you, Jaya, for presenting that case briefly. And as I said, these cases we will not present as mysteries, though we do struggle sometimes to diagnose them. And we were lucky enough to have genetic confirmation of the distal RTA in this child. So I would, however, like to call on the wisdom of our panel. I'm going to ask actually Jaya to briefly discuss, because this is a situation which is often confusing. How do you differentiate between proximal versus distal RTA?
So, proximal RTA and distal RTA, if we go by clinical presentation, proximal RTA usually present as a part of a systemic disease, as a part of Fanconi syndrome. Present distal RTA is an isolated forms. Some of the autosomal recessive forms of distal RTA can have hearing loss. Coming to the bony deformities, in distal RTA, the bony deformities are quite usually very severe. Coming to the investigations in metabolic acidosis, distal RTA has a very severe metabolic acidosis, whereas proximal RTA, the metabolic acidosis is mild, but is difficult to correct. And serum potassium can be low or normal in proximal RTA, which is low in distal RTA. Coming to the other features of generalized proximal tubulopathy, like low molecular weight proteinuria, amino acid urea, glucoseuria, are seen in the proximal RTA, which is not seen in the distal RTA. Nephrocalcinosis is often present in the case of distal RTA, and in proximal RTA, it's very rare. Coming to some of the tests, which as ma'am discussed, which we don't do in clinical practice regularly, but if you have to do it, then fractional excretion of bicarb, urine blood PaCO2 is usually very high in proximal RTA, and it is low in the distal RTA.
Okay. So I also wanted to mention that in practice, we routinely do a urine anion gap. And if there is metabolic acidosis and the urine anion gap is inappropriately positive, then we do have a confirmation of abnormal distal acidification, and we do have a good clinical evidence to say that this is distal RTA. In proximal RTA, though the routine teaching says that the urine anion gap will be negative or appropriate, we find that sometimes it is not so because of the abnormality in ammonia production when there is Fanconi syndrome. So if we have a positive urine anion gap, then yes, distal RTA is on the cards. If not, it does not rule out a proximal RTA. So my next question is going to go to Dr. Nivedita. Nivedita, are you ready to share your slides?
Yes.
Okay. So my question to you is to talk a little bit about adults, distal RTA in adults very briefly some of the acquired causes, and a comment on incomplete distal RTA. These are issues that we don't in pediatrics deal with very often, but you definitely do.
Thank you, ma'am. So after that classical presentation of distal RTA, now we come to distal RTA in adults and how does it present. So two things is distal RTA can present firstly for the first time in adults, and what does this depend on? So this can, as can be seen, these are the genes that have been associated with distal RTA. And autosomal recessive mutations of these genes cause mostly a severe phenotype with the onset in infants and childhood with a severe renal illness and extrarenal illness. But dominant mutations involving the anion exchanger has an onset later in life with a milder renal and sometimes absent extrarenal features. So this shows the genotype-phenotype correlation, and this is when distal RTA can present late. But apart from this, we should know how distal RTA presents differently in adults. Many things are common. For example, the sequelae of hypokalemia causing hypokalemic paralysis or muscle weakness, and some extrarenal features like sensory hearing loss and hemolytic anemia. But what's different is, as madam said, that it presents as rickets in infants and children, but it presents as osteomalacia, bone pain, and fractures in adults. And if it presents like nephrocalcinosis in infants, in adults, it can present with nephrocalcinosis and or urolithiasis. So it can present only as urolithiasis. And it's also very important to remember that in adults, secondary distal RTA should be ruled out, and the symptoms of the primary immune disorder behind the distal RTA should be looked for. So what should you look for in acquired? So important in adults is Sjogren syndrome and SLE. And important is these drugs which cause distal RTA, and importantly in the transplantation scene. And in the cause-effect factors, so distal RTA causes nephrocalcinosis, but nephrocalcinosis and hypercalciuria through a presumed mechanism of calcium-mediated dysregulation of tuberous itself can cause distal RTA, so that should be looked for. Rejection can cause distal RTA. Even liver cirrhosis and nephrotic syndrome is associated with distal RTA. So all these are acquired causes which should be kept in mind. So this is an interesting case that I came across in the nephrology OPD. So this was siblings of a consanguineous marriage, and they had a significant family history of similar symptoms. So the first was an 11-year-old female child who presented with rickets, bone pain, severe growth retardation, amelogenesis imperfecta, which is actually a structural malformation of the enamel, with normal renal function, normal anion gap metabolic acidosis, not very severe, severe hypokalemia, and severe hypophosphatemia. The urine pH was high, and ultrasound just showed a cortical cyst and no nephrocalcinosis. Slit lamp was normal, and even hearing evaluation was normal. So many factors go for distal RTA, but why is there severe hypophosphatemia? Why is there just mild acidosis? And there's no nephrocalcinosis. However, her elder brother had many similar clinical presentation, but had nephrocalcinosis in addition. So what could we have done just to know why there was severe hypophosphatemia in this case that looks like distal RTA? So was it malnutrition and severe vitamin D deficiency causing hypophosphatemia? Was there phosphate loss? By doing a TMP-GFR, we would ensure that. And what was the urine calcium creatinine ratio? And also, was there generalized proximal tubular dysfunction by looking at amino acid urea and others? Just interestingly, this amelogenesis imperfecta is known to be, and distal RTA is known to be combinedly caused by mutations in WDR72, which is one of the mutations that is seen associated with distal RTA. So this is just a representative picture of a case report of such an amelogenesis imperfecta with distal RTA. So what is important is we should look for extrarenal features associated with RTA that will help us towards a diagnosis. So as I said, nephrolithiasis and RTA. So the lithogenic factors that are responsible for stones are these. One is alkaline pH, the second is hypercalciuria, and the third is hypocytituria. But what I would like to stress upon is hypocituria and alkaline urine is what is most important, more than hypercalciuria. The type of stones in RTA is calcium phosphate. So what about individual RTA and stones? So distal RTA has all the three lithogenic factors. And as can be seen here with different mutations, the incidence of nephrocalcinosis is as high as 90%. And for person with urolithiasis, it can be seen that almost 20%, and especially with anion exchanger 1 mutations, as high as 42% patients have urolithiasis. They are predominantly calcium phosphate hydroxyapatite stones and should be treated with potassium citrate. But what about proximal RTA? Classic proximal RTA lacks all the classical calcium phosphate lithogenic factors. Hence, nephrocalcinosis and nephrolithiasis is not common, with the exception of Fanconi syndrome with dense disease, where there is a mutation. This mutation is also seen to be in thick ascending loop of Henle, which is associated with calcium absorption and hence has hypercalciuria and stones. So, with respect to bone disease, chronic acidosis causes diverse bone disease. So, it is seen to cause low bone turnover, demineralization. It also, in chronic acidosis, interferes with the vitamin D metabolism and action. So, in the study of 14 distal RTA patients with normal renal function, it was seen that the bone marrow the BMD measurement by DEXA was significantly lower compared to normal controls, and significant number of them had osteopenia and osteoporosis. They also went ahead to do a bone biopsy, which showed significantly decreased bone formation rate and low bone turnover. The same group did a follow-up study of the same patients after 1 year of alkali supplementation, and they showed that the BMD and bone turnover parameters actually improved. So, as Madam commented, there is another entity called incomplete distal RTA, which does not show an overt acidosis, and they show only mild renal acidification defects. Incomplete distal RTA can be acquired or hereditary, and the genetic basis of this incomplete RTA has also been elucidated by saying that heterozygous carriers of the pathogenic variants of the ATP gene and dominant mutations of the anion transporter do have incomplete RTA. Now, why is incomplete distal RTA important for us? In two issues. One is the bone disease. As can be seen in this study and also in other studies, this can be seen that 46 patients with primary osteoporosis had 35% of them had an abnormal furosemide test. And hence, these were the patients with incomplete distal RTA, and these patients were younger than controls, had a basal bicarb and pH similar to controls. The second important feature is recurrent kidney stones. So studies have shown that almost from 2 to 22% of recurrent kidney stones can have incomplete distal RTA. In this recent study of 386 idiopathic calcium stone formers, the ammonium chloride functional test was done for distal acidification, and 64 patients had incomplete distal RTA. And interestingly, these patients had more frequent calcium phosphate stones. They also followed up these patients after long-term alkali treatment, which showed that of those patients who were adherent to alkali treatment had lesser stone events than those who were not adherent. So suspect incomplete distal RTA and unexplained recurrent nephrolithiasis, especially when the stone is of hydroxyapatite, and also in recurrent calcium stone formers, even with calcium oxalate, if they have hypocituria, nephrocalcinosis, high urine pH, or even with osteoporosis with low normal bicarbonate. So based on these studies, the clinical practice guidelines have said that in adults with distal RTA, BMD by DEXA has to be done every 2 to 3 years, which could be helpful in assessing the fracture risk. Yeah, back to you, ma'am.
Okay, thank you, Nivedita. Would you mind stop sharing? So now I'm going to ask Dr. Alpana, and we're just going to have a chat about this now. Dr. Alpana, how do you go about managing a child with distal RTA, and how do you follow them up?
Good afternoon, everybody. Thank you, Dr. Priya, and the organizers for having me on this forum. Distal RTA patients, we usually start them on IPD, And subsequently, and often they require potassium supplements also. So initially, when the periods of growth is very rapid in the first 2-3 years, we need to follow them more stringently, more frequently, almost 3 monthly, and in the first 2 years, and subsequently less often. What we look at is the normalization of the bicarb to 22 to 24. That's what we're trying to look at with the alkali therapy, and normalization of potassium within the normal range. But we also get to know how well we have controlled the acidemia by monitoring the urine calcium creatinine ratio, which improves as the metabolic control is good. So urine calcium creatinine ratios are also monitored. We also look at X-rays for healing of rickets in the first few months of life. Subsequently, repeat X-rays are not required. But what is additionally important is that the severity of nephrocalcinosis has to be looked at 6 monthly initially and then annually. And the new things, the latest things which we have come to realize of late, that we tended to feel that distal RTA patients don't really develop progressive renal failure. New literature is coming in that they may actually, a lot of children by the age of 18 years, they go into stage 2 CKD almost 30 to 40%. So this is also something that as pediatricians also, as pediatric nephrologists, we need to monitor. That is the kidney sizes, CMD, urine protein, creatinine ratio, and so on. So in summary, I would say that we do blood biochemistry, both electrolytes and bicarb, urine calcium creatinine in every visit, which is 3 monthly for first 2 years and then 6 monthly. We do X-ray wrist for seeing the healing of bones in the first few visits that we see. We do USG for nephrocalcinosis initially 6 monthly, then annually. We also look at catching up of growth by checking the growth velocity, which has to be done in every visit. And then for evidence of CKD, annually at least, with protein creatinine ratio, the kidney sizes, the serum creatinine, that also has to be done. One additional thing, if we do not have the facilities for genetic diagnosis, we are just going the way we used to previously in government setups, that we are monitoring distal RTA. We should also keep checking their hearing evaluation, because we would not know which of the genetics they are in. So some of them have hearing defects which can come early or late. So that also may be evaluated from time to time for better overall outcome.
Thank you, Dr. Alpana. I'm in the interest of time, I'm going to summarize this case. If a child presents with metabolic acidosis, hypokalemia, and nephrocalcinosis with a positive urine anion gap, they are most likely going to have a distal RTA that can be confirmed genetically. The management includes correction of the acidosis. For children, monitoring growth is very important, and the healing of the bone lesions. But as you just heard, in adults too, they require long-term follow-up because they can continue to have bone abnormalities, and if not nephrocalcinosis, then overt stone disease. So I'm going to now proceed to our next case. Let me just, so Jaya, are you ready?
Yes, ma'am.
Okay.
So our second case was a 15-month-old male baby born to non-consanguineous marriage with a birth weight of 3 kgs. He presented to us with failure to thrive since 6 months of age. Currently, his weight was 5.6 kgs. He had recurrent episodes of vomiting and dehydration requiring hospitalization, and he also had history of polyuria with excessive thirst. On further evaluation, when he presented to our center, he was irritable. He had signs of dehydration with dry oral mucosa, and he had all signs of rickets as depicted in the picture on the right. So coming to the investigations. So he had severe metabolic acidosis with hypokalemia, hyperchloremia with a bicarb of 8 milliequivalent per liter. He had mildly deranged renal function with a creatinine of 0.5, which comes through eGFR of 55. His urine protein showed proteinuria, glucoseuria. His urine calcium creatinine ratio was normal. and the ultrasound abdomen done didn't show any features of nephrocalcinosis. His other biochemistry showed hypophosphatemia with a phosphorus of 2.13 milligram per deciliter. He had a rise in the ALP of over 800 milligram per deciliter. His 25-hydroxy vitamin D was normal as he was already on vitamin D supplements, and the serum TSH was normal. The child also underwent ophthalmological evaluation, which shows cystine crystals deposition in the cornea. The child was ultimately discharged on bicarbonate, potassium, phosphate, and active D supplementation. The child, it is because of these features, and we were suspecting a proximal RTA. The child underwent a whole exome sequencing, which shows homozygous variation in the exon 10 of the CTNS gene. The CTNS, so we made a diagnosis of cystinosis. The CTNS gene code for the cystinosis protein, which is a transport protein for the cystine. And if the CTNS gene is defective, there is no formation of the cystinosin, and the cystine is accumulated in the system, which leads to ultimately the other features of other systemic manifestations.
Thank you, Jaya. So I'm going to stop sharing my slides and ask Dr. Alpana. Dr. Alpana, I'm sure we know how difficult it is to manage a patient with cystinosis, a child with cystinosis. So very briefly, could you just cover what their early comorbidities are? And then we'll cover in the next section what their late comorbidities are.
Yes, we all of us are aware that cystinosis leads to a condition of Fanconi syndrome in the kidneys, and that's the earliest and the most common involvement besides the ocular involvement. The ocular involvement may start occurring quite early, but it is obvious in the form of we can pick it up by ophthalmic examination by about 18 months of age. Besides these two organs, which is the kidney and the eye, other organ which is most commonly involved is hypothyroidism, which again happens due to deposition of cystine crystals. Besides this, even GI manifestations like GI disturbances, difficulty in swallowing, and GER, constipation, diarrhea, etc. All of these are early kinds of changes. Later on, we see multi-system involvement because here the gene involved and the protein that it codes is by an intracellular organelle. It is at the lysosomal transport level, so it is ubiquitously expressed. So it is a multi-system involvement. But we are talking about what we see early on. So whenever we diagnose cystinosis, we have to look at the thyroid, we have to look at the eye, we can anticipate a lot of GI issues, intolerance also to histamine, cystagone tablets, which we are giving. So these are all the things. And another thing, we see short stature, statural retardation as a part and parcel of Fanconi's and Artemis. But these children are much more shorter than the other children. So the bone manifestations are believed by some to be way out of proportion than what usual Fanconi's is. So this also is one of the early involvements. This is a very short stage.
Thank you, Dr. Alpana. So now I'm going to switch gears and talk a little bit about the later outcomes of cystinosis. We are all familiar with the fact that almost all our patients go into kidney failure with cystinosis, but what I think is important to keep in mind is the various other comorbidities that they develop as they get older that may not have been present so much in the early childhood phase. So over to you, Nivedita.
What case Dr. Jaya presented was the typical infantile cystinosis. So we can say that cystinosis is a pediatric disease, but no, it's a pediatric disease with a spectrum that extends into the adult medicine. As is seen from this picture, these are the patients, this is the course of cystinosis when cysteamine was not given, and can be seen that they reach ESRD by 12 years of age. But even after that, patients, when they are on RRD or when they get transplanted, it's important to remember that they continue to have these extrarenal features and should be looked for. So as this is just a repetition, so this, what are the extrarenal features that we should look for? Hypothyroidism, basically endocrinological problems, diabetes, myopathy, swallowing problems, and pulmonary dysfunction, and can be seen that these complications drastically reduce when patients are put on system. Other than these extrarenal features, there is another entity called late onset cystinosis, which is seen approximately in only 5% of cystinosis cases. This can be nephropathic or non-nephropathic. The nephropathic can present in non-infantile forms in the childhood, in the adolescent, and the adults. These patients basically have glomerular involvement with proteinuria, but not necessarily Fanconi syndrome. And they might have mild renal insufficiency, but they might have heterogeneous progression. So in this study of 14 non-infantile cystinosis, it can be seen that the age of presentation of symptoms was from 4 to 23 years of age. And those presenting later in age did not have proximal tubulopathy. They had a normal serum creatinine at diagnosis, but all of them had proteinuria. And they had very heterogeneous progression with the same, these are the families. So in the same family, different patients had ESRD, they did not have ESRD, mild, some had mild renal dysfunction. So they had very heterogeneous progression. And the renal biopsy done in these patients showed FSGS in 3 and crystals in 3. And around 75% of them did have CTNS mutations, and they also had mild mutations. So it's important to understand that this set of patients can be misdiagnosed because they have proteinuria and FSGS, and they might be unnecessarily immunosuppressed, and adults may not complain of eye symptoms, but it's important to know this identity. And cystinosis also important to know once patients are on RRT, what should we look for? They may have persistent Fanconi syndrome, so it's important to monitor their very high residual urine volumes and saline loss, and the ultrafiltration has to be tailored to prevent excessive removal. They should be treated, the electrolytes loss should be treated, and there should be individualized management of the diet of these electrolytes, and the water restriction should be looked for, and even phosphate binders has to be titrated according to the existing phosphate levels. And it's important to know that the system and dosage need not be adjusted for the GFR. What should we look for in transplantation? Cystinosis does not recur in the graft, and living donor is acceptable because they carry only a heterozygous, they are the heterozygous carrier of the mutation. And it's important to note that pre and post transplant, they can have residual Fanconi, especially if the native kidney has some urine output. And it's important to ensure normal volemia and normal electrolytemia peri and post transplant. This histamine should be temporarily stopped during transplant and should be restarted around 4 to 6 weeks post transplant, because they have a high incidence of endocrinological abnormalities. Diabetes mellitus should be looked for post transplant, which might need corticosteroid reduction and avoidance, and even probably replacing tacrolimus with cyclosporin.
Thank you, Nivedita. So I just wanted to also remind everyone that it is very, very rare for a patient to actually be on cysteamine because it is very expensive and hardly available in India. So unfortunately, we see the worst of the comorbidities of cystinosis. So I'm going to move on now to the last case that we'll discuss before we wrap up. So Jaya, will you tell us about this patient? Yes. Okay.
So this girl was a 10-year-old girl who had gone to a third-degree consanguineous marriage. First presented to us at 3 years of age with failure to thrive, polyuria, recurrent episodes of dysuria, but no history of any urinary tract infection. When she presented to us, she had no, on examination, she had no acidotic breathing, any bony deformities was noted, and she had no signs of dehydration. She was hemodynamically stable. On her presentation at 3 years of age, she had normal serum electrolytes with borderline low normal bicarb. Her renal functions were normal. Urine routine showed mild proteinuria, and she had severe hypocalcemia with a serum calcium of 7.2 and hypermagnesemia with a serum magnesium of 1.1 milligram per deciliter. Her ultrasound abdomen showed medullary nephrocalcinosis, and she had high urine calcium creatinine ratio of 0.8. When we calculated her fractional excretion of magnesium, it was found to be high of around 4%. Her eye examination was normal, and she was managed with magnesium and potassium citrate supplements. She was recently admitted with carpopedal spasm, and on this time, her investigation showed derangement in the renal function with a serum creatinine of around 0.7, with leading to around CKD stage 2. Her serum electrolytes were normal, BICA was 21 milligram per liter, and this time also she had severe hypocalcemia and severe hypomagnesemia. So we tried to do a genetic testing for her, but because of the financial reasons, we were not able to do. But with this clinical picture of hypocalcemia, nephrocalcinosis, and hypomagnesemia, we had made a diagnosis of familial FHSNC, with showed that which is responsible for the which occurs as a result of mutation in the claudin gene, which codes for the claudin 16 and claudin 19, which is responsible for the paracellular transport of the calcium and magnesium.
Thanks, Jaya. So we didn't. So this is reality.
Excuse me, Dr. Pais,
Yes.
we have about 2 minutes. So can we try to wrap up in another couple of minutes? Then we can have some questions.
Sure. So I'm going to basically ask, this is a child, I'm going to ask Dr. Pragnya the last question for this case then. So Dr. Pragnya, this is a child who is going to go into CKD. We see children with FHHNC quite often. So what would be the importance of genetic evaluation in deciding if this child could have a living donor? Dr. Pragnya, are you there? I'm not sure if she's there. So briefly, before I ask Nivedita to pull up her summary slide, I'm just going to go over the importance of nephrocalcinosis in our differential diagnosis. So as you can see, there are many tubulopathies that can present with nephrocalcinosis. This child's diagnosis, we suspected, was familial hypomagnesemia, hypercalciuria, and nephrocalcinosis, but there are several others, and many of them can go on to CKD. So I think it's important to confirm a genetic diagnosis. Of these, hypomagnesemia is present mainly in FHHNC. That's what helped us. So I'm going to stop sharing here and summarize our cases with some take-home messages.
Yeah, sorry, the internet connection just, the previous one just got over. So I just logged in through my phone. So I think you've basically covered the points that there are a lot of other differentials for nephrocalcinosis. And if you go for a transplant, some of them might recur in the transplanted kidney and so on. And in addition, there might be some disease-specific therapies for some. So obviously, there is a definite need to establish the underlying etiology before you plan the further management. Thank you. Sorry about that.
No problem. No problem. Nivedita, could you have take-home messages, please? So in the interest of time, we won't share our Gittelman's case with you, but basically, we sometimes have some confusion between type 3 Barters and a Gittelman's. And so again, genetic testing is really invaluable in these cases. I think you're muted, Nivedita.
Yeah, the take-home message for this present panel discussion is that inherited tubulopathies present with specific clinical and biochemical phenotype, and it's just a fingerprint. So some of the examples are metabolic acidosis with hypokalemia, metabolic alkalosis with hypokalemia, nephrocalcinosis, polyuria, hypercalciuria with normal calcium levels. And inherited tubulopathies are a common cause of failure to thrive in children. And adults present with secondary complications like stones, bone disease, extrarenal features, and can develop renal dysfunction. The yield from genetic testing is very high in inherited tubulopathy as compared to the rest of kidney diseases. So genetic analysis helps in not only confirming diseases, but also helps in correcting the diagnosis and hence helps in reverse phenotyping. So this is just a list of the important guidelines that have been recently published in the last 2 years on these main inherited tubulopathies. Yeah, thank you.
Thank you, sir. We are ready for questions.
Since we are running short of time, I think we'll just take the questions in the chat box and try to answer them while later. But I would like to thank Dr. Priya Pais and the 4 panelists for a wonderful discussion. And certainly your points have helped to unravel at least part of the mystery of the phenotype, which has been discussed over the past 5 to 6 decades by the use of genetic tests in the diagnosis, and definitely in assisting in management of a lot of our children with inherited tubulopathies. Thank you so much. And I would like to thank Sanjeev as well. Sanjeev, would you like to say any words before we wrap up?
No, I think it's been an excellent session, except I just wanted to share our experience at SGPGI. We found, especially in distal renal tubular acidosis, a lot of secondary causes, especially posterior walls, vesicoureteral reflux. When they present late, there is a tubulopathy happening. So the dictum is that at least look for, do a good ultrasound, rule out the secondary causes, and then try and do the genetic testing, since expensive, not easily available. So keep the secondary causes in mind. I think it was mentioned, but I thought I'll just reiterate that.
Yes, sir, I think
a great.
Yes. I think thank you so much, Sanjeev, and thank you once again, Dr. Priya Pais and the panelists. And I would like to thank the organizers for this opportunity. Thank you so much.
Thank you very much to everyone.
Thank you, organizers.
Thank you.
Thank you very much.
Thank you so much, all the speakers and chairpersons, for an excellent panel discussion. It indeed made inherited tubulopathies easy learning. We now move on to the next talk. The next talk is on palliative care in nephrology. Its time has come. We'll find out. Speaker, Dr. Swarnalata ji. I request the chairpersons to come and occupy the chair. We have with us, fortunately, 2 people in person. Dr. Sri Krishna Venturpalli, consultant nephrologist from Queensland, Australia. He has more than 25 years of experience in nephrology. He has graduated from PGI Chandigarh. He is the immediate past chair of Queensland Renal Clinical Network. He has special interest in chronic kidney disease progression, hypertension. He's also a steering committee member of Advanced Kidney Care 2026. We welcome you, sir. Our next chairperson, Dr. Kiranmay Ismail, Professor of Department of Nephrology, Osmania Medical College, Hyderabad. We welcome you, madam. We have with us our esteemed chairperson, Professor Lieutenant General P.P. Verma. Sir is presently the chairman, Department of Nephrology in Primus Hospital, New Delhi. Sir has served in the Indian Army for over 37 years. He was the honorary surgeon to the President of India. He was the past president, Indian Society of Nephrology, vice president, ISOT, council member in ISPD. He also has more than 200 presentations, 70 plus publications, and 15 international publications to his name. We welcome you, sir. We are happy to have you here as a chairperson. I hand over the mic to the chairpersons to introduce our today's speaker and start the session. Thank you.
Thank you very much. I think the theme is palliative nephrology. Its time has come. I think abroad, the palliative nephrology has become a specialized fellowship. And in India's scenario, I must say that most of the nephrologists, by and large, are busy dealing with our clinical nephrology. We are managing patients with whether it's the AKI, CKD, but many times we forget there are innumerable many issues which are not being addressed. It is something like a person is having pain, or a person is having anxiety, depression, a person is complaining of weakness, he has got cognitive dysfunction, there is no help at home, there is financial issue. So to address these issues, I think what you need is a separate branch, that is the palliative nephrology and palliative care. It is for you all to decide whether the time has come for this palliative care. I personally will feel the time was there long back, but it is resurfacing and it's an important thing. I think to address this issue, We have got Professor Swaranlata. She is a well-known figure in the field of nephrology. She is a member of South Asia Regional Board, ISN. She is a TTS champion. She is joint organizing secretary of this Win India conference. She is secretary Hyderabad Nephrology Forum, and she has got a lot of publications in national and international journals. But before I hand over to her, I must compliment and thank Dr. Manisha Sai and the team for this wonderful gesture of organizing this important conference. And I hand over to my friend co-chairpersons for their comments before she starts the talk.
Thank you, sir. Good afternoon, everybody. After the very stimulating scientific program since morning, we have now come to a very soothing topic, that is palliative care. Palliative care, all of us know, it's an approach to quality of life in people with the life-threatening diseases. And all of us know the dynamic Dr. Swarnalata. She is the additional professor at Nizam's, and she is the best person to deliver this topic. I welcome Dr. Swarnalata to deliver.
Please start playing the pre-recorded video.
Yeah, good afternoon. I welcome you all to the first annual conference of Women in Nephrology India, and hope you're all enjoying the conference, and I thank you for participating in the conference. Coming to topic for today, my topic for today is palliative care in kidney diseases. Before I move on to my talk, let me share my slides first. Yeah, hope my slides are moving. Yes. So as you can see, there has been increase in life expectancy over the past few decades across the entire world. In Northern America and Australia, it's been more than 85 years. And it's least in Africa, it is less than 50 years. And if you look at India, it is somewhere around 70 to 75 years. And it's projected to increase further in the coming decades as per the UN projection. So if you look at the mean age of the population, it's least in India to less than 40 years. And in Japan, it is supposed to be the country of elderly population. The mean age of the population is more than 50 years. But I mean, should we be celebrating this because we have achieved, the increase in life expectancy to around 70 to 75 years when you are celebrating 75 years of Independence Day? I think it's not because we have not successful in increasing the quality of the life and improving the quality of life. So as with advancing age, as you can see, there is increase in the diseases, number of particularly the lifestyle diseases causing a impairment of the physical health. And most of the population are on multiple medications like antihypertensive, anti-diabetic, antiplatelets, statins, and so on. And this compromise on the physical and the psychological and the emotional health, and the functionality is reduced. And there's also compromise in the social life. Population, elderly population restricted at health. They don't have a networking with their families and friends. So the overall quality of life is compromised. And in one of the study done on the quality of life of rating in India, you can see India, the quality of life has been very poor, and it is rated somewhere lower down. So at this juncture, it's very important to have a quality of life. So what is palliation? So what do you mean by the word palliation? It means mitigation and the alleviation, attenuation, and relief. These are all the meaning of the word palliation. So how do you define a palliative care in medical therapy? So it is a specialized care that focuses on relief of pain and other symptoms of serious illness, no matter the diagnosis and the stage of the disease. Though initially it was only related to the incurable cancer, but now it has been expanded to all the chronic diseases where there is no curative option, including the chronic kidney diseases. And what are the components of palliative care therapy? It starts early in the disease, particularly focusing on not only physical health, but also on the emotional, social, spiritual needs of the patient, not only the patient, but also the family members. And is a continuous process of re-evaluation and adjustment. It also is continued towards the end of the life care, where we try to make patients comfortable, particularly when we realize is there no therapeutic options, no cure for the disease. We try to comfort the patient and smoothen the journey towards the death. And it doesn't end with the death of the patient. It continues, the journey continues for the bereavement care of the family members. So you should also remember the term hospice care, which is basically used for the patients who are critically ill and there is no the options for therapeutic interventions. And for the comfort of the patient is managed at home in the presence of the family members. And basically, it is not the quality of life, but it is quality of death, where it is the care is taken to see that the patient moves smoothly towards the death, including the psychological components. So what is the rationale of introducing a palliative care in nephrology? As you all know, that the renal replacement therapy is not equitably accessible to all the patients with CKD. Only 20 to 30% of the patients with CKD are accessible to renal replacement therapy. And despite the accessibility, the renal replacement therapy doesn't provide the cure to the kidney disease, just a supportive care. And the patient do suffer from the various these symptoms or what you call psychological and emotional component during the process of the kidney disease. And most of the patients are elderly, frail, they have multiple comorbid conditions, they're functionally poor, and there is a very high symptom burden on CKD patients. That's the reason why we need to have a palliative care in nephrology. These symptoms are no less than the cancer. As you all know, the term palliation was introduced for only the cancer. And you remember, the symptoms in nephrology is no less than that of a cancer. And the psychological distress start early in the diagnosis of the disease when the family members and the patient comes to know that it is a continuous process and there's no permanent cure and patient has to undergo dialysis for lifelong. So they get into psychological distress and then it leads on to anxiety, depression, and has to be treated appropriately. And there's very less use of hospice services in kidney patients. And the caregivers also, they also get into fatigue, and it is the responsibility of the healthcare providers to look into that aspect as well. And the nephrologists definitely, have to be included in the palliative care therapy of the patient, particularly patients with advanced kidney diseases. So as I said, elderly population is one of the risk factors for the CKD, where we need a palliative therapy. And one of the study from India have shown that the mean age of CKD in India in female is 49 years and in male is 50 years. And the mean age of the patients undergone MHD is 56 years, and elderly more than 75 years of age undergoing maintenance hemodialysis in India was 4%, and fertility in elderly was 65%. And in this study, they have shown that 20% of the patients were more than 85 years age, and among them 30% of the patient, around 30% of the patient, they died within 30 days of initiation of dialysis, and only 30 patients could survive to 1 year of dialysis. And it also showed that in patients of more than 80 years of age, there was not much difference in the survival rates among the patients who received renal replacement therapy compared to the patients who were managed conservatively. So it's $1 million question whether to give the renal replacement therapy option to the elderly population, or we are giving more harm to such patients. So I think it's a huge debate, and it's not never going to end. So that's how we have to introduce the concept of palliative care therapy in CKD patients. And how do you define a palliative care therapy in kidney patients? It's a comprehensive management of the physical, the psychological, social, spiritual, and existential needs of the patient and the families in the setting of chronic kidney disease. And what are the goals? To achieve the best possible quality of life by relieving suffering, controlling the symptoms, restoring their functional capacity, maintain the sensitivity to personal, cultural, spiritual beliefs and practices. Various terminology has been used with respect to palliation care in kidney diseases. It can be called as conservative management, active supportive care, maximum conservative management, renal support care, residual renal support care, conservative kidney care management. The palliative renal care, comprehensive care, kidney, tablet dialysis, and no clearance clinic. So there have been several terminologies being used. So in one of the KDIGO controversies conference, it was termed as a kidney support care rather than a kidney palliative care. It reinforces the appropriateness of this kind of a care, and distinguishes from the end of the life care. And the principles of the kidney support care is the shared decision making, advanced care planning, hospice care, the symptom management, and the quality of life assessment. And who qualifies for this the kidney supportive care management is patient who are anticipated to have a poor outcome on dialysis, and in whom the transplantation is not possible, is not feasible option. The recurrent vascular access problems in MSD patients, and who do not want to undergo peritoneal dialysis, and transplant in these patients is not a feasible option. The intercurrent events resulting in worsening of prognosis like stroke, fall, the bone fractures, worsening of cognitive function, these are the patients who require a palliative care. The terminally ill patients, particular terminal malignancy patients who wants to withdraw from dialysis, and increasing frailty and the cognitive decline. So these are the patients who require the supportive kidney care. What is a shared decision making? It is actually foundation of the kidney support care. It is prioritize the patients to choose to prioritize the components of the medical care deemed most important to them. It facilitates the integration of the patient's lifestyle, and it includes the family, the social community, and cultural value. All these things are taken into consideration when we take decision for the patients for the subsequent care. The quality of life assessment is one of the important factors in palliative care therapy. It begins with the diagnosis of CKD and continues till the death. It is multidimensional patient-reported quality of life. The need for there's a need for the serial assessment, and also assess the frailty as needed. The various online calculators and apps are available to do the quality of life assessment. This is one such the scale where we use a subjective, the questions is subjective questionnaire based the quality of life assessment score. It can be done easily and repeatedly. And as I said, there are certain calculators available basing on several criteria. That is, this is one criteria based upon the cognitive health, the general health, functional independence, social support, the medications being used, the nutrition, the mood, and also and so on and so forth. What is the advanced care planning? This is the epitome patient-centric care. It's a process undertaken by the individual to understand and share their personal values, the life goals, the preferences regarding the future medical care, and all these are considered for the decision making. The advanced care planning assists family members and surrogates decision making and lessens their anxieties. So family members are taken into account, and all these patient parameters are taken into consideration with respect to the patient values of life, the goals, and what are the patient preferences, and family members are taken into account, and they're discussed about the care of the patients in advance. So the advanced the care planning should be integrated into the routine kidney care for all the patients. So another important factor of the palliative care therapy is the symptomatic management. The most important symptomatic management is the pain management. However, I'm not going to discuss about the pain management for the CKD patient. Most other symptoms which has to be addressed in kidney patients, constipation, because patient is on dietary restriction and patient on several medications which leads to constipation, the shortness of breath because of the fluid overload. And most of the time it is advisable to manage these patients non-pharmacologically, but however, if it is required, the minimal medications can be used, particularly with respect to the myoclonic twitchings and myoclonic jerks, particularly but benzodiazepines and clonazepams. Who are the ideal candidates for the conservative kidney management? So presence of one or more life-threatening comorbidities, the frail with significant pre-existing functional and cognitive impairment, reside in the long-term care facility, irreversible mental incapacitation, permanently unconsciousness, and unable to cooperate with the procedure of dialysis itself makes the patient ideal for the conservative kidney management. And another important aspect of the palliative care in kidney patients is the withdrawal of the dialysis. So as we see a withdrawal of life support system, so in kidney patients, withdrawal of dialysis becomes a major decision making. And the patients who have a capacity to make the decision, who can choose to withdraw withdraw from the dialysis, can be considered for this option. And in whom dialysis may prolong the life for a short period of time, but it also prolongs the suffering. So these are the patients where they can choose for the withdrawal of dialysis. Hospitalized patients with multiple organ system failure that persists despite intensive therapy, and the severe and irreversible dementia and limited life expectancy, particularly we are expecting death within 60 days of 60 days. These are the patients where we can consider the dialysis withdrawal. So this supportive care can be offered at every point, right from the diagnosis, the maintenance dialysis, or during the acute the fallback from the dialysis, or during the increased frailty. So it basically consists of the support care, that is the prognostic of the patients, including the patients for the decision making, giving the treatment goals based upon the patient preferences, and then alleviating the symptoms and the shared decision making. This can be done at every step of the patient care. So on overview, it is important for the patients to be identified who are the candidates for the palliative care therapy. And then we have to actually do advanced care planning with respect to decision makers, and have to set the goals for the care based upon the patient parameters like social, cultural, and other practices. And the decision making can be made on the either to go for a conservative management, or initiation of dialysis, or to withdraw the dialysis if patients already on dialysis. And the other step is to reduce the suffering, the physical symptom management, or the emotional psychological management, or the anticipatory grief, or the spiritual support, so that the movement towards the journey towards that is peaceful. And the journey doesn't end with the death of the patient, can be extended beyond the death of the patient to the care of the family member with respect to basically the bereavement care. So what are the barriers? There are several barriers. If you look at in principle, particularly in India, where there is a limited resources, we usually give palliative care therapy. I still remember during my residency days, we didn't have the maintenance dialysis center as we are having now. So we used to have a huge load of patients who come with a fluid overload or uremic symptoms. We used to give them temporary intermittent proton dialysis and relieve the symptoms and send them off. Again, the patient has to come, used to come back with the same symptoms within few months. So that's how basically the whole of the nephrology care is only based upon the palliative care, knowingly and unknowingly. But I think still we need to increase the awareness, or we need to have the strategies to how to approach the palliative, how to have the approach of palliative care services in kidney patients. So usually there is no a proper training of the nephrologist towards the palliative care in our patient, which is a major barrier. And there is also lack of the patient understanding towards the potential benefit of having a palliative care. Even though if there is a availability of this palliative care, there is uneven accessible to the specialties palliative care services, and there is no perfect module, particularly in developing country like India. There is underdeveloped modules are there, and of course there is a misaligned policy in the incentives for the palliative care therapy. This is one of the study which has published the integrating the palliative care to CKD care. This is actually questionnaire-based survey study where they have tried to include the professionals in the paramedical population in this, and they have concluded that the survey results showed that the nephrologist clinicians from all the disciplinary backgrounds endorse the palliative care for the patients with advanced kidney care diseases, but experience barrier in implementation of such palliative care therapy for the CKD patients. But what are the solutions? So basically, there should be a screening for the requirement of palliative care in all the patients of CKD. So I believe most of the patients require palliative care at the beginning of the diagnosis of the CKD, and all patients should be screened at the diagnosis of the CKD. And incorporate the palliative care measures in the ESRD management programs. So all the packages we have. So as of now, we are having all the management of the CKD, the maintenance dialysis. So we should also have, the insurance package for the management of the palliative care management of the CKD patients. That will definitely create an awareness and amongst the patient as well as the healthcare providers. And the proper training, there is no proper training of the fellows. They are only concentrating at the management of the patient, particularly with respect to prescriptions and the dialysis prescription and medical prescriptions. But there should be proper training program at the DM nephrology fellow itself, which enhances the assessment competency as per the curriculum. As I said, there should be the reimbursement or insurance policy, which will definitely increase the palliative care, the quality. And there should be also be the funding for this research. A lot of research should be done in the case of palliative care therapy. These are the few, the barriers and the solutions where we can overcome we can offer a better palliative care to these kidney patients. Thank you. Thank you very much for your kind attention.
Hello. Thank you very much, Swarnalata, for a wonderful presentation. It covered the topic very well. And I thank the organizers for giving me this opportunity. And Manisha, thank you very much for last minute inclusion. This topic is very close to me because I prefer the word kidney support care rather than palliation, because palliation gives a notion that people are at terminal care. So kidney support care, because the reason is, nowadays, what happened is this kidney support care concept is introduced at the very beginning. When we are discussing renal replacement therapy, when we tell them about PD, hemodialysis, transplant, we include kidney support care as one of the components. It is based on one principle, which requires actually a titanic shift in thinking of all the residents and nephrologists. What it means is dialysis should be a choice of the patient, not an inevitability. Because most of the patients believe that the end game of CKD is dialysis. Everybody believes that they have to have dialysis. And if they can't have dialysis, there is an amount of guilty feeling, both with the patient as well as the family. And there's a big emotional burden that they can't have dialysis. And somehow is a failure of life. That's not the case. So we always make it dialysis as a choice, not as a must. That's the first principle. The second principle is every patient has a right to die with dignity. So we run a program in our hospital, what is called Living in Peace with Dying with Dignity. That is the name of the support care program which we run. And every patient is given an opportunity at the beginning to say, do they want dialysis? So there are patients in my clinic who are declined to have dialysis, continuing to be under our care for years together. It could be 2 years, 3 years, doesn't matter. The family is comfortable, the patient is comfortable, the children are very happy that the parents chose not to have dialysis, and everybody at peace. And we also discussed the choice of death. Where do they want to die? How do they want to die? Could it be home they want to die, or be it a hospice they want to die, or they want to come to hospital? So please include this concept at the very beginning and don't leave it at the last minute where everybody feels guilty about it and they think that they have to die because there's no other option. No, kidney support care is actually an option. So that's the most important. And as a last kind of comment, please do it in a systematic way. So what we do is we use different scales are available. We use IPOS scale, that is palliative outcome score scale. And we also use hospital anxiety and depression scale, HADS. But most important is nowadays, almost every program is based on what is called as Pepsi Cola. You would have heard about that. There are about 9 components of that. The first P starts with physical and the last A starts with aftercare. That's most important. But the most important component of this kidney support care is the carer. Don't ever forget the carer here, because there's a huge emotional burden on the carers rather than the patient. Patient may just remind, but the children, the wife, the husband, and those who are taking care has an emotional burden and a guilty feeling as to their relative or their close person is dying without dialysis. So these are the important things. And I suggest that if some of the teams can actually form as a network, kidney support care network, compare each of what they're following, how they're doing, because this is a double-edged weapon. Sometimes people believe that supporting the kidney support care means we are denying dialysis to some patients. Make sure that is not, that's the most important components of it. But it's a wonderful presentation. Thank you.
Krishna, very well said, I think. I think that word, when you talk of palliative care, it gives a feeling that it's end of the life care. But as you rightly said, it should be called kidney support system, because the support starts right from beginning. It is not only in the end we are trying to do it. And the second important aspect you mentioned, that we forget about the family members. Now, in Hyderabad, in their Rajiv, whatever, Agyashri free dialysis system, they started offering dialysis to all the people. And after 6 months, more than 50% of the patient gave up. They simply gave up because there is no relation or caregiver to bring them up. They do not have money even to travel the distance. So this kidney support system has to take care of that. If maybe a social worker is involved in that, maybe a charitable institute or charitable help is involved in that. It's a huge setup. It's not a single man setup. It's a huge setup. And unfortunately, possibly there is nothing in India like this at the moment. Maybe on a frugal, small scale, somebody is having a support system, some NGO is helping. But to have a comprehensive system is what is required today. And I think a very well covered topic. And there is a definite need for such things to come up. And thank you, Manisha, for bringing this up. And I always feel that family members should get incorporated in this. Yeah.
Excellent topic, well covered by Dr. Swarnalatha. As you rightly said, it has to start in the beginning itself, sir. And any questions, we can take a couple of questions, but we are running short of the time and we want to proceed to the next session. 1 or 2 questions are allowed.
The first step is the cultural change. As Swarnalatha presented, is the thinking that is the most important thing. Once you start thinking that that's what it is, it's initially to start discussing with patients first in your clinic itself, that dialysis, as I mentioned, is a choice, and every patient doesn't have to go on to dialysis, and you can explain the reasons why they can't. And if they choose not to have dialysis, support that concept that it is okay not to have dialysis. That's the most important thing. And try to coordinate with other specialties, because the same patient who comes to you, go to a cardiologist, go to an oncologist, go to an endocrinologist. So avoid inappropriate treatment. That's the most important thing. So it's a coordinated care between other specialties, so that you may say that, see, we avoid polypharmacy in these patients. What's the point of giving multiple medications for somebody who choose not to have dialysis? But what happens is you may reduce the medications, but they go to cardiologist and somebody will start medications again. So please try to coordinate. And most important is document it. So clearly state that this patient had discussion with this patient, with the family, and with eyes wide open, means with knowledge, agreed not to have dialysis. That's important when these people land in emergency services. So somebody may come very unwell in emergency, and emergency will start dialysis. So we regret that. We clearly
in Australia, what is the team? What is the palliative care team you have got?
Okay.
What are the components of that?
Yeah, it's a multidisciplinary team. For example, in my hospital, myself as a nephrologist, we have a social worker, we have a psychologist, and we have a separate CKD, CNC nurse, a nurse who is dedicated to this program. So that is basically the component of this. And in addition, any allied health will bring into the system. So somebody may require—
The patient doesn't have money. In your place, the dialysis may be free, But in India, if the patient doesn't have money,
Varmaji, that's where we include social workers.
yeah,
So the social workers will support. If it is a financial component, be open about it. You know what I mean? See, open and honest discussion is the beginning of kidney support care. That is the most important. When Varmaji, we have done this in PGA many, many times. When patients come and they're not for transplantation, we sat with the patient's families and discussed and said that, hey, you cannot have transplant. Obviously, we can't provide dialysis. And we used to explain the outcomes to the family. And we tell them not to lose their house or everything and all, and explain. And family would have accepted the decision why we are saying that. You know what I mean? So what we used to do 25 years back in PGI probably is the fundamental basis for kidney support care.
Okay. Thank you so much, all the speakers and chairpersons. We indeed have been motivated to start kidney palliative nephrology as part of our curriculum. Thank you, chairpersons. Moving on to the next talk, we have Dr. Saxena Alexander from CMC Vellore. Her talk is on IgA nephropathy. Can outcome improve without oral steroids? So I invite chairpersons, Professor Dr. Nandita Chaudhary, Chief Consultant and Senior Nephrologist from Guwahati, Assam. Madam is one of the first nephrologists in the Northeastern region. She graduated from PGI Chandigarh. Madam has held previously many positions: past President of Indian Society of Nephrology, Vice Chancellor in Assam University, Principal cum Chief Superintendent of Assam Medical College. She also has founded the Department of Nephrology at Guwahati Medical College. She also has received Lifetime Achievement Awards by East Zone in ISN in October 2012, and also Dronacharya Award by Avatar Foundation SGPJ in 2019 for lifetime contribution in the field of nephrology. She also has received Lifetime Achievement Award by Tanker Foundation, Chennai. She's truly the teacher of teachers. We welcome you, ma'am. We are happy to have you here. Our next chairperson is Professor Basu Gopal, full-time specialist transplant nephrologist from Alfred Hospital, Melbourne, Australia. He's joining us online. He also is an associate professor in Monash University, Melbourne, Australia. He's also a member ISN Education Working Group. He's also contributing significantly by editorial advisory board member, Indian Journal of Transplant. And also he's also one of the distinguished educator of the TTS. We are happy to have you, sir, here. I request the chairpersons to introduce our speaker and start the session. Thank you.
Thank you very much for inviting me to chair, and it's really a great honor to be affiliated with the Society for Women in Nephrology in India and participate in this first annual conference. And it's even greater a pleasure to introduce my my friend, my classmate, Dr. Susina Alexander from my MBBS batch, who was also my colleague in the unit in nephrology in Christian Medical College, Vellore, who's currently now Professor, Department of Nephrology, and also has made her mark in research, has now become additional vice principal of research in CMC Vellore, and as an early career fellow from DBT Wellcome Trust. And we are all aware of her excellent work in the IgA nephropathy field in India. And she is going to talk to us on a very interesting topic, which is on IgA nephropathy and how what are the outcomes and how do these outcomes, how can we achieve good outcomes without steroids? Now, this could either be focusing on conservative management, but I suspect that given her interest in renal genetics and molecular aspects of IgA nephropathy, she's going to talk to us about the advanced therapies that are going to come. So without much ado, I would like to request Susina to give us a talk and enlighten us on what newer therapies are there where we can avoid using steroids in IgA nephropathy and still achieve good results.
Good evening, everyone. I think this is a pre-recorded talk, so I'm waiting for the organizers to load the PowerPoint.
We'll be playing your pre-recorded video, ma'am, in a couple of minutes.
Good evening and greetings from Christian Medical College, Vellore. I thank the organizers of Women India in giving me this opportunity and wish them success in organizing this first national conference. My topic for today is IgA nephropathy. Can outcome improve without oral steroids? We owe it to John Berger, a renal pathologist who first described IgA nephropathy way back in 1968. The management of IgA nephropathy patient starts with risk stratification as recommended by the KDIGO. So how do we go about risk stratifying the patient? The kidney biopsy is scored using the Oxford Mixed C classification. Further risk stratification of the patient uses clinical and histological data. KDIGO specifically recommends using the International IgA Prediction Tool that is freely available online. The clinical parameters that are used for risk of progression are mainly proteinuria, blood pressure, and eGFR. Proteinuria is shown to be a strong prognostic factor and has a dose-dependent effect when it's more than 1 gram per day. When the MES score is added to the clinical parameters, it allows for an earlier risk stratification and has the same accuracy as clinical data alone at 2 years of follow-up. The International IgA Nephropathy Network Risk Prediction Tool was published by Boba et al. In 2019 and is available online as a risk calculator. Among the biomarkers currently, there is none that is validated for clinical application. So I have used the online International IgA Nephropathy tool for risk prediction. I've entered the baseline, demography, clinical parameters, and histology scores. You can also decide the time duration for the risk prediction of your particular patient. But please note that as South Asians, we have to choose others in the race column because this equation has not been validated in South Asian IgA nephropathy. After having entered all these values, the calculator gives a percentage risk for a 50% decline in eGFR or progression to end-stage kidney disease for the time duration that you have selected. So what is the role of the risk prediction tool in the South Asian population? Now, GRACE IgA nephropathy cohort is the first prospective longitudinal IgA nephropathy cohort from the South Asian region, and we looked at the performance of this equation at 3 years of follow-up, longitudinal follow-up. The patients in the IgA nephropathy cohort were arranged in the ascending order of their risk profile. There were 201 patients, and this is shown along the x-axis. The risk profile was the percentage risk calculated by the International IgA Nephropathy risk tool at 3 years, and this is plotted along the y-axis. The red bars are the patients who attained actual composite outcome over a longitudinal follow-up of 3 years, which was defined as a more than 50% decline in EGFR, end-stage kidney disease, or renal replacement therapy. The green bars are the patients who did not attain composite outcome at 3 years of follow-up. The median risk prediction for the cohort by the risk equation was 18%. But if you look at the actual outcome shown at the top, about 9% of the cohort attained composite outcome below a median prediction of 18%, whereas 54% of the cohort reached composite outcome above a median risk prediction of just 18%. So this shows that the equation underestimates risk prediction for composite outcome in the Graves' IgA nephropathy cohort and in the South Asian region. When we plotted the ROC curve for composite outcome at 3 years, a score of more than 23% had 70% sensitivity and 80% specificity for detecting composite outcome in our population at 3 years. So what are the risk factors that are relevant in the South Asian population? We looked at the predictors of composite outcome in the Graves' IgNI cohort. So clinical and baseline laboratory parameters were measured in Graves' IgNI cohort at baseline, 6 months, 1 year, 2 year, and 3 years. The diagram to the left shows a mean arterial pressure. The red color denotes patients who attained composite outcome, and the green color are those who did not attain composite outcome, and it's shown at all scheduled follow-up visits up to 3 years. The blood pressure was optimized by up-titrating to maximally tolerated dose of RAS inhibitors, as well as by adding on other antihypertensives if required. When we look at the right diagram, most patients in this observational cohort received short course of steroids over 6 months, which was tapered and stopped, along with maximally tolerated RAS inhibitors. The 24-hour urine protein significantly decreased from baseline to 6 months in both outcome groups. But if you look closely, the people who had good outcome had less than 1.5 gram per day of proteinuria at 6 months and less than 1 gram per day of proteinuria at 1 year. Whereas patients who had bad outcome had another average nadir proteinuria which was more than 1.5 gram at 6 months. We performed an adjusted Cox proportional hazards model for identifying the independent risk factors for composite outcome in our cohort, and we identified a MEST T2 score, as well as measure 24-hour urine protein measured at 6 months of more than 1 gram per day, eGFR measured at 6 months of less than 60 ml per minute, and a rate of eGFR decline at 6 months of more than 5 ml per minute per year as significant predictors. There are two important things to note here. One is the laboratory parameters that are measured at 6 months were a much stronger predictor than laboratory parameters measured at baseline, which suggests that you require at least a 6-month optimization period for both pharmacological as well as non-pharmacological interventions. The second important point is that the strongest predictor for composite outcome in the South Asian cohort was the rate of eGFR decline of more than 5 ml per minute per year. So we need to keep in mind this data that is varied in the South Asian population when we talk about treatment strategies. The KDIGO body recommends enrolling patients, all patients in a disease registry. KDIGO further recommends optimal supportive care of at least 3 months, including blood pressure control, using maximally tolerated RAS inhibitors, lifestyle modification advice, and assessment of cardiovascular risk. If proteinuria remains more than 1 gram per day despite these interventions, all patients should be given an opportunity to enroll in a clinical trial. Patients with eGFR less than 30 ml per minute should continue to get maximal supportive care, and patients with more than 30 ml per minute should be advised immunosuppression based on an individualized risk-benefit profile. Blood pressure control and RAS inhibitor is a cornerstone for the management of IgA nephropathy. This was shown well in the STOP IgA nephropathy trial, which was a randomized trial for glucocorticoid versus placebo. And it so happened that 1/3 of the patients were ineligible to be randomized after a 6-month run-in phase of intensive optimization of blood pressure and with RAS inhibitors. KDIGO has grade 1B recommendation for using RAS inhibitors for proteinuria more than 0.5 grams per day. RAS inhibitors should be up-titrated to maximally tolerated dose or allowed dose and should be stopped only if the creatinine rises more than 30% or if there is refractory hypertension. Blood pressure control to be achieved in glomerular diseases should be less than at least 130 systolic and 80 diastolic. Monitoring of labs is very important when we up-titrate RAS inhibitors as this can prevent acute kidney injury or hyperkalemia in a prospective patient. Patients should also be counseled to withhold RAS inhibitors or diuretics when they are at risk for volume depletion to prevent acute kidney injury or hyperkalemia in such patients. Potassium-wasting diuretics or potassium-binding drugs can be used to reduce serum potassium in order to use RAS inhibitors optimally. The other non-immunological strategy is weight reduction in obese or overweight patients. It's been shown in a cohort of 331 patients with IgA nephropathy that overweight or obese patients are more likely to be hypertensive, have worse renal function, and higher proteinuria. These patients also have have a worse eGFR and a greater prevalence of chronic kidney disease stage 3 or more, though there was no difference in the endpoint of death or dialysis. The other lifestyle modifications that are pertinent to the management of IgA nephropathy is to restrict dietary sodium to less than 2 grams per day, to exercise regularly, and to advise strongly against smoking. Mineralocorticoid receptor antagonists can be used synergistically with RAS inhibitors, but hyperkalemia is a problem and needs to be monitored. There's a new class of drug which has changed the practice of nephrology, and these are the glyphosins. DAPA-CKD is the largest trial to date, which enrolled chronic kidney disease patients with and without diabetes. The eGFR was between 25 and 75 ml per minute, and they had a UPCR of more than 200 milligram per gram, and patients were on a stable or maximally tolerated dose of RAS inhibitors. There were 270 participants in this cohort who had IgA nephropathy, and 254 of these participants had biopsy-confirmed IgA nephropathy. The primary outcome, which was a composite primary endpoint, was significantly less in those IgA nephropathy patients who received dapagliflozin versus placebo. The baseline characteristics of patients in both the arms were similar with regards to age, eGFR, and proteinuria, as well as a proportion of patients who had diabetes or a history of heart failure. Leading experts in nephrology have pointed out limitations in this study with regards to treatment in IgA nephropathy, as at 32 months, 24% of the placebo group exhibited the primary endpoint, and this was not in keeping with the usual prediction models. There were participants who died and were hospitalized for cardiovascular causes. There was no run-in period for RAS inhibitors in this trial. Only 16 patients out of the 270 did not receive kidney biopsy. The use of immunosuppression was at the discretion of the treating physician. So glyphosate definitely has a very strong role in chronic kidney disease, especially in the setting of decreasing cardiovascular outcome, but a stronger evidence in IgA nephropathy is still awaited. Now coming to immunological therapy, the risk-benefit profile needs to be discussed with each individual patient before we start them on any of the immunomodulatory drugs. There's been a change in the position of KDIGO with respect to outcome measurements from 2012 to 2021, and KDIGO now recognizes proteinuria reduction to less than 1 gram as a good surrogate marker for improved kidney outcome in IgA nephropathy, and it's a reasonable treatment target. So what is the role of corticosteroids in the treatment of IgA nephropathy? Earlier smaller trials did show benefit, but these trials were flawed because there was no run-in period or optimization of RAS inhibitors before randomization, and the sample sizes were small. Treatment for 6 months still suggested there's a legacy effect with sustained reduction in the risk of progressive renal dysfunction. Subsequently, a meta-analysis of 536 patients in 9 trials did show that a proteinuria more than 1 gram per day had benefit with treatment of steroids, which decreased the risk of kidney failure, and the effects were dose dependent but associated with significant increase of adverse events. The 2 large randomized controlled trials that have happened in the recent decades, the first one is the STOP IgA nephropathy study, which enrolled 380 subjects. But after an intensive 6-month run-in period with RAS inhibitors, about 1/3 of patients did not qualify for randomization. Subsequently, 162 patients were randomized, and it was found that proteinuria reduced transiently at more than 3 years, but there was no significant difference in the rate of loss of kidney function, and there were more infections in the immunosuppression group. The testing study, which was a global study, targeted 1,300 patients and 5 years of follow-up. There was an interim analysis which was done at 262 patient enrollment at 1.5 years, which showed significant decrease in renal outcome, but there was an increase in serious infection, and the trial was prematurely stalled. Another interesting observation in the testing trial was that there were 26 patients who had GFR lower than 30 ml, and these also showed an improvement in their renal outcomes with steroids, but because it was a subgroup, it was underpowered to assess the efficacy and the toxicity of steroids, though it did suggest improvement in outcomes. The major concern in testing trial that led to its premature stopping was the occurrence of serious adverse event. There were 28 serious adverse events, about 15% in the steroid group versus 3.3% in the placebo group, and there were 2 fatal serious adverse events, including one with pneumocystis pneumonia. So summarizing the evidence that was present till then, Valiga was the largest prospective cohort, and they suggested a benefit of steroids in patients, especially when proteinuria was more than 3 grams per day. In STOP IgAN, persistent proteinuric patients more than 3.5 grams per day were excluded from randomization, so it was not generalizable. Testing trial did show improvement in outcomes, but it was at the risk of serious infections. So this led KDIGO to change its position from the 2012 recommendation, which was grade 2C, where corticosteroids were recommended only for a eGFR of more than 50 ml, to a 2021 recommendation, which was grade 2B, where KDIGO suggested that patients less than 50 ml who were proteinuric despite maximal supportive care could be considered for 6-month course of glucocorticoid therapy after discussion of emergent toxicity with each patient. KDIGO also suggested the subgroups where it will be wise to avoid steroids, and these were patients who were diabetic, obese, or would have accelerated toxicity if given steroids. So the most common corticosteroid regimens that were used till now were either bolus injections of methylprednisolone followed by oral steroid, or oral steroids alone, which was given for 0.8 to 1 milligram per kg per day for 2 months and then subsequently tapered and stopped over 6 months. So then came the testing trial, the low dose. The two rows show the full dose testing trial in the top row and the low dose testing trial in the bottom row. A testing trial had planned to recruit 1,300 IgA nephropathy patients. But if you look at the top row, after recruiting 136 patients in the corticosteroid arm and 126 patients in the placebo arm, the trial had to be discontinued as there was a significant increase in serious adverse event. This is a global trial, though majority of patients were Chinese. So after a change in or an amendment in protocol, the low dose trial started, wherein patients were given 0.4 milligram per kg per day with a maximum of 32 milligram per day of oral methylprednisolone, and they were weaned by 4 milligram per day per month. In the low dose trial, they further recruited 257 patients in the corticosteroid arm and 246 patients in the placebo arm. There was a significant reduction in the combined endpoint in the corticosteroid arm compared to the placebo arm. Though there was an increase in adverse events in the steroid arm, it was much less than the full dose study. This again was a global recruitment, though majority of patients were Chinese. So what are the strategies that we need to improve outcomes in our population? Do we really need oral steroids, or is non-immunological therapy enough? Or are there any other immunological therapy that can counter or decrease the side effects that we see with steroids? Now, this is a biomarker evaluation that we have done in the Grace IgA nephropathy cohort. The diagram to the left shows the serum galactose deficient IgA1 levels, which were measured in the cohort at baseline 1 year and 2 year. We did see that with a short course of steroids, there was a significant decrease in serum galactose deficient IgA1 levels at 1 year. We also measured serum IgA levels in these cohorts, and the serum IgA levels also showed a significant decrease at 1 year. Both serum galactose deficient IgA1 and serum IgA levels were plotted, and they showed a parallel decrease at 1 year, and after 1 year there was a slow increase in the levels to baseline levels at 2 years. So what does this data suggest? One is there needs to be some immunomodulation apart from the hemodynamic benefits that we get from RAS inhibitors or the glyphosate class of drugs, as it is not just the hemodynamic parameters that may improve proteinuria, but there also needs to be some form of immunomodulation which may be given even longer term, but needs to have a better side effect profile. Now, there are certain specific populations where they consider tonsillectomy, especially in Japan, or in Chinese, there's been a benefit of mycophenolate mofetil as a glucocorticoid sparing agent. KDIGO has recommended against the use of all these classes of drugs because there has been no documented evidence of efficacy in IgA nephropathy. When it comes to fish oil, since it has tolerable side effect profile, it could be given, though there is no evidence, no strong evidence for efficacy. But even if it's given, it should be given in the dose that has been studied in randomized controlled trials. Again, KDIGO does not have evidence to support mycophenolate outside of the Chinese population, though I have to say here that there has been no such randomized controlled trial which we have looked at in a South Asian population. With regards to hydroxychloroquine, again, there's insufficient evidence outside of the Chinese population, though we have had small prospective RCTs in India which suggested benefits. The next decade or so is going to be very promising for IgA nephropathy treatment, as we have a very number of clinical trials that are looking at different drug molecules. These are looking at cytokines, cytokine inhibitors which will inhibit B cell proliferation. There are drugs that are looking to block toll-like receptors that will further inhibit B cell activation. There are drugs that are inhibiting the IgA production from the B cells. There are also molecules that are looking to inhibit the immune complex formation and its deposition in the kidneys. Also, there are complement inhibitors which are looking to inhibit the complement pathway and decrease the kidney injury. Some of the key ongoing phase 3 trials in IgA nephropathy include sparsentan, which is a dual endothelin angiotensin receptor antagonist, Nefecon, which is a targeted release budesonide, and it is in the phase 3 trial now. We have iptacopan, which is a factor B inhibitor, which is in the alternate complement pathway. We have atrasentan, which is an endothelin A receptor antagonist, and narsolimab, which is a MASP2 inhibitor. The results of sparsentan, which belongs to the DARA group of drugs, has been promising. The interim results show that there's been a 50% mean reduction of proteinuria from baseline, which is more than threefold compared to the active comparator. And this drug has been generally well tolerated, and there has been a submission for an accelerated approval pathway, which is expected in 2022. Nefecon, which is a targeted release budesonide that delivers budesonide to the Peyer's patches in the distal ileum, is another promising drug. Again, the interim analysis was presented in the WCN conference in 2021. At 9 months, the mean UPCR was reduced by 27% compared to the placebo group, and there was a significant treatment benefit on eGFR compared to the placebo. The overall incidence of adverse event was similar in both the groups, and this drug has also been submitted for accelerated approval with the FDA in 2021. The interim results of iptacopan, which is a factor B inhibitor, also was showing promise, which was presented in the ERA-ADTA conference in 2021. The primary endpoint, which was measured in 112 patients, showed a statistically significant response effect on reduction in proteinuria as compared to placebo at 90 days. And the highest dose of 200 milligram twice daily showed a 23% reduction in proteinuria. And there was also a trend observed towards stabilization of kidney function with favorable safety and tolerability. Atrasentan, which is an endothelin A receptor antagonist, also has been studied extensively in diabetic kidney disease, where they have shown significant reduction in proteinuria as well as reduction in the clinical outcomes of end-stage kidney disease and doubling of serum creatinine. Then the drug is being studied in a phase 3 clinical trial in IgA nephropathy patients. MASP2 inhibitor is in the phase 2 clinical trial, has shown overall promising results. The other treatment strategies that have been studied, that are being studied in phase 2 and phase 3 trials are ACTH, which is Actar gel, a purified form of ACTH, bortezomib, which is a proteasome inhibitor, fostamatinib, which is an oral spleen tyrosine kinase inhibitor, which prevents the downstream kidney injury after deposition of the immune complex, and atacicept, which binds to APRIL and BAFF receptors and prevents the B cell proliferation. This drug has shown promising results in phase 2, and there are many phase 2 and phase 3 trials ongoing with different formulations of this drug. So to conclude, renal outcomes can definitely be improved without the use of oral steroids, but when it comes to immunomodulation, which is also necessary for populations like the South Asian region, where there is a rapid progression to end-stage kidney disease, and there is an immunological basis for kidney injury, not just hemodynamic. We will require the use of immunomodulation with or without steroids, which has a tolerable and good safety profile. Thank you.
Over to the chairpersons. Madam, kindly unmute yourself. Dr. Nandita Chaudhary, madam. Unmute yourself. Professor Nandita Chaudhary, madam, kindly unmute. Yes.
I'm audible. Am I audible?
Yes, ma'am. Now you're audible. Madam, please unmute. Professor Nandita Chaudhary, madam, please unmute yourself.
Dr. Basu, would you like to take over? Because I think there are issues with Dr. Nandita. Yeah. Basu, you're not audible. Why is Basu not audible?
Yeah.
Yeah. Basu can't hear you.
He's not muted and yet he's not audible.
Yeah, there must be some
Other technical issues.
Technical issues. Susina, Dr. Umesh, sir, you want to comment on something on this presentation from Dr.
Excellent presentation, great take-home points, and I think she's brought out very well the role of non-steroidal therapy, at the same time when and where to use steroids and when not to use steroids. Very impressive talk.
Thank you, sir.
Susina, one question. What are the immunomodulations you think will be appropriate for India? What about hydroxychloroquine and in our setting?
Yeah, I think we need to study all these drugs in a randomized control multi-center way, because there is scope that all these drugs can reduce proteinuria and have tolerable safety profile. So hydroxychloroquine, mycophenolate mofetil, all these are drugs that needs to be studied in a multi-center RCT.
Sure. And I think budesonide is quite a few people are using it now in India also.
Yes, sir. But that's the gastrointestinal formulation.
Yes,
That's not the
yes.
WINICON formulation. So it's slightly different. The two
Different.
formulations are different.
Sorry to interrupt. I think we are 20 minutes delayed schedule, so we have to wind up this session.
Sure.
If there are no further queries, I'm sorry, we're not able to hear Dr. Basu. If you can have last comment from him, I think we can close after that.
You hear me now?
Yeah. Ultimately,
Oh,
we could,
fantastic.
yes.
Okay,
Yes. We were like,
sorry, IT issues. 3 years into e-meetings, we still struggle with Zoom, don't we? Susina, that was a really wonderful talk. Really summarized the whole issue as to what treatments are available and how newer therapies are coming up. And you're also corroborated the very interesting molecular diagnostics relationship with the outcomes. We've always learned that IgA nephropathy in the South Asian cohort behaves very aggressively compared to the other group, and traditionally, even before the RCTs, many of us have used steroids and sometimes with sparing agents like MMF or azathioprine with variable side effect profile. So amongst the newer agents that are being studied, which one do you think holds promise in terms of likelihood of pathophysiologically at least likelihood of achieving that treatment outcome?
So let me answer this in a few points. One is there are non-immunological therapies that are being studied, as well as there are immunological therapies that are being studied. When you look at non-immunological therapies, there is a limitation to the number of drugs that you can add on without a significant having significant hypotension or other side effects. So it might be a combination of endothelin receptor or angiotensin receptor blocker, or it might be a combination of glyphosate or angiotensin receptor blocker. But there is a limitation to the number of drugs that you can add on just to have a hemodynamic benefit. When we come to immunological therapies, the most promising ones will be the one that act upstream in the pathophysiological pathway, rather than very downstream at the kidney tissue level. So the molecules that are being studied upstream in the pathophysiological pathway right now are the ones like APRIL and BAFF. That inhibit the cytokine production as well as B cell proliferation. Also, there are certain complement inhibitors that are being studied, but again, complement inhibitors come with their own side effect profile. And especially in a country like India, where there's a whole lot of risk for infection, we need to be a little cautious on using complement inhibitors, as complement is also required in some amounts for your normal biological systems.
Thank you very much. And I heard that there's not much more time. If there's any other questions.
Questions will be answered in the chat box. So we'll close the session. Thank you so much, all the speakers and chairpersons, for enlightening us about steroid use in IgA nephropathy. Thank you so much. We now move on to the evening session.
Good evening, everyone. Moving on to the next session for the day by Dr. Anupama YJ on the topic sudden death in patients with end-stage renal disease. I would like to invite the following respected chairpersons. I welcome Dr. Umesh Khanna, Director of Kidney Associates, Consultant Nephrologist at Asian Heart Institute, at Karuna Hospital and Suchak Hospital, who also holds the prestigious positions of Chairman of Mumbai Kidney Foundation, Secretary of Mumbai Nephrology Group, Project Coordinator of G1 Sparsh, and with special areas of interest in community dialysis, nephrourology, and preventive nephrology. Welcome, sir. Joining him will be Dr. Vinan Bhargava, Senior Consultant Nephrologist, at Sir Gangaram Hospital, New Delhi. I request the chairpersons to take over the session and kindly introduce the speaker.
Good evening, friends. And on behalf of my co-chairman, Vinant Bhargav, I would invite Dr. Anupama to give her talk, which is very important topic. And unfortunately, it's in the news these days. We heard the singer KK, sudden death. We heard Raju Srivastav now admitted in a very serious state. So even in the non-CKD population, exercise and sudden death and other areas are in the news. And of course, we know from our dialysis experience that almost 29% of this is the USRDS data of dialysis patients have sudden death. So this being a very important topic, I think is in the fitness of things to have a discussion on this topic. And Dr. Anupama, who's got her interest in preventive nephrology, has a lot of work on CKDU. She's done a DNB in nephrology, has a lot of awards and recognition. Most importantly, today she's the editor-in-chief of Indian Journal of Kidney Disease, so Win India Journal, and making Win India proud. Over to Dr. Anupama for her talk.
Thank you very much, sir, for your kind words. My colleagues at Win India, please take a bow. It's been very interesting and very nicely going on. The conference is very nicely going on, and extremely proud to be part of Win India. Can we have this video, please?
Good morning, ladies and gentlemen, respected chairpersons, dear delegates and friends. At the outset, I'd like to thank Dr. Manisha for giving me this opportunity to speak in the inaugural conference, annual conference of Win India. I was asked by her to speak on sudden death in ESKD, and when I saw this topic, I was a little taken aback because we usually associate death with something sad, gloomy, or melancholy. To speak on death on the inaugural conference, and that too on this, to begin the second day's proceedings, seemed a little incongruous to me, and my first impulse was to ask her to change the topic or to change the timing, or both. But somehow I continued with it, and we know that death is inevitable, and as healthcare professionals, we also know that death is a metric for safety and efficacy of healthcare and efficiency of healthcare services. So it is something that we should be continuously dealing with death as healthcare professionals, and to measure death as a measure of our efficiency. So death in dialysis patients includes many causes. So in 1991, this report said that infections were the most major cause of death, but there were also other causes of death like withdrawal from dialysis, cardiac causes, and sudden death, vascular, and other causes. Those days, infections were the most important cause of death in dialysis patients, contributing to almost 30 to 40% of deaths. And withdrawal from dialysis contributed to 20% of deaths. Cardiac causes were a mere 14%. And sudden death was actually a fourth in this list of causes of death. However, sudden death has become much more commoner in these days, and more so in patients on dialysis. The incidence of sudden cardiac death accounts for more than 25% of deaths in some of the recent studies. To give a perspective, the incidence of sudden death in a general population is about 8 to 9%. There are other recognized causes of sudden death and need not necessarily be sudden cardiac death, and they include cerebral hemorrhage, pulmonary embolism, air embolism, aortic dissection, etc. And not only ASKD patients, even non-dialysis CKD patients have a higher risk of sudden death when compared with the general population. Some of the observational data suggests that sudden cardiac death varies from country to country and region to region. The Dialysis Outcomes and Practice Patterns Registry reported that the incidence of sudden cardiac death was about 33% in the United States, while 23% in Japan, 19% in Australia, New Zealand, and Canada was reported 18%. So the sudden cardiac death varies from country to country. Probably it is because of the differences between the data recording practices, different dialysis practices, and also may be attributable to different baseline characteristics of these patients, these countries. So what is the definition of sudden cardiac death? It must be remembered that there is no universally accepted and precise definition of sudden cardiac death. One of the definitions that is accepted is it is a natural, rapid, and unexplained cardiac death within an hour of symptom onset. Some of the newer definitions which have come up is sudden cardiac death may not be always witnessed, and there can be, so it is difficult to say within 1 hour of the symptom onset. Some of the deaths may be even unwitnessed and occur at home, and the medical practitioner may not have actually witnessed it. So sudden cardiac death is now defined as an unexpected death due to cardiac cause in a person with known or unknown cardiac disease within 1 hour of symptom onset, that is witnessed sudden cardiac death, or within 24 hours of the last proof of life, that is unwitnessed sudden cardiac death. Since cause of death is subject to inter-observer variability, there can be misclassification of death. The European Dialysis Working Group distinguishes between extradialysis sudden cardiac death and intradialysis sudden cardiac arrest because they represent different clinical situations and should be kept distinct. The outcome of intradialysis sudden cardiac arrest may differ markedly from the extradialysis sudden cardiac death. The most important reason being the availability of medical services at the time of arrest. So the survival rate is more in intradialysis sudden cardiac death, cardiac arrest. So what is the significance of sudden cardiac death? The high short-term mortality is seen in almost all sudden cardiac arrest, and even in those patients who have survived an arrest, the 48-hour mortality is still very high and unacceptable at 60% in one of the studies. Those patients who have undergone, suffered a cardiac arrest and where the cardiopulmonary resuscitation has been started but without access to rapid defibrillation, they carry a high mortality of 92% in hospital death and 97% 6-month mortality. This is an interesting observation which was studied from the 2002 USRDS annual data report. The patients were classified into 4 groups. Group 1, where diabetes was the primary diagnosis of ESRD. Group 2 was diabetes along with other cause for ESRD. Group 3, where the diabetes started after the dialysis started. And group 4, there was no diabetes at all. As you can see, the cardiac arrest rates differ markedly between the 4 groups, and the diabetics always had a higher cardiac arrest rate. The group 1 had a higher cardiac arrest rate compared to the group 4. And even in those patients who have survived the cardiac arrest, the group 1 always did worse than the group 4. That is, they died much more commonly than group 4 patients. Some of the risk factors for sudden cardiac death can be classified into patient-related risk factors and dialysis-related risk factors and CKD related risk factors. Patient-related risk factors are mostly related to the cardiac disease that these patients have. A pre-existing cardiac disease predisposes them to sudden death. LV hypertrophy, which is almost universal in patients with ESRD, predisposes. LV dysfunction, systolic as well as diastolic, predisposes them to sudden death, and it has been recently seen that LV diastolic dysfunction is an almost equal contributor to sudden death. Recent acute coronary event is also another risk factor. The dialysis related risk factors are mostly related to the timing of dialysis and the dialysate concentrations. That, as we know that in thrice weekly dialysis, typically patients come to the dialysis unit on Monday, Wednesday, Friday or Saturday, and or on Tuesday, Thursday and Saturday. So sudden death is more common in the last 12 hours of the long interdialytic period, or it is also more common after the first dialysis after the long interdialytic period within the first 12 hours. So this carries the almost 50% increased risk compared to the dialysis which occurs on the other days. So the dialysis with low potassium baths, where the dialysate has 0 to 1 potassium potassium milliequivalent per liter, 0 to 1 milliequivalent per liter of potassium, carries more risk of sudden death than normal potassium. So this is another important observation which has been studied about the characteristics of sudden death, and the timing of death has been stratified into three proportions, that is between 0 to 12 hour interval after the long interdialytic period, between 12 to 60 hour interval of the long interdialytic period, and 60 to 72 hour interval, that means within the last 12 hours of the long interdialytic period. So here you can see that the deaths which occur between 0 to 12 hour interval are mostly related to the cardiac factors and the vascular factors. Patients have these patients are more having left ventricular low ejection fraction, congestive heart failure, coronary artery disease, peripheral vascular disease, left ventricular hypertrophy, stroke, diabetes mellitus, etc. Whereas deaths which occur in the last 12 hours of the long interdialytic period, that is the third column, these patients have more, this is more related to the potassium. So high serum potassium, high beta blocker usage, frequent non-compliance, these are more common in the last 12 hours of the longer interdialytic period. So the beta blocker usage is the most significant factor here, and although beta blockers are known to reduce the risk of cardiovascular deaths, here it is mostly related to the hyperkalemia that the beta blockers induce. So hemodialysis as well as PD, there is an increased risk of sudden death, and it has been studied that there is as high an incidence of sudden death in PD as well as in HD, although the difference may not be statistically significant. This is more illustrated in this, that in the first 1 or 2 years after the starting of PD, the risk of sudden death is quite low, whereas with the passage of time, as the years advance, there is the curves cross and there is an increased risk of death with the PD. The dotted line indicates sudden death with PD, whereas the complete line indicates sudden death with HD. So there is a marked increase in the sudden death with PD patients after 2 to 2.5 years after starting PD. But coming to the pathophysiology of sudden death is mostly related to the arrhythmias which occur during or just after dialysis. But it also needs a vulnerable heart for the causation of arrhythmias. We can see that the arrhythmias are directly related to the fluid and electrolyte imbalance, mostly electrolyte imbalance related to the dialysis, that is either high or low potassium predisposes to electrolyte imbalances, as well as low calcium predisposes to arrhythmias. But for these arrhythmias, electrolyte imbalances to occur, there must also be an additional arrhythmogenic substrate in the form of either decreased LV systolic function, LV hypertrophy, and myocardial ischemia. We must remember here that myocardial ischemia in CKD patients is not always macrovascular disease. It could even be microvascular disease, and you cannot demonstrate it on coronary angiogram. So Also, there may be at rest, there may be no ischemia, whereas when the patients exert, there is a demand supply mismatch, and especially in the presence of left ventricular hypertrophy and calcific blood vessels, the vessels cannot match the demands of the patient, and that results in ischemia. And this ischemic heart is more susceptible to arrhythmias when the electrolyte imbalances occur. So these are the uremic risk factor or uremia related risk factors. Uremia predisposes the patients to various changes in the heart as well as other systems of the body, and these in turn may directly cause the patient to be at high risk for sudden cardiac death. For example, the structural changes in the heart includes myocardial hypertrophy, myocardial fibrosis, there is endothelial dysfunction and vascular calcification, which directly are related to the sudden death, increased sudden death in ES cardiac patients. Patients also have high risk of uremic cardiomyopathy. There is high inflammatory milieu. There is a sympathetic overactivity, and decreased vagal tone, all of which cause sudden cardiac death. There is also an electrical remodeling. The patients, they have QTC prolongation, repolarization alteration, myocardial stunning, and ventricular arrhythmias are more common because of myocardial stunning. Some of the dialytic triggers include electrolyte shifts, high rate of ultrafiltration, and the hypotension, which often occurs during dialysis, causes the stunning of myocardium, resulting in predisposition to arrhythmias. These patients also commonly have iron overload, and this can lead to conduction abnormalities. The reduced baroreflex sensitivity and baroreflex effectiveness index also results in increased sympathetic tone and resulting in arrhythmias. So this has already been pointed out earlier that excessive fluid and electrolyte shifts associated with dialysis predisposes them to arrhythmias. And the longer interdialytic period is associated with higher serum potassium, whereas sudden deaths after the first dialysis of the longer interdialytic period is linked to lower serum potassium. That means there is an excessive gradient between the serum potassium and the dialysate potassium, which predisposes them to arrhythmias. PD patients, on the other hand, though they do not have excessive fluid, the excessive gradient between the PD fluid and the serum dialysate concentration, the potassium concentration, the increased risk is due to the lower serum potassium, which is with lower baseline serum potassium that these patients tend to have after a few years of PD. The exact rhythm disturbance is usually not demonstrable if the patient is not on an implantable device or if the patient is not on some form of continuous monitoring. So if the patient has been on a wearable cardioverter defibrillator, the exact rhythm disturbance can be correctly recorded, and most often it is ventricular fibrillation, whereas in 22% of the times it is asystole or pulseless electrical activity. Bradyarrhythmias are more common than previously thought, and especially so in patients with chronic kidney disease and end-stage renal disease. Whereas in general population, it's more likely to be a ventricular fibrillation. Some of the other high-risk conditions which predisposes them to sudden death include diabetes, obstructive sleep apnea with the increased sympathetic tone, and aortic stenosis. In the dialysis practice, we know that excessive ultrafiltration predisposes the patients to hypotension, and which in turn, when the patient is already having a predisposing cardiac illness, that can cause sudden death. It has been proposed that ultrafiltration volume should not exceed more than 5.7% of the per kg of the patient's body weight. But in dialysis, it is hard to actually do because most of the patients come with significant fluid overload, and we may have to do larger ultrafiltration removal at times. The dialysate potassium and dialysate calcium are important determinants of the patient's tendency to develop arrhythmias, and especially there should not be a large gradient between the serum potassium and the dialysate potassium, as well as between the serum calcium and the dialysate calcium. Whenever this dialysate calcium is at a lower level, for example, 1.5 to 1.75 millimoles per liter, then that predisposes the patients to arrhythmias. Similarly, when there is rapid correction of the metabolic acidosis, the alkalotic milieu, that is increased binding of the calcium to plasma proteins, resulting in a low serum calcium levels. Again, that can result in arrhythmias. Similarly, low serum magnesium, low dialysate magnesium levels are also linked to increased risk of arrhythmias. So coming to the prevention of sudden cardiac death, to prevent sudden cardiac death, we can do it either we have to implement measures to reduce the risk of sudden cardiac death, and secondly, in a patient who has already developed a sudden cardiac arrest, we have to employ therapies that increase the chances of surviving a cardiac arrest, and further on that decrease his chances of developing a second cardiac arrest. So how to identify patients at high risk of sudden death? It could be clinical, in which some of the parameters we already mentioned. Patients should not have large interdialytic weight. Patients who have had a recent ACS, cardiac disease, diabetes, extremes of age, extremes of electrolytes are all important predisposing factors and high risk situations for patients to develop sudden death. Biomarkers like C-reactive protein, interleukin-6, adiponectin, etc., which suggests a high inflammatory state. Nutritional markers like low pre-dialysis serum albumin, low serum creatinine, which suggests a poor nutritional state. All these are important risk factors, important indicators to suggest that these patients are at high risk. Cardiac biomarkers like troponin and NT-proBNP, if they are significantly elevated, that also suggests that these patients are having a predisposition to cardiac problems. It must be remembered here that mild elevations in troponin and mild elevations in NT-proBNP is common in patients with chronic kidney disease, even without cardiac disease. So some of the cutoffs that have been employed are more than 99th percentile of troponin I and troponin T, as well as NT-proBNP level has been suggested that it could indicate a high risk for cardiac events. In the ECG, if there is a widening of QRS, prolongation of QT interval, and QT dispersion is very wide, then that suggests that these patients are at high risk. In echo, LVH, there is increasing hypertrophy, increasing degree of hypertrophy on serial echoes, left ventricular mass index. All these are important indicators for high risk. If autonomic dysfunction has been examined for, then there could be an increased heart rate variability, which suggests an increased risk. So coming to the prevention or the risk reduction measures, drugs like beta blockers, ACE inhibitors, ARBs, calcium channel blockers are important considerations. Beta blockers especially are important to prevent the risk of sudden death. One of the important drugs that has been employed in this is the carvedilol. The ACE inhibitors, ARBs, also could reduce risk of sudden cardiac death, although it has not been studied to the extent of beta blockers in patients with end-stage renal disease. It's well known that aldosterone predisposes to or causes or is an important contributor to the myocardial fibrosis, and so by blocking the aldosterone renin-angiotensin aldosterone system, the myocardial fibrosis could be prevented. High angiotensin levels also is an important pressor and could cause LVH, and that could also be prevented. Calcium channel blockers they can also block the calcium channels in the heart and lead to better ionic milieu, so that arrhythmogenicity is avoided. Coming to the dialysis risk reduction strategies, we have to limit the serum potassium to dialysate potassium gradient, limit serum calcium to dialysate calcium gradient, limit the UF volume in each setting. We could increase dialysis frequency. We could do short daily hemodialysis or nocturnal hemodialysis are other strategies to avoid sudden death. Implantable cardioverter defibrillator is another important weapon in the fight against sudden cardiac death. It is in the indications for use of implantable cardioverter defibrillator. This is actually from the non-ESKD population. These guidelines are from the non-ESKD population, because most of the randomized clinical trials for ICDs avoid patients on or exclude patients on end-stage kidney disease, and they are never considered for trial purposes. So these guidelines are actually extrapolated from the non-cardiac, non-ESRD cardiac patients. So for the implantable cardioverter defibrillator, the primary prevention, it could be used in patients with ejection fraction less than 35%, and those people who have a chance of survival of at least more than 1 year, it should be used. And the secondarily, to in those patients who have survived and already survived a event of ventricular fibrillation or ventricular tachycardia, in the absence of reversible causes, it should be installed. Results for primary prevention in ESKD using ICDs are diverse, and some of the studies indicate that there is a 60% reduced risk of arrhythmias with the use of implantable cardioverter defibrillator, whereas some of the studies have recorded no difference, and some of the recent trials that have been used in this is ICD-2 trial, which has examined the utility in those patients who have ejection fraction more than 35% also. However, this trial was terminated midway because they did not find much difference between those patients with ejection fraction more than 35%. It could not demonstrate any significant benefit for reduction of sudden death in these patients. Why this is so is because we must remember that the sudden death in CKD is not always due to ventricular fibrillation, and there could be a non-shockable rhythm like pulseless electrical activity or asystole, and also there are other complications of ICD placement which precludes any significant benefit which could derive from ICD placement. So there could be risk of bleeding, there could be risk of infection, and all these the leads may be displaced, and all these kind of situations result in extra risk of ICD itself, so which balances any significant benefit that could have been derived from ICD. And in the Indian situation, the important reason why ICDs are not common is because of the exorbitant cost. So this again illustrates the difference between the effectiveness of ICD in various arrhythmias. In ventricular fibrillation and ventricular tachycardia, ICD is usually effective in arrhythmia termination, and it could be potentially effective in extending survival of patients, whereas in patients who have had a pulseless electrical activity or a asystole, ICD is ineffective in both arrhythmia termination as well as in extending survival. A management of sudden cardiac arrest in the dialysis unit is better if there is the dialysis staff has already been given BLS training, and they are well trained to handle any emergency of an arrest. And also there must be an automatic external defibrillator if it is available in the dialysis unit. Then if the staff has been able to employ the AED even before emergency services has been obtained, then there is the studies have recorded that there is an increased chance of survival in such patients. So to conclude, sudden cardiac death is common and accounts for nearly 30% of deaths in dialysis patients. It includes both in-hospital arrest and out-of-hospital sudden cardiac death. Both abnormal cardiac dynamics and dialysis factors enhance the risk. Other factors unique to CKD also contribute to the increased risk. Beta blockers reduce the chance of sudden cardiac arrest, and BLS training to staff, AEDs, and ICDs may improve the chance of survival from a sudden cardiac arrest.
Thank you, Anupama, for covering.
I thank the organizers again for giving me this opportunity. Thank you.
Thanks, Anupama, for covering this important topic and on time. Before Vinant asks a question, I will ask basically my comments on the drug part, which you mentioned, that you did talk about the drugs which help preventing sudden cardiac death. But these days we see a lot of usage of azithromycin, clarithromycin, quinolones for respiratory infections, and even for viral infections, people use it indiscriminately. These drugs which have QTC prolongation, and they have used in all our patients also frequently, make them prone to develop sudden arrhythmias and sudden cardiac death. Not to forget lenoxin, Cardaron, and other antiarrhythmic. And some of them would be on antidepressants and antipsychotics, and some of them would be on prokinetics, and occasionally people on antifungal drugs. So all these drugs create a milieu where if there are other reasons which you elucidated on the dialysis factors and cardiac factors, then these drugs would add on to the risk of sudden cardiac death. And you very rightly pointed out the obstructive sleep apnea, which is another area where we see a lot of sudden deaths. Vinant, over to you.
Yes, thank you, ma'am. It's a very extensive review of the topic, which you've very beautifully covered for all the students over here and all the faculty here on the incidence and the risk factors and how to identify the risk factors and prevention strategies especially. My single comment would be that we see a lot of sudden cardiac death in our unit secondary to hypoglycemias, especially in our setup in which we have patients who are diabetics, and some of these patients are even malnourished. So they would come for a dialysis session and not take their food and then have hypoglycemia and have sudden death. There are some questions in the chat box, if I may be permitted to take them. So can I just take these questions?
Sure, please.
Yeah. So we have one question from Dr. Urmila Anand, who's asking us about the role of hyponatremia, that is sodium, and it's associated with sudden cardiac death. And there's another question which is also pertaining, which is about sudden cardiac death, whether there's an association of increase in intradialytic weight gain versus the role of excessive ultrafiltration. If you can just give your comments on that.
Sodium per se, to my knowledge, it has not been studied in sudden cardiac death, or at least not been reported in sudden cardiac death. But again, the gradient between the serum sodium and the dialytic sodium, I would think it's important to not to have too rapid a shift and too large a gradient, so that any rapid shift of serum sodium again would precipitate some arrhythmias. And second thing, with respect to sodium, I would like to highlight, I'd like to point out here that in case of sodium profiling, when there is, again, that will predispose to larger weight gains. So with respect to sodium, I think that is also to be remembered. Sodium profiling is to be avoided in patients who are at risk of sudden cardiac.
I think Dr. Kashi's answer would be probably, yeah.
Second question again on the weight gain. Again, it's rapid. When the patient comes with weight gain and suddenly the weight is, the dialysis volume, the ultrafiltration volume is kept to such an extent that the fluid is removed, then that is a precipitant, I would think, not the weight gain per se.
No, maybe Dr. Kasi feels that if you give a long nocturnal dialysis and remove that same weight gain over many hours, with a lesser ultrafiltration, maybe the sudden cardiac death would not occur. Yeah, maybe that's what he's asking.
Yeah.
Prolonged dialysis to remove the same weight gain vis-a-vis short dialysis and massive ultrafiltration.
Sorry to interrupt. We are actually running half an hour.
Right. Okay, I think with that, as me and my co-chairperson would thank Dr. Anupama for the excellent presentation, and thank WIN India for giving us an opportunity to be a part of such wonderful conference. Vinant?
Thank you very much. This is a very nice perspective with WIN India, and we look forward to more participation and more educational content from this organization. Thank you very much.
Thank you all. Yeah.
Thank you very much.
Thank you, everyone. Thank you, ma'am, for the interesting and educating talk. We would like to move on to the next session now. Coming up is the session on new therapeutics for diabetic nephropathy by Dr. Priyam Vada. Chairing this session are Dr. Noble Gracious, Associate Professor of Nephrology at Government Medical College, Trivandrum, also the State Nodal Officer of KNOS, Kerala. Also joining him will be Professor Dr. R.K. Sharma, Head of Nephrology at Medanta Medicity, Lucknow, former Professor and Head Nephrology and former Director of SGPJ, Lucknow, and also Professor Dr. D. Sribhushan Raju, Professor and Unit Head Nephrology, NIMS, Hyderabad, current Secretary of PDSI. Welcome, sir. We welcome you to the dais. I request the chairpersons to kindly take over the session and introduce the speaker, Dr. Priyamvada.
Thank you, organizers of Women in India Nephrology Conference. It is indeed privileged to be the part of this conference. I proudly introduce Dr. Priyamvada, who is actually a pride of Kerala as well as and pride of India too. Now, with her research publications and his articles, academic acumen, has shown the world women can lead India in nephrology too. Over to Dr. Priyamvada, and if other chairperson would like to comment on some, she's now Professor and Head of Department of Nephrology, Jimmer. Thank you, and please, Dr.
Good afternoon, everyone. At the outset, let me thank the WINICON team for extending the invitation for this lecture on new therapeutic options for diabetic nephropathy. We know that diabetes is a relentlessly progressive disease. And at any given point of time, around 20 to 40% of those with diabetes eventually reach ESRD. The most common trajectory taken by most of the people is the progress to microalbuminuria, then overt proteinuria, followed by a decline in GFR, and eventually reaching ESRD. Alternate trajectories are also possible. Some people progress to advanced kidney failure in the absence of proteinuria, and some of them show a rapid decline right from the beginning. And fortunately enough, some of the persons with diabetes will show a regression of albuminuria also. Traditionally, the two approaches to prevent the progression of diabetic kidney disease relied on management of hyperglycemia, then the renoprotective medications which used to target albuminuria and eventually targeting the reductions in GFR. And this used to be sort of two watertight compartments till recently. Now, thankfully, we are having drugs which target hyperglycemia and at the same time have renoprotective effects as well. The first and foremost of this is the SGLT inhibitors. SGLT is a group of transporters which are concerned with glucose transport. It's present in the gut as well as the kidney. The transporter present in the gut is SGLT1, which reabsorbs 2 sodium against 1 glucose molecule. And in the proximal part of the kidney, in the proximal convoluted tubule, there is a transporter SGLT2, which reabsorbs 1 sodium against 1 glucose. And as we move down, we have the SGLT1 again in the kidney, which reabsorbs 2 sodium against 1 glucose. So normally, the major chunk of the glucose reabsorption in the kidney is done by SGLT2. In states of health, it accounts for around 97% of the glucose reabsorption. And SGLT1 plays only a minor role, accounting for around 3%. Now, when this SGLT2 is blocked, so this glucose reabsorption, some amount of glucose reabsorption can still happen via SGLT1, but still eventually around 60 to 70% of the glucose reabsorption will be blocked if we are able to block the SGLT2. So to begin with, we had molecules which block the SGLT2 receptor alone, and now we have molecules like sotagliflozin which can block the SGLT2 as well. So probably an additive glycemic effect by reducing the intestinal glucose reabsorption and also enhancing the renal excretion of the glucose. Now, SGLT blockers, in addition to glycemic control, it confers direct as well as indirect renoprotective effects. So the SGLT is blocked, so around 60 to 70% of the glucose reabsorption from the kidneys are blocked. This translates to a glucose excretion of around 50 to 75 grams per day. So as a result of this much amount of massive glucose loss, the glycemic control is going to be better. And another important thing which happens is it creates a state of relative glucose deficiency. So as a result, lipolysis, fatty acid oxidation and ketone body formation is enhanced. So basically the cellular metabolism is switched more towards an energy efficient mode. And because of this massive glucose loss, there will be weight loss, which again will reduce the insulin resistance. And the amount of glucose reabsorbed by the tubules is going to be much more lower because the SGLT2 channels are blocked. And as a result, the tubular mitochondrial stress and the tubular injury is actually prevented. And because there is a large amount of sodium which is lost accompanying the glucose, this actually reaches the juxtaglomerular apparatus, which activates the tubular-glomerular feedback. So some amount of afferent renal vasoconstriction is happening. So this will reduce the intraglomerular hypertension as well. And in addition, the SGLT2 blockade offers multiple antifibrotic properties as well. So there are other indirect benefits also. Predominantly, the glomerular filtration is modulated by afferent arteriolar constriction, that is by enhancing the tubulo-glomerular feedback. An efferent mechanism like the way RAS inhibitors behaves is also reported with SGLT2 blockade. And SGLT2 blockade is associated with reductions in sympathetic flow, and it is also believed to reduce RAS activity and weight loss, which will actually reduce insulin resistance. Uric acid levels are reduced and hemoglobin levels are also improved. SGLT2 blockade has direct cardioprotective effects as well. So it reduces the left ventricular hypertrophy, it reduces the cardiomyocyte apoptosis, it improves the myocardial energetics and the metaharmonics, and improves the myocardial and ECM remodeling. So it also leads to reduction of the myocardial inflammation and various inflammatory cytokine levels as well. So this is in a nutshell how SGLT2 blockade offers cardioprotection, and this cardioprotection can be mutually inclusive as well. So there could be direct cardiac effects as well as direct renal effects. Then the effects on hyperglycemia, osmotic diuresis, and natriuresis. Eventually, there is a significant renoprotective effect and cardioprotective effect, which tends to protect each other. Now, coming to the major trials with SGLT2 blockades. Almost all the trials have shown that SGLT2 blockers are associated with a reduction in major cardiovascular endpoints. And most of the initial studies were cardiovascular outcome studies, and subsequently there are renal outcome studies as well. And analysis has shown that this cardiovascular benefit extends to renal outcomes as well. So most of the studies have shown that SGLT2 blockers are associated with renoprotective effects as well. And if you can see, most of the initial studies were in people who had atherosclerotic vascular disease or their equivalents. And if we analyze the data, we can see that most of the protection is afforded in people who are at risk for either CKD or at risk for cardiovascular diseases. Whereas when it is used as a primary prevention, the picture is not that very clear. It appears that SGLT2 blockade works better when actually already some damage is there. Now, the current indications for SGLT2 inhibitors include people with type 2 diabetes who are at high risk for atherosclerotic cardiovascular disease, or who have established cardiovascular disease, or patients with type 2 diabetes and heart failure, or patients with type 2 diabetes and chronic kidney disease. There are a few concerns about the SGLT2 blockade as well. And this include the decline in GFR, because SGLT2 blockade is something which is able to manipulate the renal vasculature. So tubulo-glomerular feedback is enhanced. So this may lead to transient declines in GFR. And the worst case scenario, the osmotic diuresis and the vascular reductions in the vascular flow can even precipitate acute kidney injury. The other concern is a major glucose load is excreted through the kidney, and this might lead to genitourinary infections. And there is a risk of diabetic ketoacidosis because of the insulin deficiency, as well as the low blood glucose levels. And the initial studies has reported high risk of amputation, bone fractures, etc. Now, coming to the decline in GFR. The most important mechanism by which SGLT2 blockade reduces the decline in GFR is by activation of the tubulo-glomerular feedback. And some amount of efferent arteriolar dilatation, like the way RAS blockade creates, also is reported. The mechanisms are not clearly known. And almost all the SGLT2 studies have shown that around 3 to 6 ml reductions in GFR occur in the initial few weeks of starting SGLT2 blockade. But the reassuring fact is that this decline in GFR is not sustained. Usually, this is maximum happening at around 30 days of time or 4 weeks, and following which, in the subsequent year, there is a gradual increase in the GFR. And eventually, compared to placebo over a course of years, the GFR associated with SGLT2 blockade appears to be somewhat higher. And this is basically some projections based on data from the CREDENCE trial. So as you can see, there is a rapid decline following initiation of SGLT2 blockade, but eventually, somewhere around 12 months, the GFR decline actually is somewhat better compared to people who are maintained on RAS blockade alone. So people who are maintained on RAS blockade alone, the anticipated decline in GFR is around 4.6 ml per year, whereas in patients who are maintained on RAS blockade with SGLT2 blockade, it's only 1.85 ml per year. This actually translates to an additional 15 years of freedom from ESRD. So So it is recommended that when we start on AC inhibitors, it is recommended to check the RFT after 4 weeks of starting AC inhibitors. And if the serum creatinine increments is less than 30%, probably we can continue SGLT2 blockade. But if the increment is more than 30%, we have to see for factors like volume depletion, ketosis and all. And if any of this exists, this has to be corrected. If the increment is more than 30%, probably, and if you are not able to identify any correctable factors, we will have to discontinue SGLT2 blockade. And it is recommended that patients should be clinically euvolemic, and at the time of initiation of SGLT2 blockade, we should not add other drugs, like we should not escalate the dose of other drugs like diuretics or AC inhibitors, which are likely to alter the renal hemodynamics. Now, the other concern was the massive volume losses which are associated with SGLT2 blockade. Probably with altered renal hemodynamics, it can precipitate acute kidney injury. And the initial studies on SGLT2 blockades gave a picture like some amount of acute kidney injury happens. But subsequently, on subsequent analysis, this risk of acute kidney injury was not found to be so great with SGLT2 blockades. And we do have some real world data which has compared SGLT2 blockade with the other oral hypoglycemic agent uses. And after adjusting for multiple confounders, it was found that there is no significantly increased risk of acute kidney injury with SGLT2 blockers. Then again, the initial studies with canogliflozin has shown that SGLT2 blockers are associated with increased bone fractures. So the exact mechanism again is not known. So it is believed that probably some amount of enhanced phosphorus retention happens, and phosphorus loss happens, and probably some amount of changes in the parathyroid dynamics happens, and probably this is supposed to be the reason why the patients develop bone fracture. But subsequently, again, large population data has shown that the risk of bone fractures with SGLT2 blockade is not that much higher compared to other agents like the GLP-1 receptor agonist and DPP-4 inhibitors. Another major risk of SGLT2 blockade is diabetic ketoacidosis. So SGLT2 blockers are associated with increased glucose reabsorption, and they also lead to reduced insulin levels, and something which is unwanted is counter-regulatory hormone activation like glucagon. So glucagon increases lipolysis and pushes the liver into more ketogenic pathways, and again there is enhanced ketone body reabsorption from the kidneys as well. So fortunately, euglycemic ketosis is extremely rare in type 2 diabetes. And most often some precipitating factors like an acute illness will be there. Sometimes dietary changes, rapid reductions in glucose intake, or rapid reductions in the insulin prescription. Then patient fasting in the preoperative or postoperative stage, underlying malignancy, then some drug abuse, substance abuse, and pregnancy. Those are all the triggers which are likely to precipitate euglycemic ketosis. And fortunately, this is going to be extremely rare. And if any of these situations happen in a patient who is already on SGLT2 blockade, or if such circumstances exist, it's better not to start SGLT2 blockade de novo. Then moving to the next group of agents, that's incretin mimetics. Incretins are a group of gut-derived hormones, and they're stimulated by presence of glucose inside the gut. And this incretins has an inhibitory function on glucagon, and it has a stimulatory function on the beta cells to produce more insulin and eventually reducing the plasma glucose. So the most important incretin is a glucagon-like peptide 1. And these incretins are metabolized by enzymes, the DPP-4. So there are different ways by which we can increase the level of the incretins. One is by inhibiting the DPP-4 enzyme. So usually this DPP-4 enzymes metabolize incretins so that the half-life is just a matter of a few minutes. So if we inhibit DPP-4, we can prolong the action of. We can give some drugs which can actually mimic incretin, or we can actually give human GLP-1 analogs. The first of this incretin mimetics was exenatide. This has been derived from exendin-4, which is a peptide derived from the saliva of the Gila monster. Since this is of a non-human origin, it is highly immunogenic and it is very short-acting. And this is found to reduce a postprandial hyperglycemia. Since these are all peptides, this cannot be orally given, this has to be injected. Then subsequently, human GLP-1 receptor analogs came. Since they are of human origin, They are not immunogenic and they tend to be long acting. And most of these human GLP-1 analogs have cardiometabolic protective functions as well. So even though DPP-4 and GLP-1 analogs acts by elevating the incretin levels, the cardioprotective and renal protective actions are there for GLP-1 receptor agonist, but it has not been so far demonstrated for DPP-4 blockades. A few smaller trials has shown that DPP-4 blockade is associated with the marginal reductions in proteinuria, but the data is not really convincing us in case of GLP-1 receptor agonist. So the potential cardionephroprotective mechanisms of GLP-1 receptor includes, apart from hyperglycemia, it can inhibit the sodium hydrogen exchanger in the proximal convoluted tubule, resulting in natriuresis. And also it improves the tubuloglomerular feedback like the way SGLT2 blockades do. And it reduces the inflammatory mediators in the kidney. And again, it can modulate angiotensin and the renin axis. It reduces the oxidative stress, and it reduces renal hypoxia and atherosclerosis. And also it is believed to enhance the renal endothelin-dependent vasodilatation. The indirect benefits include improving the insulin sensitivity, weight loss, and the blood pressure control, partly resulting from the natriuresis, and also it reduces the atherogenesis. It improves the coronary flow, and it is also associated with decreased intestinal lipid uptake as well. And most of the drugs can be used in patients with a fairly advanced kidney disease also. And again, here we should be careful it's not a real contraindication means that data is not available, like the way we like the situation for SGLT2 blockade. We have not used these agents in advanced kidney disease, but it appears to be safe. Some of the agents like liraglutide and semaglutide appears to be safe up till GFR is 15 ml. And most of the studies with the GLP-1 receptor agonist has shown that it improves major adverse cardiovascular endpoints in most of the clinical trials. And now again, like SGLT2 blockade, this works. This looks like this works better in patients with a history of cardiovascular disease. And whereas when the meta-analysis was repeated by taking out the patients with a history of cardiovascular disease, the benefits are not that very convincing. And coming to the proteinuria, this is a pooled analysis from the SUSTAIN-6 and the LEADER trial. This has shown that liraglutide as well as semaglutide are associated with significant reductions in proteinuria. Now, when it comes to GFR decline, the effect is not so dramatic. So both the liraglutide as well as the semaglutide are associated with reductions in GFR, but when compared to placebo, this reductions in GFR is not that great. And again, this is an analysis of most of the major trials with the GLP-1 receptor agonist. And so we can see that the cardiovascular outcomes are somewhat better, whereas when it comes to protection agonist and stage kidney disease, the response is not that great in most of the trials. And again, this is some real world data comparing GLP-1 receptor agonist versus DPP-4 inhibitor. And again, it has been conclusively proven outside the randomized clinical trial settings also, GLP-1 receptor agonist offers better cardiac and renal protection compared to DPP-4 inhibitors. Now, which one will be preferred, whether it is GLP-1 or SGLT2 blockade, because both has cardiac protective effects and GLP-1 agonists have some sort of renal protective effects as well. So what should be preferred and what should be the agent in a given situation? So if we see both GLP-1 receptor agonist and SGLT2 inhibitors, they improve the composite cardiovascular endpoints. And SGLT2 blockade appears definitely better when we are dealing with patients with cardiac failure. And when it comes to kidney outcomes, SGLT2 blockade appears far better compared to GLP-1 receptor agonist. So GLP-1 receptor agonist, in most of the studies, the renal endpoints were reduced by its effects on proteinuria alone and not on GFR. Whereas SGLT2 blockers, irrespective of the albuminuria status, it confers renal protection. So basically, even now, GLP-1 and SGLT2 inhibitors are not approved as the first-line agents. They are still second-line, but possibly it's just a question of time. In the near future, sometime they're going to be considered as first-line agents, definitely. So after metformin, GLP-1 receptor agonist is the preferred agent in a patient with high risk or established cardiovascular disease other than congestive cardiac failure. And if you're dealing with a diabetic patient who is already on metformin, and the patient has cardiac failure or chronic kidney disease, then SGLT2 inhibitor is the preferred agent of choice. So this is from the KDIGO recommendations, and again, this recommendations, KDIGO recommendations in 2020 says do not initiate SGLT2 inhibitors when the GFR is less than 30. But this status has changed. We have trials like DAPA-CKD trial and the EMPEROR trial, which has recruited patients up to 25 or 20 ml of GFR. So possibly this is likely to be relaxed, and we should not be very strict with this GFR cutoff of 30 ml. Now, moving on to the next group of drugs. Mineralocorticoid receptor blockers has long been there in the market. The problem was the agent available was spironolactone. It had a steroidal structure, and it was not really specific for mineralocorticoid. It could act on other receptors like the androgen receptors as well as the progesterone receptors. And because of this poor selectivity, the adverse effect profile was not that going to be great. So that was one major impediment for use of spironolactone as antifibrotic agents. Now, the continuance of spironolactone has come, and recently we have finerenone, which is a non-steroidal molecule, which has a very high selectivity for mineralocorticoid receptors. And unlike spironolactone and eplerenone, it has an affinity for MR receptors in the heart as well as the kidney. So this means that lesser amount of adverse effects and lesser amount of hyperkalemia, and probably more antifibrotic potential compared to antihypertensive or antiproteinuric potential. Sorry. There are two major trials done so far with finerenone. So one was the Figaro diabetic kidney disease. So this was done in type 2 diabetic patients who with the proteinuria and compromised GFR who are already on RAS blockade, optimal RAS blockage. And in the Figaro DKD trial, the primary outcome was a cardiac composite outcome, and the secondary outcome was renal. And it was found that there is a 13% reduction in the primary as well as the secondary composite outcomes from the Figaro diabetic kidney disease trial. Another important trial which was done almost simultaneously was the Fidelio diabetic kidney disease trial. The inclusion criteria and all are somewhat similar to the Figaro trial. And the only difference was here the primary outcome was time to the renal composite endpoint, and the cardiovascular outcomes were secondary. And again, this trial has shown that finerenone protects from the composite kidney outcomes as well as the composite cardiac outcomes. And this is a pre-specified meta-analysis called fidelity meta-analysis, comparing the data of the Figaro and the Fidelio trials. And it has found that there has been a 14% reduction in the cardiovascular endpoints and a 23% reduction in the composite cardiac endpoints. And then that brings another question. What about combining finerenone with the SGLT2 inhibitors? And a few patients, not really big numbers, a few patients, around 259 patients in the Fidelio diabetic kidney disease, they were already on SGLT2 inhibitors. This was not part of the protocol. So, so the outcomes of these patients were combined with the remaining patients in the study who were not on SGLT2 blockade. And it was found that both finerenone was able to exert its effect whether the patient was co-prescribed SGLT2 one or not. And it seemed that co-prescription of finerenone and SGLT2 blockade is a safe strategy. And another unexpected advantage, which was actually found from this trial, was those who were prescribed SGLT2 blockade and finerenone, they tend to have a lesser amount of hyperkalemia when compared to people who are on finerenone alone. So this means that possibly this is a safe strategy to combine this, and this needs to be confirmed in large randomized controlled trials. And there is a trial which is already going on, which is looking into the combination of empagliflozin and various doses of finerenone. So these are the three molecules: SGLT2 blockades, GLP-1 receptor agonist, and finerenone. These are the three molecules which are likely to revolutionize the management of diabetic kidney disease in the next decade. And there are a few other molecules which also has been there in the market, which has been tested in small trials, and probably they are not anywhere close to routine use, unlike the three agents, and probably we might need a little more data on this. And one of the drugs which has been there in the market for quite some time is bardoxolone. So bardoxolone is a drug which is acting on the NRF2 KEAP1 axis. So bardoxolone upregulates NRF2 and KEAP1. So NRF2 is a sort of messenger which actually has antioxidant and cytoprotective properties, and it eventually leads to upregulation of multiple antioxidant and cytoprotective genes. On the other hand, KEAP1 inhibits the pro-inflammatory genes, and eventually, when we give bardoxolone, this might result in reduced proteinuria as well as nephroprotection. So there has been the initial trial on bardoxolone, which was a sort of promising, but subsequently a large trial actually has shown that there is no benefit with the bardoxolone, and in fact, bardoxolone was associated with a significantly higher death from cardiovascular causes. So one possible overlooked reason for bardoxolone was bardoxolone used to cause significant fluid retention. So this was not really known initially when the bardoxolone trials were not going on. Another concern with the bardoxolone was probably bardoxolone will enhance the renal elimination of creatinine. So whatever nephroprotection seen with bardoxolone, that might be just because of the enhanced creatinine clearance, or it might be with an assay interference with the creatinine assay. So this was actually tested subsequently in a small study where GFR was measured using inulin clearance, and it was found that with bardoxolone, yes, there's a definite increase in GFR when measured by inulin clearance. So this has actually led to another phase 3 trial, which is underway in Japan. Here they have excluded those patients who are at risk of cardiac failure, and this trial is going on, and possibly this results of this trial, whatever it is, it would actually give a better idea regarding the therapeutic role of bardoxolone in the management of diabetic kidney disease. The other group of agent which has been tried is endothelin-1 receptor antagonist. So endothelin has 3 types of receptors, and ET1 is one of the major receptors which creates all sort of bad things when kidneys are concerned. So this leads to efferent arteriolar vasoconstriction, so intraglomerular hypertension, sodium retention, pro-inflammatory, and it stimulates the pro-fibrotic pathways. So the first trial was done maybe around more than a decade back, and this was with a molecule called avosentan. It was shown that avosentan is associated with reductions in albumin-creatinine ratio, but there has not been any changes in the renal endpoints. Then subsequently, another trial with another molecule called atrasentan has been done, and that has shown to reduce the composite endpoint of doubling of serum creatinine, end-stage kidney disease, kidney transplantation, and death from kidney failure. But again, the problem with the endothelin-1 receptor antagonist in AVOID trial as well as the SONAT trial was there has been increased risk of fluid retention. Then the other group of agents which has been going on for which animal studies has been done include thymine, pyridoxine, aminoguanidine, and benfotiamine. These are all in of advanced glycosylation products, and most of the trials are small, and we are yet to have a conclusive statement regarding the use of these agents. Then the other group of agents which has been tried is epigenetic modulators. So this chromatin, normally chromatin stays in the condensed form, and when an acetyl group is added by the enzyme histone acetylase transferase, this chromatin becomes relaxed and it's open to transcription. And this acetyl group is removed by histone deacetylase, and again this means that once the acetyl group is removed, the chromatin structure becomes more condensed and transcription doesn't happen. So a group of molecules called histone deacetylase inhibitors are tried, which actually keeps the chromatin in the open configuration, and this might lead to transcription of many anti-inflammatory and anti-fibrotic genes. And again, most of the data is just limited to animal testing, and we don't really have a molecule which has been approved in human trials. Then another molecule which has been tested maybe in the last decade is sulodexide. Sulodexide is basically a purified form of glycosaminoglycan, sorry, which has antithrombotic, fibrinolytic, and anti-inflammatory properties. And again, most of the studies with sulodexide is pretty small, and probably there is some benefit, but that needs to be reproduced in studies with larger sample sizes and diverse clinical situations. And another molecule which of interest is baricitinib. So baricitinib is something which actually inhibits the JAK-STAT pathway, so that downstream regulation of profibrotic molecules does not happen. So this is tested. This was initially used in rheumatoid arthritis, and subsequently it got approved for management of COVID as well. There are small trials with baricitinib in diabetic kidney disease, which has shown that baricitinib is associated with reductions in urine albumin-creatinine ratio. And again, probably this has to be followed with larger clinical trials, looking at hard endpoints rather than the protein-creatinine ratios. And there are a few other molecules also which has been tested in small trials, like some of the molecules are targeting inflammation. Then some molecules targeting oxidative stress like our good old allopurinol. And apart from SGLT2 and GLP-1 agonists, there are molecules specifically targeting the musculature, reducing the intraglomerular hypertension and all. And most of them, they are either in phase 1 or phase 2 trials. And other molecules which are tested include roboxystatin, which is a protein kinase C inhibitor, then perfenidone, an inhibitor of TGF-beta, then pentoxifylline, which is supposed to be reducing the mesangial cell expansion and matrix proliferation. And there are quite a lot of other pathways which could be targeted, and many of the drugs are in the development phase. And let us hope that in subsequent years, we will get more molecules targeting specific downstream inflammatory and fibrotic pathways of diabetic kidney disease. So that is all for the day. Thank you all for the patient listening. Thank you.
Thank you, ma'am. That was a great session. Sorry to interrupt. Since we are running short of time, we would like to invite the chairpersons to give concluding remarks. We'll take the questions in chat box.
Nephropathy is such a topic that it requires a lot of discussion. A lot of literature is also going on with a lot of newer molecules coming into the research and as well as into the market also. And as Dr. Priyamvada nicely alluded to, so many interesting molecules, and we need to see any new molecule comes into picture, we get excited, but only thing is the time alone can tell whether which can withstand the test of the time or not. And the hope such molecules should come. Diabetic nephropathy, kidney disease being the most common cause of end-stage renal disease all over the world, especially in our country. And with as we are running short of time, and I conclude the session and thank you. Thank you, Dr. Priyamvada. I thank the organizers also for the same. Thank you.
Thank you, sir.
That was a wonderful session, madam. Thank you. Moving on to the next session, that is Heart Failure in CKD, a Change in Approach by Dr. Namrata Parekh. Chairing this session are Dr. Shrijit Parameswaran, Professor of Nephrology at JIPMER, Pondicherry. Joining him is Dr. Manjuri Sharma, Professor and Head of Department of Nephrology, Guwahati Medical College, Assam. I invite the chairpersons to kindly take over the session and introduce the speaker, please.
Good evening. Am I audible? Am I audible?
You are audible, ma'am.
Yeah. Good evening. It gives me immense pleasure to introduce Dr. Namrata Parekh, who will be speaking on the heart and the kidney. She has done her MBBS from C.U. Shah Medical College, Surendranagar, Gujarat. MD General Medicine from MP Shah Medical College, Jamnagar, Gujarat. DNB Nephrology from Yashoda Super Specialty Hospital, Hyderabad, Telangana. Worked as consultant nephrologist at Virinchi Hospital, Hyderabad, Telangana, and Divine Life Hospital, Adipur, Gujarat. Currently, solid organ transplant fellow at the Ottawa Hospital, Ottawa, Canada. Over to Dr. Namrata. I know it will be a very good presentation.
Thank you so much, ma'am. Thank you, Win India, for this opportunity. And without wasting more time, let's start the session then. Hello, good evening, and a warm namaskaram to everyone in Hyderabad. Thank you, Win India, for giving me the opportunity to address this forum. I've spent many an evening in the auditorium at Nizam's listening to talks given by some amazing mentors. And so it is truly a humbling experience for me to be on the other side of the stage today. My topic of discussion for today is heart failure in chronic kidney disease with a focus on changes in approach. Thank you, Win India, again for inviting me to talk on this topic, because in preparing for this talk, I have learned a lot myself. So it has definitely been a learning experience for me. Now, the fact that the heart and the kidney are related is definitely not a new concept. In 1836, Dr. Richard Bright, who is widely regarded as the father of nephrology, described structural changes in the heart in patients with chronic kidney disease. Today, we know that both heart disease and chronic kidney disease share certain common characteristics, such as common risk factors, a predisposition for the older age group, increased risk of hospitalization and ICU stay, as well as increased risk of mortality. Both conditions may fail to respond to conventional therapies or even develop toxicity to them. In fact, presence of either may predispose to or even worsen the other. So it would not be an exaggeration to say that heart failure and kidney disease go hand in hand. If we look at the epidemiology, then about 45 to 63% of patients with heart failure have chronic kidney disease, while 65% of patients with chronic kidney disease have cardiovascular disease. If you look at this graph, then it shows us that as the GFR declines, there is an increase in the hazard ratio of incident heart failure, and this risk is more in patients who have a higher albumin creatinine ratio. So we can say that as the eGFR declines and as the proteinuria increases, the risk of heart failure also increases. Similarly, if we look at heart failure and other cardiovascular disease, then the prevalence in patients with chronic kidney disease is definitely more than that in patients without this entity. And finally, if we look at the survival amongst patients with heart failure, then the survival is definitely lower at higher stage of CKD. The black curve here shows us the survival probability in patients who have a normal eGFR, while the other curves show us the survival probability at various stages of CKD. You can see that as the eGFR declines, the survival probability also declines. This interplay between heart disease and chronic kidney disease has led to a new terminology called cardiorenal syndrome or CRS. However, I should point out that it is often difficult to point out what came first, heart disease or kidney disease, and it is more often a case of what came first, the chicken or the egg. This complicated relationship has led to a subclassification of CRS into 5 types. Type 1 denotes acute heart failure leading to acute kidney injury. Type 2 includes patients with chronic heart failure who go on to develop chronic kidney disease. Type 3 denotes patients with acute kidney injury who develop acute heart failure. Type 4 describes patients with chronic kidney disease who go on to develop chronic heart failure. And type 5 describes a systemic insult, which includes the both of heart and the kidney. So let's start with the definitions. As we know, KDIGO defines chronic kidney disease as persistently reduced eGFR of less than 60, or at least one of albuminuria, urine sediment abnormalities, histological or structural abnormalities present for at least 3 months. Heart failure, on the other hand, is not a disease in itself, but rather an umbrella term, which includes signs and symptoms due to structural or functional cardiac abnormalities associated with reduced cardiac output or increased intracardiac filling pressure. It is a misconception that heart failure develops only in the presence of reduced left ventricular ejection fraction. Although heart failure with reduced ejection fraction or HFrEF does form a significant component of this entity, we should also remember that heart failure can develop even with moderately reduced ejection fraction or even preserved ejection fraction. However, for the sake of today's discussion, we'll be largely restricting ourselves to HFrEF or heart failure with left ventricular ejection fraction of less than equal to 40%. If we look at the pathophysiology, it is fairly straightforward. Reduced ejection fraction leads to reduced cardiac output, which leads to systemic hypoperfusion. This leads to activation of various sympathetic mechanisms like the sympathetic nervous system, which leads to systemic vasoconstriction. This will initially increase venous return to the heart, leading to an increase in cardiac output. Ultimately, however, it becomes maladaptive, leading to an increase in afterload and actually reducing cardiac output. Further, hypoperfusion of the kidney will lead to activation of the renin-angiotensin-aldosterone system, which actually denotes an effort by the kidney to preserve eGFR. There is dilatation of the glomerular afferent arteriole and vasoconstriction of the efferent arteriole. Ultimately, however, this mechanism also becomes maladaptive, and these compensations actually reduce blood supply to the kidney. Finally, activation of the RAS will cause increased aldosterone activity, which leads to increased retention of sodium and water, which worsens edema and hypertension, and ultimately leads to deterioration of both heart disease and kidney disease. Before we look at the management, let us consider this case vignette as an introduction. All of us are familiar with the scenario. You get a call from your colleague in cardiology about a 65-year-old gentleman who has been admitted with acute decompensated heart failure. You are told that he had some chronic kidney disease at baseline and that a serum creatinine used to be around 2 milligrams per deciliter. This brings it to an eGFR of around 34. You are told that he is symptomatically doing much better now, but the creatinine is about twice of what it used to be. Serum potassium is 5.6. What would you advise? I'll tell you what I used to do as a resident in nephrology. I'd flip directly to the medication chart and go, aha, diuretics, aha, AC inhibitors. Advice largely consisted of consider withdrawing of any drug, daily renal function test, and review SOS. Maybe that was not the right thing to do. Last year, something very weird and even a little sad happened at a hospital in the United States. 2 physicians ended up in blows over the care of a particular patient, and one of them was actually arrested. This physician was a nephrologist. The physician he assaulted was a cardiologist. Their argument was over discontinuation of a medication. I do not know what that medication was, and I leave you to form an intelligent guess. But I do believe that we owe it to our colleagues in cardiology to try and understand better the management of heart failure in kidney disease patients. This year in May, the American Heart Association laid forward guidelines for the management of heart failure according to the level of evidence. The recommendations were given a grading of strong, moderate, or weak, with strong recommendations being coded green, recommendations with moderate evidence base getting yellow color code, and those with a weak level of evidence being coded light orange. Modalities which were found to have no benefit were coded dark orange, while those which were actually found to be harmful were coded red. Further, they said that management of heart failure should be based on the stage in which we find a particular patient. Stage A includes patients who have risk factors for development of heart failure, but who do not have any structural or functional heart disease. Stage B includes patients with structural and functional heart disease who have not yet become symptomatic for it. Stage C is symptomatic heart failure, while stage D is advanced heart failure, which is unlikely to respond to drug management alone and will require additional procedures. For the sake of today's discussion, we'll restrict ourselves to symptomatic heart failure because it is in this stage that pharmacotherapy is most likely to help. And it is also the stage where nephrologists are most likely to be involved. In the interest of saving time, I'm going to skip management of stage A and stage B and skip directly to heart failure with reduced ejection fraction, stage C. Now, when we encounter a patient with reduced left ventricular ejection fraction and manifestations of fluid overload, we have an array of drugs to choose from. All of them have high level of evidence and are strong recommendations. You can use conventional agents like angiotensin-converting enzyme inhibitors, angiotensin receptor blockers, along with beta blockers, or you can use newer agents like angiotensin receptor neprilysin inhibitors, mineralocorticoid receptor antagonists, SGLT2 inhibitors. Diuretics may be used as required for management of edema. Now, the dose of these drugs may be up or down titrated depending upon the response obtained and the adverse effects observed. There are certain special scenarios and patient conditions which will require additional management, including device therapy, but this is beyond the scope of discussion for today. So if you go back to the slide, then it is obvious that the main target for management would be these compensatory mechanisms. We can use beta blockers to suppress the sympathetic drive. We can use vasodilators to reduce the afterload. We can use digoxin to maintain cardiac contractility. We can use diuretics or SGLT2 inhibitors to promote sodium and fluid diuresis. But the drugs which are used most often by nephrologists and cardiologists alike are RAS inhibitors. This includes ACE inhibitors, ARBs, angiotensin receptor neprilysin inhibitors or ARNIs, and mineralocorticoid receptor antagonists or MRAs. Let us start with ACE inhibitors. You can see that the evidence for the use of these drugs is decades old, but you can see at the same time that most of these trials excluded patients with a higher serum creatinine or a lower eGFR. To the credit, these trials did found good benefit with ACE inhibitors in terms of reduction of all-cause mortality as well as cardiovascular death and hospitalization for heart failure. These benefits are preserved up to an eGFR of 60, with some benefit being seen even up to an eGFR of 30. However, beyond CKD stage 3, we enter this gray zone where the evidence base is not very strong and the data is quite limited. At least we have the consolation that these drugs will not cause a lot of harm. However, if you go down to CKD stage 5 or the stage of dialysis, you find that there is practically no evidence of these drugs in the management of HFrEF. This is mirrored in the evidence base for angiotensin 2 receptor blockers. Again, you can see that trial evidence comes from trials which excluded patients with a higher serum creatinine. In terms of ARB, the striking difference from ACE inhibitors that while there was definitely a benefit in terms of reduction of cardiovascular death and hospitalization for heart failure, benefit for reduction of all-cause mortality was not as strong. However, this benefit of reduction of cardiovascular death and hospitalization is preserved up to an eGFR of 30. Below that, in CKD stage 4, evidence is limited, while in CKD stage 5, it is virtually existent. We know that for both ACE inhibitors and ARBs, these drugs act by causing vasodilatation of the efferent arteriole, and so some fall in eGFR after initiating these drugs is normal and even acceptable. In fact, unless the serum creatinine increases by more than 100% of the baseline or the eGFR falls to less than 20, we do not necessarily need to discontinue them. Even then, we should look for other potential culprits like simultaneous use of diuretics, radiocontrast, or coexistent infections. We should first start by halving the dose of these drugs and then reevaluating. If at all we need to stop these drugs completely, then patients should be reevaluated once kidney function stabilizes. And if possible, we should try a rechallenge with these drugs. Both EC inhibitors and ARBs will cause an initial decline in eGFR, but as we know, this is transient and reversible. And over a long period of time, the fall in eGFR is not very different from placebo. Okay. So AC inhibitors and ARBs are older RAS blockers. Newer agents include ARNIs or angiotensin receptor neprilysin inhibitors. It's a huge name because it's a combination of two drugs, a neprilysin inhibitor like sacubitril and an angiotensin receptor antagonist like valsartan. We've already talked about ARBs, but let's talk a little about neprilysin inhibitors. Neprilysin is a peptidase which cleaves atrial natriuretic peptide and B-type natriuretic peptide. These are enzymes secreted by the atrial and ventricular myocytes in response to heart failure. They promote natriuresis and thus bring about diuresis. So if we use a neprilysin inhibitor, it is going to prevent degradation of these hormones and thus bring about extended diuresis of sodium and water. This will antagonize the harmful effects of aldosterone and at the same time may even permit a reduction in the use of diuretics. So this combination of sacubitril and valsartan has been used recently for management of heart failure. But you can see that even these trials excluded patients who had an eGFR of less than 30. In terms of benefit, they found an improvement in terms of reduction of all-cause mortality, cardiovascular death, and hospitalization for heart failure, with the evidence being preserved up to an eGFR of 30. Unfortunately, no evidence for patients with CKD stage 4 or 5. As these drugs work in a mechanism of action similar to AC inhibitors and ARBs, some increase in serum creatinine should be expected with their use. But again, you do not need to discontinue them unless the serum creatinine is more than 100% of baseline or the eGFR falls to less than 20. AC inhibitors, ARBs, ARNIs, and even mineralocorticoid receptor antagonists, which we'll see shortly, act by increasing aldosterone activity. And so it is quite possible act by inhibiting aldosterone activity, and so it is quite possible that you'll see an increase in potassium. You do not need to discontinue these drugs unless the serum potassium is more than 5.5. Which brings us to mineralocorticoid receptor antagonists. These drugs act by blocking the activity of aldosterone on the mineralocorticoid receptors. How they act is not exactly known, but it has been found that they have an anti-inflammatory, anti-fibrotic action. They prevent cardiac remodeling and ventricular hypertrophy. They also have antiarrhythmic and anti-infarction properties. And through all these properties, have even been found to inhibit glomerular hypertrophy and glomerulosclerosis. These drugs have also been used a lot in the management of heart failure. And one of the drugs which is used most commonly is spironolactone or aldactone. Unfortunately, it has low selectivity for the mineralocorticoid receptor and will also bind to the hormonal receptor, leading to hormonal side effects like gynecomastia. They also have higher affinity for the kidney, and so it is associated with an increased risk of worsening of kidney function and hyperkalemia. Eplerenone is a newer mineralocorticoid receptor antagonist, which has medium selectivity for the mineralocorticoid receptor, and so it does not cause hormonal side effects. It will still cause worsening of kidney function or hyperkalemia, although the risk is definitely less than that with spironolactone. Finally, we have Finerenone, which is different from other drugs of this class in that it is non-steroidal. Also, it has high affinity for the mineralocorticoid receptors, and so not only does it not cause hormonal side effects, it is also associated with a low risk of worsening of kidney function and hyperkalemia. Again, most of these trials excluded patients with a lower eGFR and did find a benefit in terms of all-cause mortality, cardiovascular death, and hospitalization for heart failure. Like we have seen for other drugs, we do have no evidence about the efficacy or safety of these drugs in patients with CKD stage 5. I'll take just a few minutes to talk a little more about Finerenone because it is found to be quite an efficacious drug both for the management of heart failure and chronic kidney disease. Fidelio DKD was a trial which was published in 2020, which used Finerenone in patients up to an eGFR of 25. It was primarily designed to study outcomes of Finerenone use in patients with chronic kidney disease and type 2 diabetes. They found that there was definitely improvement in kidney outcomes with this drug compared to placebo. Not only that, even the cardiovascular outcomes showed benefit compared to placebo. Incidence of hyperkalemia was higher with Findrenone compared to placebo, but on analysis, it was found that the frequency of adverse effects was quite similar in the two groups. Thus, Fidelio DKD concluded that treatment with Findrenone resulted in lower risk of CKD progression and cardiovascular events. This led to another trial called Figaro DKD, which came out the next year in 2021. In contrast to Fidelio, this trial was designed to study cardiovascular outcomes rather than kidney outcomes in patients with diabetic kidney disease. Again, they found that Findrenone did better than placebo, both in terms of cardiovascular outcomes as well as kidney outcomes. Higher incidence of hyperkalemia was noted, but again not found to be significant. The fidelity analysis was carried out as a meta-analysis of Fidelio DKD and Figaro DKD. As expected, there was an improvement both in cardiovascular and kidney outcomes, and the safety profile was found to be similar between Findrenone and placebo. All in all, does seem to be an excellent drug. The only disadvantage or the only minus point is that it's not very widely available. Findrenone is still not available in India, and even in the Western world, its use is rather limited. Similar to other RAS blockers, mineralocorticoid receptor antagonists are also associated with an initial decline in EGFR, and long-term slope in EGFR may be a little steeper than other drugs of this class. Again, as we have seen, it is associated with hyperkalemia, but the use of potassium binders may permit the use of these drugs provided the EGFR is acceptable. All of these drugs, be it AC inhibitors, ARBs, ARNIs, or MRAs, are associated with some drop in EGFR, but it should be remembered that the survival benefit conferred by these drugs is much more than the perceived risk of worsening of kidney function. And so all efforts must be made before we consider discontinuing these drugs. We now come to the reigning celebrities in nephrology, or SGLT2 inhibitors. These act by inhibiting the sodium glucose cotransporter 2 and inhibit natriuresis, thereby causing reduction of blood pressure and amelioration of volume overload. They are also found to have antioxidant, antifibrotic, and anti-inflammatory action, and thus may possibly offer direct protection to the kidneys. We are all familiar with a number of clinical trials which have studied these drugs recently, but it should also be remembered that there is very little evidence for use of these drugs below an EGFR of 20. Up to an EGFR of 30, we can say that these drugs have good evidence for reduction of all-cause mortality, cardiovascular death, and hospitalization for heart failure. Below this, evidence is again limited and virtually non-existent for patients with CKD stage 5. One of the first trials which brought about evidence for use of SGLT2 inhibitors was CANVAS. Ironically, this trial was actually designed for evaluation of cardiac safety of canagliflozin to be used for management of diabetes more than anything else. To the surprise, the researchers found that canagliflozin brought about significant reduction in cardiovascular mortality, hospitalization for heart failure, as well as all-cause mortality. 2 years later, the DAPA-HF trial was published, which studied or compared dapagliflozin versus placebo. Again, benefit in terms of reduction of cardiovascular outcome and even improvement of kidney function was noted with dapagliflozin as compared to placebo. More recently, we had the Emperor Reduced trial, which compared empagliflozin with placebo. And a difference from other trials was that it included patients with heart failure irrespective of diabetic status. You can see that there was less incidence of cardiovascular outcomes, including cardiovascular death, hospitalization for heart failure, and with empagliflozin compared to placebo. Empagliflozin was also found to slow the decline of EGFR in patients with chronic kidney disease. So if there's one thing that both cardiologists and nephrologists can agree on, it is do not hesitate, fluosinate. The use of SGLT2 inhibitors or fluozins has become so widely popular that I'm going to take just one more minute to talk a little bit more about these drugs. While these drugs are quite excellent, it should be remembered that the use is contraindicated below an EGFR of 25, simply because it has not been studied in these patients. It is also contraindicated in patients who have critical limb ischemia. For patients who have some degree of volume depletion, genital mycotic infections, hypotension, a prior history of critical limb ischemia, diabetic ketoacidosis, and a history of severe hypoglycemia, it might be prudent to address these factors before starting treatment with these drugs. We can start dapagliflozin and empagliflozin at a dose of 10 mg per day and canagliflozin at a dose of 100 mg per day. When patients are on these drugs, they need to be educated about the need to be vigilant about their hydration status and to maintain proper hygiene. They should also be educated about sick day rules and advised to discontinue these drugs if they are feeling unwell. While patients are on SGLT2 inhibitors, they need to be monitored for weight, blood pressure, blood glucose, and kidney function. If you're going to use them with loop diuretics, then these might require a reduction in dose if we have coexistent volume depletion. Again, if used with sulfonylureas or insulin, these drugs may also require dose reduction or discontinuation in the event that the patient develops hypoglycemia or is at a risk for developing hypoglycemia. Again, like RAS inhibitors, SGLT2 inhibitors will bring about an early decline in EGFR, but this stabilizes over the long term, and the long-term decline in EGFR is not different from that in placebo. In contrast to RAS blockers, SGLT2 inhibitors do not have a lot of effect on serum potassium and so are not expected to cause hyperkalemia. They're also not expected to cause a drastic increase in serum creatinine, and if this is observed, it should prompt an evaluation for other causes. Again, if the EGFR falls below 20, it might be an indication to discontinue these drugs. However, all efforts should be made to find other potential causes and treat them before considering withdrawing these drugs. Just a word on beta blockers. Again, centuries of evidence, but again, exclusion of patients with higher serum creatinine or low EGFR. These drugs do not really have a lot of effect on kidney function, and so if you do see an increase in creatinine with the use, you should possibly look for other causes. So to conclude, as far as various drugs are concerned for management of heart failure, you have strong evidence for the use of AC inhibitors, ARBs, ARNIs, MRAs, SGLT2 inhibitors, and beta blockers for reduction of cardiovascular death and heart failure hospitalization up to CKD stage 3. As far as ARBs are concerned, the evidence in terms of reduction of all-cause mortality is not that strong as that of other drugs that we have seen so far. Once you reach CKD stage 4, AC inhibitors and SGLT2 inhibitors may still have some benefit in reducing cardiovascular death and hospitalization for heart failure, but beyond a EGFR of 15, there is absolutely no evidence for the use of any drugs. This is somewhat ironic because as we have seen that as the EGFR declines, the risk for mortality due to heart failure also increases. So it's rather unfortunate that this group of patients, which is most likely to benefit, has been excluded from all the trials designed so far. In a recent KDIGO controversies conference, it was found that evidence is strong up to an EGFR of 30 for various drugs used in management of heart failure. But once the EGFR declines below 30, there is also a sharp decline in the evidence base. The time has come to design clinical trials which are more inclusive of patients with chronic kidney disease. The low EGFR and the perceived risk that these patients may be at harm is something that needs to be thought about again. So my take-home messages for today are that heart failure and chronic kidney disease go hand in hand, and so definitely cardiologists and nephrologists should work together. Conventional therapies with RAS blockers and beta blockers are good drugs in terms of having excellent evidence, being widely available as well as economical to use, and so they continue to be first line of management. Newer drugs also have good evidence base, but suffer from limited awareness, high cost, and lack of availability. Most of these drugs will cause an initial decline in EGFR, but this should not be an indication to discontinue them. And finally, and perhaps most important of all, say no to renalism. Thank you all for patient listening. I apologize for any
Thank you, Namrata. That was quite an extensive review of available literature, especially on an issue which is quite vexing to nephrologists and treating these patients. Quickly, one thing, because you didn't know, our cardiologist seems to be in the habit of prescribing digoxin for these patients. It was there in one of your figures you mentioned, but what is your view on treating these patients with the digoxin?
Digoxin is something that has fallen out of practice recently. I have not seen a lot of cardiologists using it of late, but again, I'd say same precautions need to be maintained. Monitor for serum potassium, monitor for decline in kidney function. But if at the end of the day, cardiac safety is definitely important. So if it's going to help your cardiac contractility, then with a watchful eye, I would probably continue the drug.
Okay. Yeah, so I believe that the it probably doesn't contribute much to survival. Probably, yeah, at least there are some reports saying that the survival may be worse on digoxin, treatment with digoxin and similar drugs. But it's true that for some patients, when your hands are tied, and they are quite symptomatic, especially when you don't see a long-term options for them, like undergoing a transplant. I do believe that for short-term improvement in their symptoms, it may be warranted. Thank you.
Thank you, sir.
Thank you, Dr. Namrata. It was really a very nice presentation. Just one small question, if I can have, regarding the clinical utility of your ARNIs. How much is it used? There was a lot of hype when it was first introduced.
Unfortunately, I have again, its use has been limited, partly because of cost, partly because of concern for hyperkalemia and rise in creatinine. And in resource limited settings, we always have this issue about how we're going to monitor these patients on a long term. My cardiology friends assure me that it does work pretty well, but if I say personally, I've not seen it work very well. Evidence is good to suggest that it has shown good benefits over a long term.
Thank you.
Yeah. And thank you, WININDIA, for the opportunity. It's really a surreal experience for me to be on the other side of the stage today.
So I think we can conclude since we're running short of time, and we can go over to the next lecture. Thank you so much.
Thank you.
Thank you, ma'am, for that enlightening session. We move on to the next session for the day, that is on green dialysis. Its time has come by Dr. Manisha Sahai. We have with us esteemed chairpersons, Dr. Soundarajan P., former professor and head nephrology, SRMC Savita University, currently working as consultant nephrologist at Apollo Hospitals, Chennai. Also joining us will be Dr. Deepankar M. Bhaumik, professor of nephrology at AIIMS, Delhi. I request the chairpersons to kindly take over the session and introduce the speaker, Dr. Manisha Sahai.
Good evening, everybody. It's a pleasure to take part in this WIN program from Chennai. I have a great pleasure to introduce Dr. Manisha Sahai. She's a young nephrologist. I call her young because I know her from her student days. Shouldering a very big responsibility in one of the oldest medical colleges of this country in Usmania General Hospital as professor at the department. She's also an editor-in-chief for Indian Journal of Transplantation. She's a deputy chair for the CME Committee of International Society, and she's a president for the Nephrology Forum of Hyderabad, so on and so forth. And she has been an upcoming star, one of the star nephrologists of Hyderabad city with a lot of publications and gold medals during her undergraduate curriculum. She holds a lot of responsibilities as Vice President of Indian Society of Nephrology. And to the academic front, she's a keen researcher, a very good orator. We are going to listen to her a very interesting, fascinating topic on green nephrology. My colleague, chairs will introduce this topic. Dr. Bhaumik and Dr. Kumut Mehta.
It's indeed great pleasure to be chairing this session, Green Nephrology. And the title is very apt. The time has come. We need to save the earth because we are overusing the resources. We have around 33 lakh patients on dialysis in the world as of now, and they use a huge amount of resources with a very large carbon footprint, about which Dr. Manisha will be speaking shortly. I will not stand between you and the talk. Dr. Manisha, please go ahead with your presentation.
So thank you very much for the kind introduction. So I'll move over to the topic, green dialysis. Its time has come. So coming to the topic, What is biomedical waste? Biomedical waste is classified as any item that comes in contact with body fluids. Specifically, it is any waste that is generated in the diagnosis or treatment of humans. So we are aware, still the echo is there. Okay, otherwise run the recording then. Can I speak now?
Manisha Sahai.
Okay, so we are aware of the different categories of Is it okay now? Yeah, or maybe you run the recording otherwise.
It's
No,
okay
it's
now.
not,
You
it's not
can-
coming, right?
I can see your slides. Can you put it on full screen mode?
Yeah, just that's what they are doing.
Yes.
पूरा स्टॉप कर दो वो माइक से बात करो
No, not.
Yeah, sorry. So I think it's done now. So yeah, we
Yeah,
are
it's
talking
fine.
about the green dialysis and what is biomedical waste. It's classified as any item that comes in contact with body fluids. Specifically, it is any waste that is generated in the diagnosis or treatment of humans. It's not advancing. Not advancing. So we have 10 categories of waste, and the biomedical waste can be divided into these 10, and dialysis produces almost all categories except the category 2, that is the animal waste. We all know that dialysis is a life-saving therapy. But remember, dialysis is at the heart of biomedical waste matter, as it's one of the most important waste producers in the whole hospital unit. Your dialysis unit is the maximum biomedical waste producing unit. We know in 2010, there were around 2.6 million patients who were treated with dialysis, but estimate for 2025 is about 4 million people dialysis worldwide. Majority are on hemodialysis. What about India? Around 1.75 lakh people are on dialysis. Prime Minister Dialysis Initiative is likely to increase the numbers. We are going to have a huge generation of biomedical waste, solid waste as well as liquid waste. And nephrologists, we all are the key persons who are going to understand this problem. Nobody else is going to understand the problem. Does hemodialysis generate waste? Yes, it does. Solid waste, you can see, this is how we are polluting the environment. And this solid waste, I think you ran the recording.
good morning, good afternoon, good evening, waste producers in the whole hospital. In 2010, about 2.6 million people were on dialysis across the globe. And in 2025, this number is going to increase to 4 million people. Majority are on hemodialysis. What about figures in India? About 1.75 lakh people are treated with dialysis in India. And after this PM initiative, the dialysis is going to increase in numbers with universal coverage of hemodialysis. There's going to be a huge generation of biomedical waste, as well as a lot amount of water is going to be generated. And nephrologist is the key person who is going to understand the implications. Does hemodialysis generate waste? Yes, it generates a lot of solid waste as well as liquid waste as well. Now, what about the solid waste in hemodialysis? We know that we have waste in the form of HD consumables, which are dialyzers, bloodlines, infusion fluids, needles, concentrates, as you can see in the inset picture. In addition, you also have hazardous waste, for example, the soiled swabs, which are used during hemodialysis. In addition, do not forget about the carbohydrate, the cardboard box packing for hemodialysis. Liquid waste during hemodialysis, yes, it's generated from the RO reject water as well as from the dialysis effluent. So is there any Indian data on waste production in dialysis? There is hardly anything, and hence we did the study in our unit. It's a prospective observational study of 1 year. We have an 18 machine dialysis unit, and we measured the waste generated from one dialysis, daily waste generation from the unit. We also looked at the monthly waste generation, the electricity consumption, the cost of waste disposal in our unit, the type of waste produced. And this study was done along with hospital administration and was approved by the Institutional Ethics Committee. So looking at the expected waste generation from a single hemodialysis session, so we just added the material used during hemodialysis, the weight of all that, dialyzer, fistula needles, bloodlines, the arterial blood cover, stoppers, venous bloodline cover, infusion sets, saline bottles, syringes, fistula, etc. All of them, most of them are from plastic. The plastic may be of varied varieties, for example, polyvinyl chloride, polypropylene, so on and so forth. And then we added the weight. So it resulted in a net wet weight of 0.7 kg and a dry weight of 0.45 kg for each dialysis session. So 0.7 kg into 12 dialysis per month was 8.4 kg per person per month. This was the dialysis material. In addition, we looked at the cardboard boxes used in a month, and that amounted to 70 kg. That is 3.5 kg per person per month. And we also looked at the concentrate containers. So this amounted to 1.5 kg per person per month. So adding all this, we came up with a figure of 13.4 kg waste generation per person per month, or 1.2 kg waste generation per dialysis. So remember this figure, 1.2 kg per dialysis session. Then we also looked at the daily waste generation in another manner, where we measured whatever waste was produced in the unit, the waste in the yellow bin, the red bin, so on and so forth. So at the end of the day, it was measured by a spring balance. And this was done for a year. And what did we find? We found that in January, the total waste per month was around 3,000. Same figures were seen in other months as well with little variation. Dialysis numbers were around 2,000 per month. And if we looked at per kilogram waste generation in this method, we found that it was again 1.2 kg per person per dialysis. So again, it came to the same figure. Now looking at the composition of this waste, 70% of it was plastic waste, 6% was the contaminated swabs, 20% was general waste, and 4% was sharps. This waste generated in the hemodialysis unit was then transported by the biomedical waste management and was either subjected to incineration or landfill. The general waste went into the landfill. What about the liquid waste generation? So each dialysis needed 120 liters of water, and this was discarded into the drain after use. And the RO produced around 120 liters of water per dialysis as reject, and this was also discarded into the drain. So per month, per patient, we had how much water going down the drain? 240 liters for each dialysis, including both the effluent and the reject water. And for 12 sessions, it was roughly around 2,888 liters, that is 3,000 liters per month, a huge figure. In addition, there was chemical waste as well, which included bleach, renalin, citric acid, so on and so forth. So liquid waste was again not reused for any purpose. It was just disinfected and it went down the drain. Electricity consumption of our unit was 4 kilowatt hour for one dialysis session. And the cost of waste disposal was around 6 rupees per kg. In private hospitals, this amounts to around 36 rupees per kg. Thus, from a small pilot study, what did we find? Each dialysis patient generates around 1.2 kg waste per session of dialysis. This is almost 70% plastic waste. Liquid waste is 35,000 liters per year per person. Electricity consumption per session was 4 kilowatt hour, and cost of waste disposal was 6 rupees per kg. So this was our study with its findings. What does the literature say? Literature says similar solid clinical waste generated is around 1.135 kg per session. Most of it is plastic. And some studies have reported that the waste may vary from 177 kg of solid clinical waste per year to 279 kg per year. What about RO water? So it said that in a study by Barakter et al., each single dialysis consumes around 500 liters of water, where they have included the reject water, the effluent, as well as water used for priming, rinsing, and sterilization of the system. So our study showed 240 liters per dialysis. Here they have said 500 liters per dialysis. Electricity, in a study by Hampton et al., they say that each hemodialysis treatment uses more than 1/2 of daily consumption of electricity by an average 4-person household. And cost of waste disposal about 2.2 to 16 euros in Europe, and in USA it's around 2 to 21 US dollars. So why is the biomedical waste management important? It's important because if it's not disposed properly, there is injury from sharps to rag pickers, there's chance of infection, there is contamination of water. Again, with the burning and incineration of the plastic, there is depletion of ozone layer, there is damage to human health and reproduction, there is decrease in immunity, mutations, endocrine abnormalities, so on and so forth. And there is a carbon footprint and a greenhouse gas effect, which causes damage to the environment. So it has hazard to health as well as to the environment. So what should we do? Are there any measures which we as nephrologists can take? So let us look at some of the simple steps which can be done. The basic principle we all know is reuse, reduce, recycle, and we are doing it all for general garbage. Can it be applied to our hemodialysis unit? Yes, it can. How do we do it? Let us look at some tricks and trade. So look at the use of lighter dialyzers. So if you use a dialyzer with a polypropylene housing, it is lighter than polycarbonate housing. And this reduces the biomedical waste by 2.8 kg per year per person. The difference between lightest and heaviest polyflux dialyzers in a study was around 95 gram, which amounted to 13.6 kilogram per person per year. Again, whenever you are doing dialysis for children, use pediatric dialyzers as far as possible because they are lighter, and use a pediatric tubing. Whenever possible, do not use the adult tubings to dialyze the older children. As far as possible, stick to the tubing appropriate for the size of the patient. Then another important thing is do not throw off the dialyzers with blood inside them. Empty the dialyzer before throwing, because this also contributes to a lot of biomedical waste. And Fresenius 6008 machine allows to save 150 gram of medical waste due to emptying process at the end of dialysis, which is not there in 4008 tests and 5008 machines. Empty the blood tubings as well. This also reduces the biomedical waste generation by 21 kg per patient per year, huge figure again. Another important step is learn to reuse. But again, here there is a caveat. Because of reuse, there may be increased exposure to cleaning agents and sterilants and increased chances of bloodborne virus infections due to reuse. However, the positive point is there is decreased number of dialyzers and decreased amount of packaging material as well. And it leads to saving of 40 kilogram per year biomedical waste. It reduces the biomedical waste by a significant amount per person. What about hemodialysis and peritoneal dialysis? So as far as the solid waste is concerned, both are comparable, but peritoneal dialysis produces much less liquid waste as compared to hemodialysis. So this may be one of the methods of green dialysis, promote peritoneal dialysis. Another method is learn to recycle. And for recycle, segregation of waste at source is important. It takes just 90 seconds more. That's 1.5 minutes for segregation of the waste at source. Use biodegradable plastics, avoid PVC, avoid phthalates. Use those plastics like polyolefins, which are biodegradable. And what should you do? For recycling, even of the infectious waste, after microwave, hydroclave, or autoclave, the plastic waste should be subjected to shredding in a recycler. You can see many machines are available. On the right side, you have the old shredder, and on the left side, you have the new shredders available, which automatically they disinfect the waste and produce shredded waste. And this is Shreddy Plus 70, SteriMed, Shreddy Shred, Metica, Selectron, so many are available. And what happens after this waste is shredded? This contaminated plastic derived from dialysis water is sterilized, followed by shredding into confetti-sized pieces. You can see that in the picture. And these are then incorporated into concrete and used for laying the road. So you can see it's written there, this road is made from waste plastic. So whatever plastic we are wasting in our country, we are just throwing it off, can be reutilized for road laying. So this was about the solid waste. You can consume it properly. What about the liquid waste? The RO reject water has high TDS, more than 2000 ppm, and high sodium. Can it be reused? Obviously not for drinking, but you can use it for mopping the floors. For toilet flushing, did you know that each toilet flushing, it uses around 5 liters of water, a huge volume. So this dialysis waste can be used for toilet flushing. Water can be used for gardening, for improving the hospital landscape. Water can be transformed into watts. The water can be used to generate hydroelectric power, and this hydroelectric power can again be used in the dialysis unit. And this is being done in some of the units in the West. In UK, dialysis services have reported savings of 4 million liters of water per year with a new water system with reuse of reject water in gardens and toilets. And it has led to an enormous cost saving as well, 10 million euros, because of the Green Nephrology Network. What else can be done? We can look at solar panels for dialysis unit. This helps in reducing the carbon footprint and helps in saving the environment. The hydroelectric power from dialysis wastewater can generate energy to reduce the dialysis unit and at the same time reduce the carbon footprint as well. So we should have, ladies and gentlemen, a cradle to cradle approach, not cradle to grave. What is this cradle to cradle approach? We should learn from nature. Human beings are born, they live their life, they die, and again they are reborn. So nature, it completely utilizes whatever it produces and leads to rebirth, cradle to cradle. There is no death in nature. Same thing can be adopted for dialysis unit, where the dialysis components are produced, they are used, and then they are recycled. So this is called cradle to cradle approach. As you can see, the nature utilizes everything on the right side, whereas the man-made things we are discarding, and we should learn to follow the nature, and the technical cycle should also be like a biological cycle where everything generated is utilized and regenerated. And finally, This concept of green dialysis can be expanded into green nephrology, and this is the Russian doll model, which means that the smallest Russian doll is the patient population on dialysis. The bigger Russian doll is those patients who are on pre-dialysis care. Then the yellow doll, which is slightly bigger, is population with CKD prevention. And the blue one, the holy grail, is education and interaction with the environment. So the universal theme should be prevention, education, so that a minimum population goes on dialysis. This is the Russian doll model. Ladies and gentlemen, I conclude by saying that we have wrapped the nature in plastic, and the nature has gotten back at us in the form of COVID epidemic, which we had last 2 years. And the nature has wrapped the human beings in plastic. And this is going to recur if we don't open our eyes and save our environment. So dialysis waste management, this post by Dr. Agar says, why won't anybody listen? I conclude by saying that they will, provided we nephrologists make them listen. So thank you all for a patient hearing. And if there are any questions, I'll be happy to take.
Thank you, Dr. Manisha, for your excellent talk. And you shared us the secret of how to turn our dialysis rooms into green area. I think I have a question. What was your waste load during the pandemic? I'm sure it have been different. Your unit uses single-use dialyzer, single-use everything, no reuse. Was there any?
Absolutely, sir. So very pertinent question. So this study was done before the COVID pandemic. And during the COVID pandemic, our load did not increase much because as per the hospital policy, the COVID center was the Gandhi Hospital. But from the studies which have reported dialysis and COVID pandemic, you rightly said, it again added to the whatever load we had existing. So 1.2 kg per person per dialysis session is generally what is the regular dialysis load, which has been described in the Western world, and same load our study found as well. But this must have been multiplied at least 1.5 times during the COVID pandemic. And as you said, we do perform single-use dialysis. Again, there are pros and cons of it, as I already alluded to in the lecture. So though it's preventing the bloodborne viral infections and the exposure of the people working in the dialysis unit to the sterilant, that's the plus point. But again, it's contributing to a lot of biomedical waste. So we have to, I think, rethink, reuse.
Thank you.
Thank you, Manisha. I think that was an excellent talk. You covered all the points, and I congratulate you on excellent study at your institute. I think the first in the country. I think we need more of that. Just one point, another way which they have suggested is that we all use a standard dialysate flow QD of 500 ml per minute. That can be reduced. And it has been shown that even if you use 400, that can make a lot of difference, because many patients don't usually have a very high blood flow. So if you just keep the ratio okay for around 1.5:1, that should be okay. So another way is to reduce the QD.
Absolutely.
I think you've done very well. Chat box.
The other thing was one more thing which can be added is we are using those plastic cans for the dialysate, plastic cans. Instead of that, we can have an online dialysate preparation system, which would do away with the plastic cans. So this would reduce the plastic waste by almost 95%.
Sure. Thank you, Manisha. I think we are running out of time. We had an excellent session, and we close the session and go over to the next set of foreign talks. Thank you very much.
Thank you.
And thank you, Dr. My co-chair as well. We thank the organizers.
Thank you, ma'am, for that enriching talk. The next session for the day is by a renowned international speaker, Dr. Camille Cotton, on approach to post-transplant pneumonia. We have with us chairpersons, Dr. Shyam Bansal, Director Nephrology at Medanta Medicity, Gurugram, and Dr. Girish Narayan, former head of nephrology and former superintendent from Osmania General Hospital and Medical College, currently working as a senior consultant nephrologist at Uday Omni Hospital, Hyderabad. I request the chairpersons to kindly take over the session and introduce the speaker, please. May I please request Dr. Girish Narayan sir to kindly introduce the speaker?
Now, may I request Dr. Jha or the other Dr. Shyam Bansal to, because I do not have the required information about our guest.
So Girish sir, it's being displayed on the screen, sir. If you can,
now it has
Dr.
come.
Shah. Yes, sir. Please, sir. Go ahead, sir.
Yeah. Good evening, everybody. It's a pleasure to be associated with this WINICON conference, first of being held in India. And so now it is a pleasure to introduce our guest speaker for today, Dr. Camille Nelson Cotton from USA. She is an associate professor at the Harvard Medical School, and she has been president of the Transplant Infectious Disease Section and the Transplant Society. She is the first transplant infectious disease specialist to be counselor for the Transplant Society from 2020 to 24, and has been authored for severe versions of the 3 versions of the American Society of Transplantation travel guidelines, and an author of CDC Yellow Book chapter on immunocompromised hosts and travel for past decade. Her clinical interests include vaccination to the transplant candidates, recipients, the cytomegalovirus, the zoonosis virus, and the travel to the tropical countries. I'm sure this is a topic which is of interest to almost all the transplant physicians and surgeons, and because we know that this is one of the important causes for the increased morbidity and mortality in the transplant patients. So now, without wasting much time, I request Dr. Camille Cotton to present her talk. Is she online?
I am here.
Yeah, good evening.
Good
For
evening.
you, it is a good morning. Yeah, please go ahead.
Everyone, it's a pleasure to be with you today to talk about the approach to post-transplant pneumonia. I'm Camille Nelson Cotton, and I work at Massachusetts General Hospital in Boston, where I am a clinical transplant infectious disease specialist. So pneumonia in the solid organ transplant recipient is a pretty large topic, and I think that's why I was asked to speak about it. As you can see, the differential diagnosis of pneumonia is quite extensive in solid organ transplant recipients. There are a whole host of viral infections, some community, some more of the opportunistic infections. There are a whole host of bacterial infections, as you can see listed there. Fungal infections, and those can vary quite a lot depending on where you are in the world and various exposures and risk factors, various parasites, including Toxoplasma strongyloides and Echinococcus. And then interestingly, there are a whole host of non-infectious etiologies, and I'll talk a little bit more about that. So the question is, when you're seeing a solid organ transplant patient with pneumonia, how do you pare that down? So there is a really helpful concept of the timeline of infectious complications after solid organ transplant. And there was a great chapter just written in a book that I edited on emerging transplant infectious disease issues. You can see that after solid organ transplant, we think a lot about the first 4 weeks after transplant, when we worry most about nosocomial pneumonia. And then the first year after transplant is when we think about those opportunistic infections, reactivation of latent infections. That's when we tend to see more cytomegalovirus, nocardia, Mycobacterium tuberculosis, Aspergillus, Mucor, Pneumocystis, Strongyloides, Toxoplasma, Cryptococcus, that type of thing. And then usually when people are more than 12 months out, that's when we tend to see more of the community-acquired infections. However, I often say patients don't necessarily read the textbook, and so you can see a lot of variation in this overall schema. I do think it's helpful to just think about the timeline and when there is the period of highest risk for opportunistic infections, which is usually that first year after transplant. Although it can go on longer than that, and especially if we treat for things like rejection with higher doses of immune suppression. So things that can be key features of the history include recent hospitalizations or illnesses, at which point they may have a higher risk of nosocomial or more resistant pathogens. What type of exposures do they have in their community? Are there sicknesses circulating in the community that might be a risk for them? What is their immunization status? Have they had their appropriate vaccinations? What is the amount of time since transplant, as I mentioned? Are they still on prophylaxis with trimethoprim sulfamethoxazole, or are they many years out from transplant? What comorbidities do they have that could increase the risk of opportunistic and other unusual infections? And then what is their net state of immune suppression? How many medications are they on? What are the doses? Have they had recent rejection? And then how sick are they when they present? So all of those can go into the equation. There are a whole host of epidemiologic risk factors that you can see listed here. And I think that this should go into our calculation. I could probably give an entire lecture on this topic alone, but these should, recent travel, exposures, water supplies, gardening, animals, seasonality, and then nosocomial infection are all things to take into the risk equation when you're seeing someone with pneumonia. What tests to send initially? Well, I think it's good to send a complete blood count with differential, electrolytes, check kidney function, check liver function, and then usually start with a plain chest x-ray, possibly going on to chest CT scan. Often non-contrast is fine for standard pneumonia evaluation, although you can't see the lymphadenopathy, but that's not usually an issue. And I'm a friend of nephrology, so I try to avoid contrast. It's important to realize that up to 25% of patients can have a clear chest x-ray at the time of presentation of pneumonia. And then do viral testing, especially obviously COVID-19, influenza, other respiratory viruses, send sputum for gram stain and culture, and possibly also stains and cultures for things like acid fast bacilli and fungus. And then blood cultures are important as well. A good number of people can be bacteremic with pneumonia. And just as an example, and I'm not sure what all of you have in your individual centers, and even in the United States, it varies a lot. But in immunocompromised patients in my hospital, we are allowed to do a panel like this where you can see a whole host of pathogens. And this is actually quite helpful, especially if we diagnose someone with a virus, then we don't need to use antibiotics, which can be quite good and helpful, reduce the risk of complications. Regarding chest imaging, now I think it's good for all of us to be at least know preliminarily what findings there are in a chest x-ray and how to best interpret it. Things like consolidation often reflect fungal infections or mycobacterial infections or possibly nocardia, that type of infection. Bronchopneumonia can be atypical bacteria or community-acquired viruses. Diffuse infiltrates is often viral, but can be pneumocystis, but could also be pulmonary edema or hemorrhage. Nodular infiltrates, which can sometimes look like a multifocal consolidation, can be CMV, but also bacteria or septic emboli, or sometimes pneumocystis, or sometimes Legionella. Can be a whole host of things. Adenopathy is more commonly seen with mycobacterial disease, PTLD, sometimes cryptococcus, sometimes cancers. And then pleural effusion is something that should be evaluated. It could be there for a whole number of reasons. I was always taught that never let the sun set on a febrile patient with a pleural effusion without doing a thoracentesis. So I do think that that's something important to work up further. Now, unfortunately, I love this slide. This was written by a real expert in the field. You can see that you really can't tell anything necessarily, like a definitive diagnosis, based on the chest CT imaging. And so many things will mimic other findings, as you can see here, the mold looking like Klebsiella. So I would be cautious when you're interpreting this. So basically, the best thing to do is go ahead and look at the patient, think about all the risk factors that I've mentioned. And if they have a low risk for an opportunistic infection with a non-severe presentation, if it's okay to treat them probably as an outpatient, potentially as an inpatient. But if you're worried about nosocomial pneumonia, consider maybe a broader antimicrobial regimen. If you're just thinking it's a routine bacterial community-acquired pneumonia, it's okay to choose antibiotics based on local susceptibilities. And then depending on what the exposure history is for a specific pathogen, you sometimes can target one specific pathogen. You know, if they're testing positive for influenza, you could just treat them for that. Sort of depends on the case. And then if you're really worried that they are at moderate to high risk for opportunistic infections or severe presentation, proceed to an expanded evaluation with a broader empirical therapy, maybe thinking about fungi or other things. Here's the algorithm. So if they are higher risk, or if they're failing the initial treatment, go on and think about additional studies as listed here, blood cultures, sputum cultures, maybe do some serology testing, especially for endemic fungal infections, perhaps histoplasmosis. We published a series of that from India not long ago. Look at Legionella urine antigen, fungal testing, CMV. Consider doing a chest CT scan, and then consider doing a bronchoscopy, sending for various specimens, and the bronchoscopy as well, depending on whether or not you've done a biopsy. But do send broadly. Many of us would be consulting a pulmonologist at that point. And again, the diagnostics that you would send would depend on availability in your own laboratory. I do want to emphasize that the differential diagnosis of pneumonia in solid organ transplant patients includes non-infectious etiologies. So a good transplant clinician knows to look for mTOR-induced pneumonitis, which would be like rapamycin pneumonitis. Seen that not infrequently, especially with reduced renal function. Other drug-related pneumonitis, pulmonary embolism, pulmonary hemorrhage, pulmonary edema, volume overload. You know, volume overload, I've seen it so many times, and it can look exactly like pneumocystis. And clinically, the patient feels poorly, is hypoxic, etc. So lots of overlap. Also, hepatopulmonary syndrome is something that we see, especially in patients with liver disease, lung tumors, either primary or metastatic, and then post-transplant lymphoproliferative disorder. So if somebody's not improving, it may be infectious, but it may not be infectious, and that's where you should pursue additional diagnostics, thinking broadly. I want to go through a couple of cases. The first one is a 56-year-old woman who had non-ischemic cardiomyopathy, initially had a left ventricular assist device, now has a heart transplant. Her heart transplant donor was positive for hepatitis C, so we used that donor heart and then treated her for hepatitis C. She's on valganciclovir and atovaquone, and she had a lot of acute cellular and humoral rejection with aggressive treatment of that rejection. So her net state of immune suppression is high. She was admitted to the hospital a year after transplant, was found to have left upper lobe pneumonia, also altered mental status, and brain lesions were found by CT scan. And I'll show you. That's the left upper lobe pneumonia that you can see there. The left upper lobe pneumonia again. Again, another view, pretty socked in, pretty, good left upper lobe pneumonia. And then here are the brain lesions that you can see, which is ominous. So right there, you're thinking, brain pulmonary lesions. So you're thinking fungal or nocardia for the most part. Could be bacterial, somewhat less likely. So fungal markers, non-diagnostic tests were all negative. Bronchoscopy showed thin branching gram-positive rods. Brain biopsy showed the same. And she was diagnosed with nocardia. We initially started her, we almost never used trimethoprim sulfamethoxazole because transplant patients tend to not tolerate it very well with high potassium and higher creatinines, etc. So we actually gave her imipenem, thinking hard about which was better, imipenem or ceftriaxone as a first pass. We also gave her linezolid. And then she was switched to ceftriaxone once we got susceptibilities back on what turned out to be nocardia nova complex. We did intravenous for 3 months, followed by azithromycin out to a year. And she did well. The brain lesions resolved, the chest lesions resolved. Her bronchoscopy fluid galactomannan was quite positive at 2.5. Cultures remained negative for fungus. She was started on voriconazole. So what else needs to be done for a transplant patient when you start them on anything that ends in azole? You need to reduce the tacrolimus. And you can see here that her tacrolimus dosing was fine, kind of in the 5 to 10 range for the most part. Voriconazole was started And you can see her tacrolimus levels went up to 25. So always, and then it took a long time to really get them down to sort of target range, which was a real challenge. So always remember to cut the tacrolimus dose in half at least when starting voriconazole, and trend those levels carefully. There she is a month later, much improved, and she actually did quite well. So happy story overall. But just always remember that it could be more than one thing, and then remember the brain lung syndromes that you can see with nocardia and fungus. The next one, similar but different, 2 years out from kidney transplant on tacrolimus, prednisone, mycophenolate mofetil. No major risk factors for infection. He's working as a professor, doing well. He had this small pulmonary nodule noted, and they said, okay, well, the chest CT was done for a different reason. They said, we'll just follow up on that in 3 months. Of course, 2.5 months later, he came back with fevers, cough, and chest pain. And there it is, much bigger, right? Like, oh no. So given how ill he looked, we pretty quickly went to bronchoscopy. But upon further questioning, he and his wife expressed concern about birds that nested in their bathroom vent for quite a while. She had gotten bird mites from the bathroom vent. This is just pictures from the internet, not from their own home. But so bird exposure, pulmonary lesions, what are we thinking about? Maybe somebody in the audience is yelling it right now. But Cryptococcus neoformans. Okay, so we see this. I think I told you that that usually happens in that first year after transplant, but sometimes people forget to read the textbook, so sometimes it happens later. Clearly, the exposure would have been the birds nesting in the vents. He also had this by brain MRI, so pretty significant lesions, a cryptococcoma. Interestingly, his blood serum cryptococcal antigen was negative. When repeated, it was positive, very low level at 1 to 2. His CSF showed 37 white blood cells with 90% lymphocytes. Glucose was somewhat low, protein not very high. It was culture negative. He ended up getting ambisome for 2 weeks with 5-FC. The repeat lumbar puncture was much improved, and he was switched to fluconazole 800 milligrams a day. And then we reduced his tacrolimus. As I said, always reduce the tacro when you're starting anything that ends in azole for the most part. And then he's going to be on long-term fluconazole treatment. And he's done really, really well. And they got rid of the birds. Zoonoses are everywhere. I do caution my patients to stay away from birds as much as possible. The last case I want to show you is a 64-year-old woman who had a kidney transplant. She had induction with antithymocyte globulin, and she was maintained on tacrolimus, prednisone, and mycophenolate mofetil. After transplant, she was highly sensitized. She had early humoral rejection, so she was on higher doses of immune suppression. So already there, you're a little worried that she's at higher risk for infection, even more than a year out from transplant. Chronic parvovirus infection was treated with IVIG and slowly resolved. I never like that, chronic parvovirus. That's always kind of ominous. She comes back 4 years after transplant with progressive onset of malaise, low-grade temperatures, dry cough, and found to have significant hypoxia, ground glass opacities, and tree and bud opacities on chest CT scan. And she has a positive test for influenza B, even though she'd had the flu vaccine 5 months earlier. You know, we do think the vaccines are good and at least partially protective. We do tend to see that the vaccine efficacy wears off 4, 5, 6 months after administration of the influenza vaccine. So that's her initial chest x-ray upon presentation. You can see diffuse reticular disease, especially in the lower lobes. And then 4 days later, it looks a lot worse, a lot more nodular. Definitely a worse situation. So additional data that came in were that her 1,3 beta D glucan was super high, at greater than 500 in her blood. Her serum galactomannan was also very high. This is rarely positive, but hers was 2.6, highly suggestive of invasive aspergillus, both of those together. Her bronchoscopy, she was intubated. Bronchoscopy showed a very high galactomannan in her bronchoscopy fluid of greater than at the upper limit of the assay. 4 different cultures grew Aspergillus fumigatus. She was treated initially with isobuconazole because of concern about drug interactions and acute renal injury. And then because she was so sick, we gave her Ambazome 5 milligrams per kilogram. And unfortunately, she became progressively worse. Comfort measures were enacted per family request, and she passed away. I'm sure that this case won't be surprising to any of you, having taken care of so many COVID patients in India who then developed invasive mucormycosis. And I think all of us are quite familiar with this viral infection that then has a superimposed fungal infection and can cause life-threatening disease, really tragically. There was a really nice series from the Netherlands. I just don't have enough time to talk about it all, but then talked about influenza followed by fungal infection. So this is something to really respect. And I think really encourage vaccination, because patients may not die always of influenza directly, but the superinfections can be quite significant. So always remember to monitor for superinfection in these patients, especially when they take a turn for the worse. So just in conclusion, approaches to post-transplant pneumonia. I think, first of all, common things happen commonly. And so it's always good to think about common things that might happen, but also think about unusual diagnoses with the initial workup. So what is, what might be different or atypical, or what may make you think something different is happening rather than the common things. Think about the individual patient, the net state of immune suppression, the overall risk of opportunistic infections, and a careful history can really be quite helpful. Monitor closely, and if things don't improve, proceed with additional diagnostics. Really good to have a good handle on what additional diagnostics are available in your own clinical setting. Also think about your antibiogram and what antibiotics and antifungals are more likely to work based on local resistance patterns. And just to conclude, sometimes in transplant medicine, Occam's razor, which is, what is the most likely simple diagnosis to fulfill the clinical setting. Sometimes it's right, but Hickham's dictum, which is that patients can have as many diseases as they darn well please, is also something that we see in transplant patients. So I think always be thoughtful and considerate and think about alternative diagnoses. So thanks very much for your attention, and I'm happy to have questions.
Yeah, thank you, Dr. Kamil. Sorry, I joined slightly late. So for an excellent talk and insight into the chest infection post-transplant, as always. So before this opening the session, I just like to see one of the questions Dr. Kamil asked, whether this panel is important in most of the hospital. I think in the tertiary care hospital, we do have these panels for pneumonia, which include the viral and bacterial infection, of course, but then there are sometimes problem with the fungal diagnosis. So if suppose if somebody has this galactomannan or beta-2-glucan, which is slightly positive in these patients, and you don't get anything in the lung by bronchoscopy, so would you actually consider giving the antifungal to these patients? And what would be your approach if we are not able to get anything in the bowel or bronchoscopy, and we get positive maybe 1.5 or so beta-2-glucan or serum galactomannan?
Thanks. Nice to see you. That's a great question, one that we struggle with. And in fact, we were even discussing yesterday at work. I think it depends on the individual patient, the chest imaging, your impression of their risk of possible fungal pneumonia. I would take a serum galactomannan usually quite seriously, because that's really pretty suggestive of invasive aspergillosis. So I think galactomannan, almost always I would initiate antifungal treatment unless there were a really strong alternative explanation. Unfortunately, galactomannan is really very rarely positive in the blood, but when it is, I usually would treat. Glucan, beta-D-glucan can be false positive for so many reasons. I find it to not be very useful, and I often find it to be misleading. And so I think if you have a very strong suspicion based on radiology, based on clinical progression of the patient, then I would consider antifungal treatment. But otherwise, it may be from, there's a whole host of reasons why you can have false positive beta-D-glucan. And so I wouldn't necessarily treat in that scenario. So I think it requires further thought. My personal favorite is the cryptococcal antigen, because when that's positive, you're always sure that there's cryptococcal disease. But the others, less so, especially beta-glucan. That's a good and challenging question. Somebody asking, can galactomannan be positive in tuberculosis? And it should not be positive with tuberculosis, but you could, as I said, you could have two concomitant infections. Sometimes we see that, unfortunately.
Yeah, it's because see in India, I see we see a lot of tuberculosis. So many patients who have fever, who have undiagnosed cause of persistent febrile illness for some time, and then you are not getting anything, and then you have to do these tests. And sometimes we recently have such a patient, but beta-glucan was positive, 3.5 or 6 value, not very high. But then nothing is coming out of the bowel or something, and then whether you start antifungal or you actually start anti-tubercular, because this is much more common in India as compared to the fungal. Obviously, that is a possibility. So that's a thing for. So, Dr. Girish, sir, would you like to? Yes, sir.
No, she has highlighted a very important, but one question I wanted to ask Dr. Kevin, how sensitive and specific is the galactomannan value, serum values, without any obvious radiological lesions, either in the lung or anywhere else? Based on this serological value, is it advisable to treat the patient with?
So, well, that's a great question. If you have completely negative chest imaging and you're not worried about invasive fungal disease elsewhere, I guess I wouldn't send the test to begin with. If for some reason you're presented with the situation, maybe the chest imaging is slightly abnormal, and you have a positive blood galactomannan, which is really rare. We had to screen Dr. Prasad in our institution actually looked at the number of times that we sent galactomannans and the number of times it was useful. And in many thousands of times, it was only useful like 20 something times. So galactomannan is not such a great diagnostic, but if it's positive, I think in general, you would probably want to do a bronchoscopy, see if you can confirm the diagnosis. And then I would have generally a fairly low threshold to treat unless you have an alternative explanation for the chest imaging and an alternative explanation. It is for the galactomannan. I think in general, we really want to avoid progression of invasive fungal disease. I would also speak to your laboratory and just confirm that they had, no problems with the test and that their testing scenario seems to be going smoothly, I guess.
So I think it is very important to keep an open eye to all the infection. We recently, Dr. Kamil was also part of that, published this series on histoplasmosis, although it is very uncommon in our place, but there were 5 patients and we then thoroughly investigated and found that pulmonary histoplasmosis and all that is there in India. So this diagnosis should also, because this is very much confused with tuberculosis in India. One thing you highlighted in one of your cases that you use isobuconazole in a patient with a fungal infection, aspergillosis. So we usually here use voriconazole. So does it has replaced, means this is like become the first line drug now, or means they are almost same, or you can use any of them if you have invasive aspergillosis?
Well, I think it depends on the individual case, and then in our setting, what's covered by insurance. Isobuconazole has fewer drug interactions, especially with the transplant medicines, and then it doesn't have the QT prolongation issues that voriconazole and posaconazole can have. I would say that I'm fine using voriconazole for invasive aspergillus. I usually use posaconazole with mucormycosis. Isobuconazole is approved. We have seen more breakthrough candidal infections with isobuconazole. I think they're all very good for treating invasive aspergillosis. I will say that if I have a severe case of invasive aspergillosis, I often start with ambisome, the lipid formulation of amphotericin B, and we'll treat for maybe 5 to 7 days, or depends on how severe it is. Also, if there's CNS disease, I might treat for longer. Amphotericin B is fungicidal and the azoles are fungistatic, and it can take longer to get to therapeutic level with the azoles. So I often I call it kind of like induction therapy with amphotericin B products, followed by consolidation with azoles. But I think voriconazole is fine. I would do a loading dose and then follow trough levels. And obviously follow your calcineurin inhibitor.
The total duration of therapy, Dr. Kamal? The total duration of therapy.
Yes, so that's something I struggle with, and I wish that there were parameters that could be globally applied, but I think you really need to follow the patient and the imaging. And once you have good resolution, sometimes, you know, it might be 2 or 3 months for chest disease, depends on the burden. With things like CNS disease, I often treat much longer. So sort of depends on the location and the extent of disease, and then radiographic response. Somebody who's 5 to 10 years after kidney transplant may actually resolve their infection fairly quickly, whereas somebody who has had, you know, really intense immune suppression and doesn't have such a robust immune system will probably need a longer course of treatment. So it is tailored to the individual patient.
Yeah, Dr. Kamil, just the last question I would like to ask you. See, you have done a lot of work on COVID, and COVID is still there, and some patient with transplant patient, they come with pneumonia and it's COVID. So what is your approach to treating those patients? What do you do with immunosuppression, and do you use any particular agent in these patients, or it's a general supportive treatment?
So we generally give patients with COVID, we usually give monoclonal antibody, bebtelovimab, if they are outpatient because of the way it's licensed in the United States. Or if they are inpatient, then we give remdesivir. If they have significant hypoxia, we give dexamethasone. And we usually reduce their antiproliferative, either usually CellCept or Myfortic, by about 50% temporarily while they're sick. We were just discussing this week whether with patients who are now very well vaccinated, many of them have gotten the pre-exposure prophylaxis monoclonal antibody Evusheld, and we're actually seeing very mild disease in transplant patients. So we're sort of wondering what the best approach now is to altering their immune suppression, and should we be doing it at all? We still like the general idea of maybe at least for a week cutting their antiproliferative in half. There is the antiviral agent Paxlovid, but we have not used that in our transplant population unless they are not on tacrolimus or sirolimus or cyclosporin because of the profound drug interactions. And we've seen some major toxicity. One of the lung transplant recipients at our sister hospital was given Paxlovid by the primary care doctor, and the drug levels were, I think it's a different system, but we're about 25 times higher than the target. So we're about 100 compared to a usual tacrolimus target of 5. So that's significant toxicity. Sorry, that's probably hard for nephrologists to hear. I know you don't like tacrolimus toxicity. The patient did okay, but those drug interactions are profound. I do think it's time to keep, make sure that your patients are really well vaccinated and ongoing doses of vaccine. In the US, Moderna and Pfizer will be releasing within the next month or 2 a bivalent vaccine that covers both ancestral Wuhan strain of COVID and then the Omicron strain. And we're hoping that that will provide additional protection for transplant patients.
Thank you. Thank you, Dr. Kamil, again for this wonderful talk and your answers. They were so. I would just from conference and from the organizers from the Indian Nephrology, I would like to thanks for a wonderful session. Thank you, sir. Thank you, Dr.
Thanks very much. It's wonderful to be with you all.
Thank you, Dr. Camille Cotton. That was a very interesting case-based approach to the topic. Thank you, chairpersons. So we now move on to the session by Dr. Liz Lightstone on the topic lupus nephritis, paradigm shift in treatment approach, farewell to induction and maintenance. Chairing this session are esteemed chairpersons, Dr. Muthu Jayaraman, Senior Consultant Nephrologist, Bharati Raja Super Specialty Hospital, Chennai. She is joined by Dr. Neela Prasad, former professor and head Department of Nephrology, Nizam's Institute of Medical Sciences, Hyderabad, and also joined by Dr. Manish Rathi, Professor, Department of Nephrology, PGIMER, Chandigarh. Without further ado, I hereby request the chairpersons to take over the session and kindly introduce the speaker.
Thank you. Thank you. Thank you, Win India, for asking us to chair this great session on lupus nephritis. At the outset, I would like to congratulate the team Win India for conducting such a wonderful conference with a great content and speakers. You all will agree that today's speeches and academic content were far excellent, on par with international needs. So with that, congratulating the team, I move on to the subject. Today's topic is management of lupus nephritis, a paradigm shift, and saying farewell to the induction therapy. As nephrologists, we will be very happy to welcome this topic, and it's a much needed subject, you all will agree. Because for the past 2 decades, we were managing lupus nephritis with the 2 sets of guidelines. One is GEDIGO, which says steroid induction with MMF, and the Euro-lupus guidelines, which insists on cyclophosphamide and steroids, and with the reduced days of maintenance. But with this therapy in the last 2 decades, we could improve the 5-year survival of lupus nephritis for more than 80%. But the long-term survival at 10 years, about 30% of them move on to ESRD. So far, right now we have 3 new medicines have come on board. One is voclosporin, that is CNI, modified CNI molecule, and 2 is the belimumab, which is another B cell modification drug, and 3rd is the popular rituximab. But Ritex has shown that not great improvement in the outcome, but still it is used in resistant lupus. So we hope today's talk by Professor Liz Lightstone from Imperial College London and as a professor of renal medicine to tell us how the new paradigm with the farewell to induction and maintenance with the new drugs is going to change the outcome of long-term outcome of lupus nephritis. For example, how it will change, reduce the inflammation, which leads to AKI, reduce the flares, which saves the nephrons, and reduce the injuries to the photocytes, that reduces the proteinuria. So with that introduction, I request Professor Liz Lightstone to give her talk. on lupus nephritis,
Hello,
parallel
and
induction
thank
and
you so much
maintenance. Over to
inviting
you,
me to the
Professor Elise.
WINICON conference. It's a real pleasure for me. I've watched Women in Nephrology India grow in the last couple of years, and that's through my involvement with Women in Nephrology, and I'm an enormous fan of what you've been doing and achieved. And I'm also heavily involved with the International Society of Nephrology, so there's double reasons for being delighted to be here this afternoon. And I was given a title without a question mark, but I decided to add the question mark: Lupus Nephritis, Farewell, Induction and Maintenance, question mark. These are my disclosures. I think there's a couple of slides I've marked with don't tweet. It'll be obvious which they are. Please don't tweet unpublished data. So when you're thinking about managing lupus nephritis and what we're trying to induce and maintain, you've got to think about what we're trying to induce and maintain. And I think there's a fixation on treatment regimens rather than what we're trying to achieve, and that's what I'd like to move you away from moving towards thinking about. And you need to think about the standard of care and how the new disease modifying agents work in terms of when they should be used, which we summary don't know yet, and to also realize that there's much more to managing lupus nephritis than just managing the immunology. So I want to tell you about a patient of mine who I've known for some years now. When she first presented to me, she had a history of type 1 diabetes. She'd been diagnosed a few months earlier with lupus and was only on hydroxychloroquine, for which it was treating her arthralgias and fatigue and alopecia, and she'd been fine. But then she developed edema and breathlessness with increasing fatigue and was referred to us because she was found to be nephrotic with gross fluid overload and severe hypertension, and in fact severe renal dysfunction with an EGFR of 23 mils per minute and a serum albumin of 20. I'm not sure what units you're used to. This is milligrams per millimole. Milligrams per millimole. This is about 7 grams a day. She had strongly positive ANA, positive double-stranded DNA, and when we first met her, she had a normal complement. This was a biopsy, and happily it showed no chronic damage, but floridly abnormal glomeruli with global changes, where you can see far too many cells. There's almost no open loops, which is why she had very poor function, and she had loads of macrophages. This was a really active lupus nephritis. So when you're thinking about standard of care, and I would think that most of you would accept that the current standard of care is steroids plus mycophenolate or steroids plus cyclophosphamide, the outcomes in all the trials are largely guided by levels of proteinuria rather than function, and that's fallen over into KDIGO. So these are the KDIGO guidelines from 2021. They define a complete response of reduction in proteinuria to less than half a gram a day. They also say you should do a UPCR for a 24-hour collection. I never do that, except in a trial, and that stabilization or improvement in kidney function within 10 to 15% of baseline. Well, I don't want that young woman to be within 10 to 15% of a baseline of 23 mils per minute. I want her to have normal function. And within 6 to 12 months of starting therapy, or a partial response, which doesn't mention function at all and just talks about being non-nephrotic and a 50% reduction in proteinuria. What matters to patients is the long term. You've got to preserve kidney function long term, and you need to do that by preserving nephrons. And you need to treat promptly. So give methylprednisolone plus, but methylprednisolone is your fast friend. You need to prevent kidney flares, and that means you need to think about the additional immunosuppressants and also adherence. And you need to think about immunological and non-immunological treatment. Sorry, every time I touch my desk, my slide moves on, so I apologise in advance, there'll be a lot of that. And you want to promote long-term health. And I do have a particular angle here, which I think is fairly obvious from this slide, but to prevent organ damage, to reduce morbidity and mortality, to prevent treatment-related toxicity, and to control morbidities, the most important thing you need to do is reduce the steroids. And of course, you need to improve quality of life, including preservation of fertility. So I would argue you need to minimise cyclophosphamide. And lupus nephritis is very complicated. You're looking after people for many years. She's the first presentation for lupus nephritis, but we're under no illusion she's only going to have one. The problem is we don't know how many she's going to have, and we don't really know who's going to flare. So lupus nephritis is a frequent manifestation of lupus, and it's a significant cause of morbidity associated with cardiovascular disease, infection, drug toxicity. there is this concept of induction and maintenance. And we know from old data that high-dose cyclophosphamide is associated with a great deal of toxicity. Complete clinical remission is rare and probably so in real life, though I think it's more common in real life than it is in trials. And urinary proteinuria, or proteinuria, is a marker of damage as well as activity. So it's not an ideal marker that you're doing well. Lupus and lupus nephritis flare, and I think there are very few patients who just have one episode and we never see them again. Well, there are patients we never see again, but it doesn't mean they don't flare. And I would argue that most flares are due to non-adherence or withdrawal of therapy, not failure of therapy per se. And there is a concept of really difficult lupus, refractory lupus nephritis, but there's no really accepted definition. This is my favorite graph at the moment, and it's shamelessly stolen from Achim Anders, and I thank him for it. But it's this concept that we have a fixed number of podocytes and nephrons over time, and some of us are born with more and some of us are born with fewer, but we all lose nephrons over time. So none of us are going to get to 120 without needing dialysis, probably. But a single episode of lupus nephritis, you've shifted that curve to the left very rapidly. And then if you keep doing that, you're going to end up in renal failure. Even if you've only had a couple of episodes of lupus nephritis, it's why your patients burn out over time and end up with impaired renal function over time. And that's the commonest trail to end-stage kidney disease that we see. So you need to hit hard and early, and you need to prevent flares to preserve function, because that's how people stay alive. Because lupus nephritis predicts mortality. This is from a large study in Norway, and this is the standard mortality ratio for lupus nephritis and non-lupus nephritis in patients with SLE. And you can see, particularly in this younger group, hugely increased standardized mortality ratio in those with lupus nephritis compared to those patients who never had lupus nephritis. And the current focus is all on the immune system. And clearly you need to tackle the immune problems in order to treat the underlying nephritis. But if you think about diabetic nephropathy, or you think about lupus nephritis is the way you think about diabetic nephropathy, you've got to treat the whole person, and you've got to treat and preserve kidney function beyond the immunology. And if you treat lupus, then you're going to treat the lupus nephritis. And as we all know, if you treat lupus nephritis, they're often much better from less systemic lupus. And the injured kidney needs looking after to maximize kidney lifespan. I'm not going into histology, but this is what we're talking about mostly. Class 3 to class 4, proliferative lupus nephritis, and class 5 is membranous lupus nephritis. And some of the recent trials have excluded class 5, but some haven't. And the guidelines still all talk about induction and maintenance. And it's true, I think, that you need to be thinking about inducing remission. But the problem is nobody can, well, I don't agree with having to use the term remission. What is remission? But I don't think we should be thinking about induction and maintenance in terms of treatment strategies, because some of the treatments we use all the time. The only one that we really use as an induction is cyclophosphamide, and we sort of stop that at a fixed time, regardless almost of whether they're in remission. So it doesn't quite fit. And we also need to consider relapse-free survival. If you think the relapses cost you nephrons, then you don't want patients flaring. So these are the KDIGO versus the EULAR guidelines. EULAR were published in 2019 and KDIGO last year. And KDIGO is still, I think, a bit steroid heavy compared to EULAR. So I prefer the EULAR ones, which start you on lower doses of methylpred. No one should be having more than 0.5 gram of methylpred at one time, and lower doses of oral prednisolone. And that fits with more recent trial data. Interestingly, in 2019, before voclosporin data came out, EULAR was saying you could start with a CNI, but for a limited time. So if you like, that also slightly comes under induction rather than sort of continuous therapy. And then maintenance, you essentially, if you're on MMF, you stay on MMF. If you've been on cyclophosphamide and you're Caucasian, you can have MMF or AZA, but I think for all other ethnic groups, you should be on MMF unless you want a pregnancy. So long-term MMF is the way forward, and minimizing steroids. So you can think about remission. If you're thinking about induction, you've got to know what you mean by remission. And in all the studies, actually, as I mentioned, it's focused on proteinuria. And some of that is justified by the work from Maria Delara and others, who looked at the long-term outcomes of the Eurolupus cohort and the ARMS cohort, and showed that actually you didn't need to achieve what we call complete remission, less than 0.5 grams a day at 12 months, to still have good function 7 years down the line. Now, you might argue that 7 to 8 years down the line is not very long if you're starting this at 23, 24. But we loosened our proteinuria targets at 1 year. Then if you're Anna Malvar in Argentina, actually, you don't accept that at all. And you say you need to know what's going on in the biopsy, and you can have patients who have activity on the biopsy without much proteinuria, and you can also have proteinuria due to damage without any activity. So she has this extraordinary regimen where she does a first biopsy and does what she calls induction, either cyclophosphamide or MMF, mostly MMF these days, does a second biopsy at now mostly 12 months, because 6 months is too early. Then she has them on maintenance therapy for a very long time, and then she does a third biopsy, and she only withdraws treatment if they have an activity index of 0. If they've got any activity, they get treated for longer, and sometimes they go through the whole thing again. And in her single center analysis, she had a very low flare rate compared with contemporary metrics. Not a single patient went into renal failure, and a relatively low number of patients needed to be treated to realize benefit. But this is very intense and it's very long term. And there's many patients who you're not going to be able to follow up for that period of time. So this again is stolen from Achim Anders, and this is the current approaches to treatment. Most people give everybody steroids and some methylprednisolone, and then you can choose from 1 to 5. And I think the commonest thing is to give a low-dose cyclophosphamide, because that has all the efficacy of oral cyclophosphamide, but grossly reduces total dose, or mycophenolate and And some people are using, particularly in China, tacrolimus and low-dose MMF with quite high-dose steroids. And then maintenance, you go on to MMF, AZA, and not many people are using long-term TAC, I think. What has shifted over time is the steroid dosing, and that delights me, and I will take a little bit of responsibility, but I really like this article from my colleagues in Mexico and Ohio, and I think this graph is very nice. Methylprednisolone pulses at the beginning, get in there fast and treat. And it's very clear that, that the higher your dose, then you get dose-dependent adverse effects, and you also get time-dependent adverse effects. So there's been a shift to lower maximum doses and withdrawing steroids and avoiding these high-dose steroids altogether. We haven't quite got there yet. I really like this graph. I used to do a sort of different version of it, and the blue line is the average daily dose, and the yellow is the total dose. And you can see that even in BLISS-LN, you were giving doses of steroids that were comparable to the ARMS. And even in Eurolupus, if you actually follow Eurolupus, you give large doses of steroids. We're the outlier up here. In Rituximab, where we have patients who are not on steroids, we don't give them any oral steroids, we just give them some methylpred. So that's what their total equivalent is. And then I'm going to come back to the voclosporin trials. And music to my ears, KDIGO said glucocorticoids should be tapered to the lowest possible dose during maintenance, except where they're required for extra lupus manifestations. I would argue you need other drugs if you're needing lots of steroids for extra lupus manifestations. And discontinuation of steroids can be considered after patients have maintained a complete renal remission for more than 12 months. I disagree with that. I withdraw them much earlier than that. So this is our data, and I don't want you to tweet this. I think my little video is going to be blocking my do not tweet sign. I'm going to try and move it because I want to show my colleagues, but it's Hannah Wilson, Hannah Beckwith, who brought this data together. 352 patients from their first biopsy with us, and at least 18 months follow-up, or if they died. And had protocol treatment. We've used a lot of protocols over the years, but rituximab, no oral steroids, rituximab rescue, no increase in oral steroids if they're already on them, IV cyclophosphamide. And what you can see is there's really no difference in time to renal replacement therapy, time to doubling their baseline serum creatinine, and their time to flare. The IV cyclophosphamide group go back far longer, so there's a lead time bias there. But what I'd like to highlight is that being steroid-free is achievable in the majority of patients. At 7 years follow-up, 67% of patients were no longer taking steroids, and 54% had a really well-preserved EGFR. That doesn't mean that 46% didn't, but this was over a 20-year period. And the Rituxi loop, 85% of them remained steroid-free. So if you start off with no steroids, you never need steroids. But it is also a mindset of the clinicians looking after these patients to get them off it. So to go back to how we treat, we address immune-mediated injury in proliferative lupus nephritis. You're trying to prevent the glomerular necroinflammation, hyperplasia and immunothrombosis, and IV steroids are critical to that. But you're also trying to treat what's going on in the lymph nodes, not just what's going on in the kidney, but what's going on in the systemic lupus activity. So we have disease-modifying drugs, and the old staples, cyclophosphamide, myphenate, don't use AZA for induction. And then there's voclosporin, the B-cell therapies, anifrolumab, and belimumab. So voclosporin is a novel CNI. It's been approved for use in lupus nephritis. It reduces T-cell activation, has a direct antiproteinuric effect on podocytes within 2 weeks. And it doesn't do much to the general markers of SLE activity or extrarenal activity. It does in some patients, but the minority. And when I first made this slide, we didn't know anything about its impact long term, but actually it was presented at the ERA, and there's now 3 years of data showing no nephrotoxicity or metabolic adverse events, because people have been saying, oh, you could only use these drugs for a year. And we think you can make a good antibody response to if you're on tacrolimus. There's no reason to think you wouldn't do that with voclosporin. I have to say, tacrolimus is a fraction of the cost. We're all very used to using it, so I wonder if that's what we'll be doing, and it's certainly not licensed in the UK yet. The reason I really like the Aurora trial is their steroid taper, because it's the most rapid steroid taper of any trial. They could have up to 1 gram of methylpred, and then the maximum dose of oral steroid anyone got was 25 milligrams if they were over 45 kilos, I think. And then they rapidly tapered down, and they were on 2.5 milligrams by 16 weeks. And they were a failure if they were still on more steroids at a later time point. So it was a large study. The phase 2 had some excess deaths in Bangladesh, and they didn't stop the phase 3, which I think was important because I think there were local factors. They had a very stringent primary endpoint, which was complete proteinuria reduction, because of course it's a CNI, and there was radical steroid sparing. We still don't have repeat biopsy data, which I think makes some of us anxious, but it met its primary endpoint by country mile, and it met all its secondary endpoints. And the odds of achieving renal remission, and it was a stringent renal remission, were 2.65 times greater than control, with a similar safety profile. So it was approved in January 2021. I think we'll all start using tacrolimus. As I've said, ERA guideline had that in its guideline in 2019, and as a nephrologist, we're very comfortable using CNIs. We don't know if it's just speeding up remission, but there was nice data presented at the ERA. What they showed over 3 years of follow-up was actually they got better adequate responses with voclosporin. The patients were much less likely to flare, and they had preservation of renal function, So whereas you had that initial drop in GFR, it was preserved or improved over time compared to the control group. So that's quite potent data, actually. It's very expensive, and I can't see it being approved for use in the UK. And neither is this drug. It is a sort of approved for use, but it's not funded or approved by NICE, which is anifrolumab, which was studied in the TULIP-LN study. Completely different drug. It works on your systemic immune response. It's an anti-interferon alpha receptor, so it's a broad anti-interferon. With the intense regime, more patients obtained complete remission and borderline lower dose of steroids, not very impressively. It appeared to reduce lupus flares. Where it appears to be really effective is actually in bad skin lupus. In 1 year of data, there was no nephrotoxicity or metabolic adverse events, but there was a very high rate of zoster, which they'd seen in the sort of phase 2, 16.7% versus 8.2%, and more flu. And it is worrying with COVID, because your interferon system is critical to fighting viruses, and this would worry me, I have to say. Well, there's loads of data out there about B-cell depletion or B-cell interfering B-cell activation, and that's using either anti-CD20, rituximab does, or obinutuzumab. or anti-Bliss with belimumab, and there's now years of experience with belimumab. So obinutuzumab is a much more potent CD20, anti-CD20 than rituximab, and it does it because it depletes faster and for longer. So rituximab takes a few weeks to deplete fully, and it's worn off, certainly in lupus patients, by 6 months. Obinutuzumab is within 2 weeks, you're completely depleted, and you stay depleted for at least a year. And the data are consistent with that. So whereas the LUNA trial was negative, this was the phase 2 study. And with the obinutuzumab, what they saw was improving and then stable complete response rates compared to placebo. And the obinutuzumab patients had a greater improvement in EGFR, urinary PCR, and serology, and fewer required addition of rescue therapy, which actually does mimic the LUNA study through to week 104. So if you deplete B cells and you keep them depleted, patients do well. And what was comforting was, despite that, actually the SAEs were higher in the control group than the treatment group, and I suspect that's because they ended up on more steroids. And the Regency trial, which is a phase 3, is underway. My worry is the thing we know stops you making anti-COVID antibodies is rituximab. And so we've often timed our rituximab so that patients can have a vaccine and make some antibodies and then have a memory response. But if you've got to treat someone who's then going to have 18 months of depletion, how are they ever going to get a proper vaccine response? And that is a problem. The BLISS-LN study, belimumab was added to induction and maintenance therapy. So the thing to point out when you're thinking about induction and maintenance is all these patients had these drugs from the very beginning in their studies. They were add-ons to standard of care. They weren't instead of standard of care. This was an enormous study that went on for years and years and years, giving belimumab and standard therapy versus placebo. And the primary endpoint was completely novel. It was at 2 years. It was using that more generous proteinuria endpoint that we talked about earlier, which has never been validated at 2 years. And then physicians could choose whether patients got MMF or cyclophosphamide, and 2/3 got MMF and 1/3 got cyclophosphamide. And then they went on to maintenance. And this, I think, is a flaw in the study because the cyclophosphamide group went on to AZA, whereas the MMF group went on to MMF. So they inducted and maintained with the same treatment. It was a large study. It had a 2-year primary endpoint, and it had this primary efficacy renal response of her. And they've done a very interesting post-hoc analysis focusing on renal function and flares. And it met the key primary and secondary endpoints. So the primary endpoint is very generous. So it's a GFR more than 60, which I think for a 25-year-old is rubbish. It was a urine protein creatinine ratio less than 0.7, which is fine. And they weren't a treatment failure, which meant they had to have reduced their steroids by 24 weeks to less than 10 milligrams and not have had rescue therapy. And they had to do this twice, which is quite stringent for a study. And the patients on belimumab had a 55% greater odds of achieving that at week 104. The secondary endpoint of week 104 was complete renal remission, and that was stringent. That was a GFR more than 90, which we'd all be happy with, proteinuria less than 0.5 and not a treatment failure. Now, there was a much greater likelihood of achieving that if you were on belimumab than if you were not, but it was still only sort of 30% versus 20%. These aren't huge numbers achieving complete renal response, so we've got an unmet need. And there was a secondary endpoint looking at time to renal-related events. Sorry if we keep moving my video around, or death. And this was driven, the differences that were found were driven by doubling of serum creatinine or renal worsening. There wasn't much end-stage kidney disease or death. And there was a 49% reduction in the relative reduced risk of a renal-related event or death. And that was very impressive in the first study. In the post-hoc analysis, it wasn't really powered to do any of these analyses. It didn't improve outcomes when added cyclophosphamide or azathioprine. Small group, problematic having azathioprine, I think, or with pure class 5, again, tiny group. But patients on belimumab had a significantly reduced risk of renal flare with both standard of care and across all classes of lupus nephritis. So a 55% reduction in risk of lupus nephritis. It appears to be the perfect maintenance drug. And importantly, and I think this is a really important endpoint, they were much less likely to have a 30 or 40% fall in GFR. And that's what we worry about. That predicts end-stage kidney disease. It's uncommon, but those patients are in trouble when they do it. And they had a 48% and 62% risk reduction of experience of 30 and 40% decline compared to standard care alone. So to me, that really makes belimumab very attractive. It's very good for extrarenal disease, though we've seen renal flares on belimumab in patients on it for non-renal disease, so it's not the perfect drug. And we have, for instance, many of us maintain our patients on MMF and prednisone, and we're just going to add in belimumab. And I have a very skeptical approach to this. It's an IV, it was observed given, and I think quite a lot of the patients, the only thing they were taking at 2 years was belimumab, but I don't have any proof of that. And the question I'm asked all the time that I can't answer is when to add it. The trial added it at the beginning, it was an induction agent, and it was a maintenance agent. I think it's going to end up as a maintenance agent because it is expensive and not everyone will need it. But managing lupus nephritis is much more than managing the immunological problems. So you need to think about non-immune mediated injury and really think about hyperfiltration. And actually, I would say this is less important to stress for a renal audience, I hope, than from a rheumatology audience who do not think about this. Achim Anders has come up with this vile phrase, CARP-Ds, cardio-renal protective drugs, but it's all encompassing. You've got to think about obesity, reduce steroids, diabetes, reduce steroids, steroid diet, all the things that really make your remaining nephrons work too hard, and you need to treat with those as well as all the immunological agents. So I really like this diagram from Achim. You use the DMARDs to control the immune-mediated disease. You use the CARP-Ds. We all use ACE inhibitors. No one knows whether we should be using SGLT2 inhibitors. And there is no data yet because they were excluded from the big CKD trials. But it works in IgA, so I have no idea why it wouldn't work in proteinuric lupus disease. And of course, things like spironolactone, do they have a role? And all the other things you need to think about to preserve nephrons. You need to reduce the steroids. If you want patients to be well over time, you need to reduce the steroids, you need to increase our vaccination rates to lots of things, not just corona, and you need to improve adherence. And I just want to talk about adherence for a moment. This is one of my favorite quotes. I do the lupus clinic with, among others, Dr. Tom Cairns, who's one of the best biopsies in the world. And he was talking about a patient who was complaining of abdominal cramps. And he said, well, could this be related to medication? She was on MMF. Can't be that. I'm not taking any. And it's just too frequent. And the thing we do now, because all your patients should be on hydroxychloroquine because it keeps you alive essentially, and it's non-immunosuppressive. But we identified, and this was work from Saxena Alexander, who I hope is in the audience, a significant population with subtherapeutic levels and were more likely to flare. And we sort of defined a lower limit of normal, but it also offers the opportunity to explore causes of non-adherence. And I had that exact conversation this week with a young pregnant woman whose complement's falling, whose DNA is rising, who's now pregnant, and she's tiny. And I said, well, she might just have to increase her hydroxychloroquine because her levels are so low, and she confessed she's really not been taking any. So she can stay on the same dose, she just needs to take it. So back to our patient, what did we do? She was very nephrotic, she had bad renal function. She wouldn't normally have got into any trial, but she went into rituximab and she went into a complete remission. And it's one of my bugbears that you exclude patients from trials with low GFRs. She had nothing chronic on her biopsy. This was all to play for. Sorry, and she did exceptionally well. Her function improved, her GFR went up over time and stayed up over time. Her proteinuria just melted away and her serum albumin came up. She was maintained, she needed tiny doses of drugs. So 250 BD of MMF, she stayed on hydroxychloroquine, she didn't flare despite B cell repopulating. And this is over 1, 2, and 3 years. You can see that her creatinine was completely stable here in the gray, and her GFR was nice and high, and she didn't flare. And then she sent me a WhatsApp saying she was engaged. And then we did pre-pregnancy counseling, and she switched to azathioprine, and she sent me another WhatsApp with a pregnancy test, and she had a nice fall that we like to see, a 10% fall in her GFR, and she had a very successful pregnancy with baby Dylan. So in conclusion, I don't think I've answered the question, but I think you have to think much more holistically. Lupus nephritis impacts negatively on survival and health-related quality of life. Your treatment strategies need to be targeted to maximize efficacy and minimize toxicity. So that to me is minimize the steroids. We don't yet know who is going to do well with cyclophosphamide and who is going to do well with MMF and who needs belimumab and who needs TAC. We don't know that. We don't get enough information in the biopsies. We don't have enough predictive markers. the trials would suggest that adding on something early on is good and beneficial, but I think you risk over-treating some patients. The trial we need to do is belimumab versus CNI, and we need to look at belimumab as a sole maintenance agent. But don't fret about the semantics of induction remission. Just focus on preserving function and well-being. And you do that by treating immune-mediated injury, non-immune-mediated injury, and not forgetting all the other stuff, because our patients get very bogged down in all the other stuff, and it's what we never have time to really approach that makes all the difference. And never forget the pregnancy planning. These are the many colleagues I work with, but particularly to highlight Hannah, who've done the work on long-term outcomes. Many thanks.
Very good presentation, Dr. Peace. What you are showing is that we had to achieve remission very fast and very early, and then look for maintenance of GFR, that is renal function, and take enough care that the renal function will not come down. So in this you are using both immune, that is targeting both immune mediated and non-immune mediated glomerular injury. This is what I am understanding. So are you saying that you want to start straight away immunosuppressive drugs? That is, I felt that this belimumab is less toxic and also bringing down the proteinuria very fast. So you want to start with that and then give them a short course of steroids and then change them to a maintenance dose.
So if I understand you right, you're asking about when do I use belimumab early on? We're not routinely using belimumab early on. It's not going to go through a nice appraisal for lupus nephritis. We can use it because the criteria in the UK, you have to have a low complement or high double-stranded DNA and a SLEDAI of 10. So if you've got nephritis, you get there quite easily, not for a class 5, obviously. And we don't quite know when to start it. The trial used it from the beginning. And what's surprising in the trial is that the curves separate very early on. So they see an effect and benefit of belimumab from, I think, about 8 weeks and certainly from 24 weeks, which I think was a surprise because in extrarenal lupus, they all think of it as a slow onset of action. So there is an argument for using it, but it's an expensive drug. And I think you have to be cautious because there are some patients like my patient who needed almost no treatment. She had methylpred, she had a tiny dose of MMF, and she was in and rituximab, and she was in remission in a minute. So I do worry about over treating, but I do like belimumab because it's also very good for extrarenal disease. So for those patients with bad joints and bad skin, you're getting a really useful added bonus. So we're using it increasingly, I would say. And I also think a lot of patients are going to end up on it as single maintenance because what they hate is taking the tablets. And we get steroids. It's definitely steroid sparing. All the biologics need to be steroid sparing.
Okay, so you are giving more stress to immunological, immune-mediated inflammation, but your clinical guideline is proteinuria, not the complement levels or immunological levels. So, what do you say?
So proteinuria, I think, is a really problematic biomarker. It's useful when you first start because it's usually mostly acute. But as time goes on, so we definitely see, so the group, Brad Rovin and the Argentinian group, have clearly shown that you can have very active nephritis in a proportion of patients who appear to be in clinical remission. So their argument is at the moment, the only marker we have is to re-biopsy. We did the opposite when we were doing our first rituximab work. We showed that a lot of people who were supposedly not in remission in a year they just had some chronic damage, which was accounting for their proteinuria. So it's sort of a useless marker. And I think a lot of people fail trials because they've still got proteinuria, but it's because of glomerular scars, not because of active disease. And we don't routinely rebiopsy in trials, which is a deficit. There is a new marker, which I think shows a lot of promise, and that's CD163, which is a urinary biomarker, which really does correlate with activity. And I think that's going to become into much more general use and will allow us to say the activity is declining. You also then need a marker of fibrosis, because most repeat biopsies show that activity goes down and chronicity goes up. So we need something that prevents chronicity. And of course, the worry with the long-term CNIs is you might promote chronicity.
Yeah, thank you. Thank you, Madam Dr. Neela, Madam. That was a wonderful discussion that you had started. May we request certain comments from Dr. Manish Rathi too? Dr. Manish.
Thank you. Thank you, Professor Liz, for masterly presentation. And it is always very nice to hear from you, especially in the field of lupus nephritis. And I have a couple of comments and I want your suggestion. I think you have done a marvelous job with steroid sparing and with rituximab. And of course, all of us target that our patient should be on as low as possible steroids and preferably not on any steroid, but somehow we are not able to replicate your work here, right? Because even we publish, even with 0.5 mg of steroid, our patients are relapsing in the induction phase I am talking. So if we are giving methylprednisolone followed by 0.5 mg of steroid, even then they have a higher kind of or poor response rate and a higher risk of flare. This we have published. So what we have come down with all this thing is, from earlier we were using 1 mg, but now we are using 0.75 to 0.8 mg per kg. That is all we can do. Like, we can't go beyond or lower than that. So somehow we are not able to replicate your work. Maybe there are some racial differences, or the severity of disease is much more in our patients. So your comments on that. And second comment was, you have rightly said that this induction and maintenance are like arbitrary cutoff. And we have arbitrarily put it at 6 months or 12 months. What we should be targeting is that how these patients are responding to our immune therapy, whatever we are giving, whether we are giving mycophenolate or cyclophosphamide. So whether these patients are responding at the end of 6 months or 8 months or 9 months. So we have to target the response, and then we have to switch to a lower, kind of a maintenance therapy. But my question is, suppose our patient has started improving at the end of 3 months itself, like this patient has gone into remission at the end of 3 months or 4 months. Will you switch this patient to maintenance therapy at such early stage, or you will keep at least 6 months of so-called induction therapy?
Okay, so great questions. I'm very interested by your data. We serve a large Indian Asian population. So 34% of my patients in that long-term study are from India or Pakistan. So our patients look like your patients, I think, but it may be they're picked up earlier. I don't know. It may be that your patients are presenting more severely. When you say they're flaring, it's that you can't get them into remission with the lower doses. So you pulse them and then you give them what? What do they get?
So what I was saying that we did a randomized trial where we randomized patients into 2 groups with the standard of care. We were randomizing to 2 groups of steroid. All patients were receiving methylprednisolone, and one group was receiving 0.5 mg per kg of steroid, and another group was receiving 1 mg per kg, which was our standard of care at that time. And what we find in comparison to 2 groups, that the patient who had 0.5 mg per kg had a poor chances of going into remission. And second, even if they go into remission, they had a higher chances of flare. So they require a kind of rescue therapy with increase in the doses of steroid, and again, maybe kind of a reinduction.
What was their other treatment though? You use cyclophosphamide generally, don't you?
Yeah, but in this trial, it was mycophenolate as well as cyclophosphamide. So our main thing was comparison of steroid therapy rather than cyclophosphamide.
I mean, it's really interesting, Manisha. I mean, it's different from the My Lupus study, which showed that was a very short study. That was only 24 weeks, but they got equal complete and partial responses in the 0.5 milligrams to the 1 milligram, that will have been, I think, an almost entirely Caucasian population who are different without a doubt. They're much easier to treat in Northern European white, but they showed no difference but much less Zostra than in the higher group. So clearly you have to tailor it to your population. And I suppose for severity, it'd be very interesting to look at sort of grades of severity, what other additional treatment they had. You have to do what works for your patients, but 0.75 is in keeping with the KDIGO guideline. And I always commend you for the trials you do. I think they're excellent and they're important because lupus patients are different and they're different the world over, so that we assume that one thing. But I have to say, the patients we've treated with rituximab and Rituxi Rescue are from all backgrounds. We've treated Black patients, Asian patients, whatever. So, and they've generally done well. The patients who do badly are the ones who never take their tablets. And that's my perpetual bugbear. I do think there are some patients who probably do need a bit more steroid. And the one thing that worries me on a biopsy that makes me think about giving more steroid is if they've got a lot of interstitial inflammation, because I think the only thing that really squashes that quickly are steroids. And I think that can quickly lead to scarring if you don't treat it. So those patients I might give a bit more to. I've now forgotten your second question.
Yeah, if that was regarding induction and maintenance therapy, like the arbitrary cutoff versus like when you decide.
So I think it's really difficult. We don't tend to reduce, so we measure mycophenolate levels. So we don't tend to reduce the dose. We don't do this 1 gram BD and then reduce to 500 because often they're subtherapeutic at 500. A lot of patients, we never get up to 1 gram BD because they don't need it based on levels. Cecina will tell you that I'm measuring the wrong levels, but that's fine. So we tend to keep them on the same dose of MMF and we keep them on it for a very long time if we can. The only time we really give up early is if we switch to AZA for pregnancy. And, you know, a 39-year-old woman with new lupus nephritis who's desperate to get pregnant, I might switch her at 6 months if she's doing well. There are predicted markers. So I was just saying to a patient this week who's actually in a trial that I thought she would do well because her complement's risen quickly and her double-stranded DNA has fallen from thousands to sort of hundreds very rapidly. So, and that we know from Maria Delara's work that that actually is a good prognostic feature and predicts a good outcome. So I think we need to be better at saying, well, what predicts them doing well? I'm not, the Eurolupus even, we give 3 months, but we have some patients that we then give extended courses to. And really based on response, you know, you can see they're improving, but they've not got there yet. And they were often on MMF before. So why change them back at that point? Just continue monthly doses. They're still not getting a lot of cyclophosphamide and they do very well. So I think you really, I'm not an arbitrary guideline person. I think you have to look at the person in front of you. What's the trend? Is the trend in the right direction, but do they still need slightly more aggressive therapy? And I think you can reduce steroids too quickly. If they've gone on to high-ish doses, I think you have to be quite careful about how you reduce them. If they've never been on them, it's a different issue.
Thank you. Thank you so much. I think that was a lovely discussion which has been going on. Sorry to interrupt you, the chairpersons. We apologize for the inconvenience being caused as we are running behind the schedule by an hour. So I thank all the chairpersons out here, Dr. Muthu Jayaraman, Dr. Neela Prasad, Madam, and Dr. Manish Ratty, and an excellent talk by Dr. Liz Lightstone. Thank you so much for joining us. We move on to the next session. I give to the MC persons for the next session. Over to you, please. Thank you, ma'am. That was certainly an educative talk. The next exciting session for the day is on hemolytic uremic syndrome, Unraveling the Genetics by Dr. Anuja Java. I request the chairpersons of the session to kindly join us. I invite Professor Dr. Anuradha Raman, Madam, former professor and head of nephrology at Osmania General Hospital and Medical College, currently working as a senior consultant nephrologist at Sunshine Hospital. Madam, please. Joining her will be Professor Dr. Gangadhar Taduri, sir, professor and head of nephrology at the Department of NIMS, Hyderabad, and OST to Chief Minister, and Dr. Tarun Kumar Saha, sir, senior consultant nephrologist, Apollo Sikandrabad. I request the chairpersons to kindly introduce the speaker and take over the session, please.
Okay, I think it's my pleasure to introduce Dr. Anuja Java, who is Associate Professor of Medicine, Washington University School of Medicine in St. Louis. She is Director Kidney Transplantation, John Cochrane VA Medical Center, St. Louis, Missouri, USA. It's my pleasure to introduce her. She did her internal medicine training at Orlando Regional Medical Center, USA. Her research focuses on defining the functional consequences of genetic variants. So she's an apt person to talk on this hemolytic uremic syndrome. This morning, we all had a pre-conference session on genetics, and we know that we are moving towards genetics, and we'll be excited to know what she has to tell us about hemolytic uremic syndrome. Before I hand over floor to you, okay? Dr. Anuja, the floor is all yours.
Hi, everyone. I'm Anuja Java. I'm a transplant nephrologist at Washington University School of Medicine in St. Louis in Missouri, USA. It is an absolute pleasure to be celebrating the inaugural conference of WIN India with you all today. And I really have to thank the organizers for inviting me to participate in such a celebratory event. I have been tasked with talking about the genetics of hemolytic uremic syndrome. And what I'm going to do is, my talk is divided into a few different sections. I'm going to briefly introduce the disease, discuss a quick overview of the complement system, talk about the value of genetic testing that would include who to test, when to test, what to test for, and then how do you interpret those genetic test results when they come to you. And I'm going to use a case to kind of go over how we do things, and then end with a short slide on treatment and conclusions. So hemolytic uremic syndrome, as you all know, is a thrombotic microangiopathy, which is a term for a pathological process which is caused by thrombotic occlusion of the microvasculature. As seen here on the left is a healthy capillary which has blood flowing freely through it. And on the right is a capillary which has been damaged by thrombotic microangiopathy because of the occlusion by the thrombus that restricts the blood flow through the vessel. The disease features what we typically know as a triad of hemolytic anemia, which is non-immune, resulting from intravascular breakdown of the red cells, thrombocytopenia because of consumption of the platelets in the clot, and organ injury, which is due to end organ ischemia. Kidneys being the predominant organ involved, although extrarenal manifestations include strokes, MI, or GI ischemia, bowel perforation. Now, HUS has traditionally been divided into typical HUS, which has, is the term used for E. coli or sugar toxin associated TMA. And atypical HUS is the term which is reserved or should be reserved for complement-mediated TMA. And this is the entity which has a very well-described genetic component. And for the purposes of my talk today, I'm going to stick with describing the genetics of the atypical hemolytic uremic syndrome. So aHUS occurs due to an abnormal regulation of the alternative pathway of the complement system. This dysregulation or overactivation of the complement system occurs due to a mutation in one of the complement proteins, which is identified in about 50% of patients. However, less than 50% of those patients that have a variant identified have a functional consequence that is known about the variant. Currently, multiple computational tools or predictive models are utilized to understand the impact of these variants. And despite the use of these tools, a majority of the genetic variants in these patients are reported as variants of uncertain significance. And that poses a challenge for clinicians because not knowing whether that variant is of significance or not, it leaves you in the conundrum of what to make of the etiology and prognosis of the patient. Moreover, the risk of recurrence after a kidney transplantation is high, and it depends on the underlying complement abnormality. Over the past 8 or 10 years, as we have understood or advanced in our understanding of the pathogenesis of these diseases, and with the approval of anti-complement therapy, it has allowed for successful transplantation in many of these patients. So to quickly go over the complement system, now you know that there are 3 ways the complement is activated: the classical, the lectin, and the alternative. The classical pathway is activated when an antibody binds to an antigen. The lectin pathway is activated when lectins, which are proteins, recognize the carbohydrate moieties on the surface of a bacteria. The alternative pathway, unlike these two, does not require a trigger. It's in a state of continuous on, or as we call it, takeover. It's similar to an idling car with an engine on, ready to go. The goal of the 3 pathways is the formation of C3b, which is the primary component of the complement activation. This C3b functions as an opsonin for the immune complexes for the bacteria and gets them ready to be phagocytosed by the reticuloendothelial system. An important point to remember here is that no matter how this initial C3b is formed, once it is formed, it can really rev up the activation through the feedback loop of the alternative pathway, which is shown here in the dotted line. And if the trigger continues, the C3b, through a series of additional steps, can lead to the formation of the membrane attack complex, which pokes holes on the surface of the bacteria, leading to bacteriolysis. So really, the complement system has been designed as a first line of defense against infections. It's part of your innate immunity to really prevent debris, foreign particles, bacterial attack. That it does that through opsonization, phagocytosis, through debris removal, immune complex removal. And as I said, the alternative pathway is a very important and a potent component of the complement system. Because this pathway is constantly on, and because it has the feedback or the amplification loop into which the C3b can loop into and lead to continuous activation, this pathway needs to be very strictly regulated to prevent damage to healthy host tissue. And this regulation is achieved through a number of proteins called the regulators of complement activation. And these proteins include complement factor H, factor I, complement receptor 1, membrane cofactor protein. And they regulate the system through 2 or 3 different mechanisms. One is known as cofactor activity, and one is known as decay accelerating activity. I'm not going to go into the details of how that regulation occurs, but I'm happy to discuss that later during discussion time. Now, disease or aHUS occurs whenever there is a problem with regulation of this alternative pathway, such that there are either loss of function mutations in these regulators such that they cannot do their job and cannot control this alternative pathway, or there are gain of function mutations in complement components like C3 or factor B, such that these components then become resistant to regulation by the regulators. In addition, there could be actually acquired factors that could lead to disease, and the most important and common one includes factor H autoantibodies. The way factor H autoantibody functions is that it interferes with the regulation of factor H, and that is how it functions as a negative regulation of the disease and leading to aHUS. So in summary of the genetics, there is either loss of function mutations of factor H, membrane cofactor protein, or factor I, or like I said, there could be gain of function of C3 or factor B, which makes these proteins resistant to regulation. And this table here kind of gives an overview of how frequently you would see a variant in one of these proteins in these patients. What is the risk of end-stage kidney disease if a pathogenic mutation is identified in one of these proteins? And the risk of recurrence after a kidney transplant if it is not identified in time and not treated in time. 2 other important points to remember is that this is an autosomal dominant inheritance, which means that you only need 1 defective allele to cause disease. Number 2, this is a disease which you would often hear the term of it has reduced penetrance, which means that the genetics by themselves are important, but they often need an environmental trigger to really manifest disease. The second important point is that there could be diagenic inheritance, which means that some patients may actually carry mutations in more than one gene. So there may be a variant in factor H in a C3 or a factor I in a C3. So moving on to then, what is the value of genetic testing and why then do we need it, right? So as I mentioned, we know that these variants are found in AHAS. So finding these mutations, doing genetic testing in AHAS aids in diagnosis, and it establishes the etiology of disease in your patients. Number two, it provides prognostic information with regard to what is the risk of progression. Is this patient at risk of end-stage kidney disease because of this mutation? What is the risk of relapse if this patient's treatment is discontinued? What is the risk of recurrence after a transplant if this patient carries this mutation? Additionally, if your patient is looking for a kidney transplant and carries a mutation, it is critically important to do this testing in potential donors, because if the donor, a living related donor, carries a mutation that may be problematic in the recipient, you do not want to take a kidney. So making those kind of decisions is also critical, and that can be made when you do the genetic testing for these patients. The next question then is, who are the patients who should undergo genetic testing? Well, the first obvious answer is that patients who have a clear history of atypical HUS. Well, you see a biopsy-proven thrombotic microangiopathy and you don't have another etiology. Or if there is a patient who has a significant family history of thrombotic microangiopathy or AHAS. However, it's extremely important to remember that if you have young patients who present with severe hypertension and they present with hypertension as the cause of end-stage kidney disease, I highly encourage you to screen them for genetics for atypical HUS or thrombotic microangiopathy. It is, I will say this, that hypertension as a cause of end-stage kidney disease is really not the right etiology. The diagnosis of hypertensive nephrosclerosis in young patients is not a diagnosis. It's an incorrect term. We tend to label it because we don't know better. So if you have a younger patient who has lost his or her kidney to hypertension, please test those patients. Young women who had preeclampsia during pregnancy, and those women ended up developing end-stage kidney disease because preeclampsia did not resolve, should also be considered for testing. It could very well be an atypical HUS case and not your bread and butter preeclampsia. And then, of course, any patient who has an unexplained kidney failure, either in the family or in the patient itself. And you could argue that patients with unexplained kidney failure would probably benefit from a more broader genetic panel to really look for all causes than just the TMA, but something to consider in those patients as well. So when you do order genetic testing for these patients, majority of the labs that do this kind of test primarily only test for 13 common genes, and I've listed those genes here. And the reason is that these are the genes that over the years through research have most commonly been associated with disease, and genes for which we have the most data in association with AHAS. However, there are about 56 to 60 total complement genes. So when you're checking for 13 genes, there are a good 40 genes that are not being checked for. Now, at this point, we don't have enough data to include that in the panel, but it is something to keep in mind, because when we say that only 50% of patients have a genetic etiology identified, that is probably because we're only checking for 13 genes, and we really don't know that they might have a mutation in those other 40 genes that have not been associated. There's not enough research to talk about them. Second, when the genetic lab does this testing for these 13 genes, they give a report out based on the American College of Medical Genetics. The report would describe the genetic variant, if identified, as one of 5, either pathogenic, likely pathogenic, a variant of uncertain significance, it may be a likely benign or a benign variant. Now, if you get a report on a patient that says the mutation is pathogenic or likely pathogenic, that clinches the diagnosis. You've rested your case, you don't need to go further. You have a patient with a clinical history, you found a pathogenic mutation, it's a clear-cut diagnosis of atypical HUS. However, the problem or the challenge comes when you kind of have a clinical history, But the report says, well, the patient carries a genetic variant, but it's a VUS, it's a variant of uncertain significance, so we really don't know whether it's benign or it's not, or it's pathogenic. At that point, you probably need to take the next step. You may need to involve specialized labs that do functional testing, biomarker testing. However, before that, there are several things in the report itself that'll help you figure out what that mutation might mean. And learning to read that genetic report through some of the points that I'm going to talk to you about might be helpful. So if you get a report that talks about a variant that is a VUS, the first question or thing to look into is what complement protein is the variant in? Is it in one of those well-known regulators? Is it in a factor H or a factor I or C3? That is more important than in one of the complement factor H related proteins for which we have much lesser data about being pathogenic. Even among the regulators, the factor H is a much more potent regulator. So a mutation or a variant in factor H would be more significant than a mutation, say, in MCP. Second question when looking at the report is, does this report tell me whether this variant has been reported in the literature? And most good labs will tell you, they'll quote papers, they'll tell you that, yes, this variant was reported in this paper and this is what it showed. And even if they don't, you can do a quick online search. You type the variant, type the protein, and it'll pull up, is there a case report? Are there anything that's been reported with this variant before? Next term I want you to recognize is something called a conserved mutation, which means that is this mutation occurring in an amino acid that has been conserved across species? So if amino acid at a particular site has been conserved, meaning it's present in the monkey, it's present in the rat, it's present in the pig, it's present in humans, that means across species, that particular amino acid has been passed on or has been conserved. That is an important amino acid. And if there's a mutation at that site, that is most likely a problematic mutation. Like I said, a lot of the genetic reports will tell you if it's a conserved mutation or not. Then another thing to keep in mind is what is the frequency or the minor allele frequency or MAF as we call it of the mutation. aHUS is a rare disease. So a variant that is rare, that is, and by rarity I mean found in less than 1% of the population is generally a pathogenic mutation. So if you find a variant and it's reported in 20% of the population, probably not the one causing disease. But if you have a mutation that is, say, reported as a frequency of 0.5 or 0.05, that is probably a more important mutation to pay attention to. And finally, another thing to look into is based on what we know about the protein, do we think that this mutation could be causing some kind of a problem in the function? And I know that's a little bit more in depth than for a general nephrologist or a clinician to go into, but if you know the different important functional parts of a protein, then knowing that a mutation is an important part of the protein may give you an insight. And even if you don't, one of the important ways of recognizing if that mutation is causing a problem in the function is simply by testing the level of the protein. So if you have a mutation in factor H and you check the level of factor H in the patient, and if the level is low, you don't need to go further. You know that the mutation is causing the low level, and that gives you the answer. Now, if you've gone through all these steps diligently and you still don't have an answer, then of course, the gold standard way of really understanding the importance of these mutations is to either use the patient's serum to do functional assays or recombinantly make these mutations in the lab, in vitro, purify them, get the mutated protein, compare it to the wild type protein, do a series of complement assays, combine with structural assays and kind of put that whole information together, along with complement biomarker testing, which I'm going to show the testings that we do here. So, like I said, I think all of this information can be nicely put together in this case that I'm going to talk to you about. And this is a real world case from our practice. This is a 22-year-old white male who developed end-stage kidney disease at the age of 3. At that time, it was thought to be secondary to E. coli-triggered hemolytic uremic syndrome. At the age of 11, this kid underwent a kidney transplant, and a year later, his kidney function worsened, underwent a biopsy that showed acute cellular rejection. He went back on dialysis 2 years later, but then came to us to get evaluated for a second kidney transplant. At the time of his evaluation for a second kidney transplant, we went back and we saw that this patient had an E. coli HUS that was more aggressive than you would have expected. So we did genetic testing for this patient, and his genetic testing showed a variant in factor I, and that's the variant arginine 406 to histidine change. And the genetic report said it's a variant of uncertain significance. Well, we didn't know anything at that time. He got a second transplant. We had the drug available. He got the drug. But because it was a VUS and we were not in the position to do any testing in that time, some 5 or 6 years ago, the patient was doing fine. A year later, the drug was stopped. Less than a year after the drug was stopped, his kidney function started to decline again. And the biopsy this time showed cellular rejection as well as antibody-mediated rejection. So we went back into looking at this mutation to really understand, is this mutation playing a role in this patient's disease at all? Although the patient has not developed a TMA, we're just dealing with rejection here, but we didn't have an answer. So we started investigating this variant. So the first of all, it's a variant, it's in factor I, so we know what protein it is in. It has been reported in the literature, but the frequency was 1.6%. So it's not less than 1%. So it's not very rare, but it's not 20%. So it's kind of edging on the borderline level. And we figured out that it's present, this mutation is present in the light chain, which is the functional aspect or the functional chain of the factor I. This is the chain, or this is the domain of factor I, which is the regulatory domain. So it's present in an important part of the protein. So we went through the checklist that I mentioned. We know what protein the variant is in. Yes, it's been reported, minorly in frequency, borderline, not very rare. Based on the fact that it's an important functional part of the protein, it probably is problematic, but we don't know. So what do we do first? We check the level of factor I in the patient. The factor I level came back completely normal. That means the mutation is there, but it's not causing decreased levels of factor I in the protein. So the next step then was to do the functional analysis. And like I said, these are analyses that we do in our research lab. We recombinantly make the protein. We get the purified mutated protein, compare it to normal factor I protein using a number of complement-based assays. And I can spend more time to describe those assays later on if needed, but just to keep the timing in mind, I'm going to just give you a summary that our functional analysis showed that the mutated protein decreased the rate of cleavage of C3p. That means there was a defect in the regulation of this protein when it was regulating C3p. And our overall analysis based on functional data was that it had defective cofactor activity, or it had defective complement regulation. And the next layer of analysis that we do in these patients is structural analysis. I do that really in collaboration with a structural biologist here in St. Louis. And really what Nicola does for me is that he models the proteins of the variants on these three-dimensional models of C3b factor H factor I, and he comes up with an interpretation based on where the mutation is. And again, I'm not going to go into the details of the structural analysis, but this is really to give you a flavor of how structural analysis interpretation is done. And what he interpreted was that there is a unique signature called E123, and with that mutation, that unique signature is disrupted, and that possibly explains why this mutation causes a defect in function. So we put all this information together. We say that yes, the patient has a mutation. It's in a factor I, which is a regulator. The protein level of factor I is normal in the patient. However, the functional data shows that it's dysfunctional or it's defective. So clinically, the patient had HUS, which was E. coli HUS, but now we probably think it was not E. coli HUS. He lost 2 kidneys. The first one, yes, was in cellular rejection, but the second one was an antibody-mediated rejection. It's important to remember that thrombotic microangiopathy and AMR can sometimes be on the same spectrum. So our assessment of this case was that his loss of kidneys was somehow related to dysregulation of the complement system due to the mutation. And if we are going to give him a third kidney this time, we're going to have to do the anti-complement therapy for him, and we probably have to keep him lifelong. And this is one of the more challenging cases we've had, and which is why I wanted to kind of show you how we go about stepwise teasing out what is going on in the patient. And this flowchart here I've put together really to really summarize what I've discussed so far. So when you're evaluating a patient with TMA or suspected AHAS, you do a good, thorough review of the history, the laboratory features, and the pathology if you can do a biopsy. And then your complement studies include doing genetic testing. If you find a benign or a pathogenic variant, you kind of have your answer. But if you find a variant of uncertain significance, remember, go through your checklist. If that gives you an answer, it's great. If not, then you have to take that next step of doing these specialized or consulting labs to do these specialized testing for you. And on the left panel in the green is all the biomarkers that you could and should potentially use in AHAS patients. And these would include looking for C3, C4, looking for serum antigenic levels of the complement protein, checking for autoantibody, particularly factor H for AHAS. In individual cases, you could even look at split products, C3C, C3D, to get an assessment of if there is complement activation going on. And then you put all this information together, your genetic, antigenic, structural, functional, and that gives you a good picture of what is going on with the patient, what is the etiology, what is the risk of recurrence of this disease, what is truly going on at a biochemical genetic level on this patient. And we have used this approach to publish 2 of these papers over the last year or so. And both of these papers actually contain real-time cases from our practices. And each of these cases, we've gone over these steps like I described to you, and how to tease out and how to go about interpreting and doing genetic analysis for patients. And all of this genetic information is also critical, and we also use it to really stratify treatment. And I understand, and I recognize that anti-complement therapy is not easily and readily available in India. But if genetics is available, that kind of at least helps you risk stratify your patients. So if you find a pathogenic mutation in any of your complement proteins, or you have a persistent factor H autoantibody, those patients need lifelong treatment. Whereas if you have an MCP mutation, or there is a patient who carries an acquired factor H autoantibody and that can be successfully treated with plasmapheresis or rituximab, those patients don't really need to stay on treatment. And if you have a variant of uncertain significance, those patients obviously need further investigation based on everything that I have described so far. So in conclusion, I want to say that the knowledge of complement genetics has definitely, over the past many years, transformed our understanding of AHAS. And I encourage wider utilization of genetic testing, not only in patients where we suspect AHAS, however, but also to remember younger patients with hypertension, preeclamptics who end up with end-stage kidney disease, or any other aggressive TMA that does not resolve with supportive therapy should undergo genetic testing. And a combination of your genetic, antigenic, structure, function, and biomarker data would really give you the full, clear, comprehensive picture of diagnosis and will define the etiology in your patients. Yes, it requires some expertise in complement biology, but a lot of it, almost 50–60%, if you know, you can do it on your own. And then ultimately the goal is precision medicine, knowing the genetics in each individual patient and stratifying treatment based on that to define the duration of therapy, to define what you can treat, how you can treat, how long you can treat, is really the ultimate goal and the future of medicine. With that, I am going to stop here, and I look forward to your questions live. Thank you.
Thank you, Dr. Java, for the excellent talk on and opening our horizon on the role of genetic testing and where we should increase the indications of doing this genetic testing, particularly for young malignant hypertension patients and a person who has a preeclampsia and going into ASRD soon, that those are the areas where we should increase the testing for genetic testing more aggressively. What is interesting to know that the presence of genetic abnormality itself is not enough. We need to know the functional aspect of it, structural aspect of it, and there are other cofactors. So it's not a very simple, straightforward whether we have a genetic abnormality or not. So it's much beyond to that. So we need to improve our understanding further to apply it on clinical aspect. So what is your take-home message for the clinician that at present what we are supposed to do with our limited resources, and what we do go from here?
Absolutely. So no, you're absolutely right. Like I said, this is a reduced penetrance disease. The genetics is important, but environmental triggers are equally important. And many times we come across cases where, the patient has gone through all their life, their young adult life, and nothing happens until something happens in their older age and they present with TMA. So it's really challenging that time, because you know that the patient carried the mutation all their life. What suddenly changed? So I definitely think that's a challenging part. In terms of what you can do with limited resources, what I can offer, and I've offered this nationally to my colleagues here in the US as well, is that given that we are a global community, there's so much networking going on. I do help out with cases, and that is the best I can offer. We do have a research lab. It's not CLIA certified or clinical lab, but I do offer consultations on these cases to patients nationally here, and I do have a database that I help out with. So until we can get more labs that can do this functional testing on a more a level that is available to everybody, this is the best we have. We are here in the US. There are a couple labs in Europe who do something similar. So there are resources available, and I think with the communication that is now open, I think you're free to reach out and ask for help.
What happened in a post-transplant HUS, that when the previous biopsy or previous workup is not available, and yes, person gets a post-transplant HUS, and we think that it's due to the CNI. Yes. So what would be your suggestion to how to treat those kind of situation? Of course, we remove the drug and try to give FFP. Some people try to give plasmapheresis, FFP both. So what is your advice in this situation?
Right, that's a great question, and it's a scenario I face day in and day out in my practice. So absolutely, the first thing is if we don't have a biopsy available and the patient develops a TMA, obviously you don't know, because you don't know what the cause of the kidney disease was. So the first step is supportive therapy. If the patient has been on CNI, you would probably stop that, replace it with something else. However, our approach is that we send genetic testing right away. Again, that doesn't help us because it takes a week or 2 weeks to come back. So we don't know the answer. But if removing the CNI does not help the patient in the next 24, 48 hours, our approach is actually to go ahead and give them 1 dose of the drug, because that buys us about a week or some time to figure out what is going on. So that is really what we've been doing here, is treating the patients where the TMA is aggressive and is not responding to supportive therapy.
Yeah, but eculizumab is not available with us. So sort of that, do you recommend doing any plasmapheresis, or by just giving simple FFP infusion? Because recently,
right. Right. So I think given that the drug is not available, probably plasmapheresis can be tried. At least it is something to do. It is not very effective, maybe effective in 20, 30% patients, but in the absence of anything else, it's definitely worth a try.
Now, recently I encountered a patient who developed TMA within first month after transplant. Connection issue. Yeah, so the biopsy was suggestive of TMA with patchy cortical necrosis. It was a very severe TMA. And what we did, we removed the offending agent. And whatever literature I read, I did not do plasmapheresis, but I gave FFP infusion for continuously for 10 days. And see, he had a remarkable improvement, although my pathologist, who is a very senior, well-renowned pathologist of the city, she called me and told, it's a first thing that, Saha, you have a bad news. this biopsy is suggestive of a cortical necrosis. He didn't even say me patchy. Obviously, biopsy can be patchy. She told me it's a bad news for you. It's a cortical necrosis. Then I said, madam, we did everything. There was no evidence of any rejections and all. So we thought it is due to the TMA causing the cortical necrosis. But to our utter surprise, he improved remarkably from creatinine, which was 4 above 4, came down to baseline of now about 1.5, 1.6.
So did you send any testing to see whether he was defective in any of the proteins? Because the only way that would make sense is if he was defective in a factor H or factor I and he had low levels and you replace that with FFP. That would be the only explanation for a case like that.
Yeah, we have sent the sample. We have waited for the report.
Okay.
Yeah, okay. An excellent presentation. My quick 2 questions are actually whenever we are encountering a patient going for a transplant in a CKD, is there any role of doing any testing, genetic testing to detect like whatever, like Dr. Saha told, post-transplant he had encountered a TMA, like any unknown etiology of kidney disease where we don't know what is the etiology of kidney disease? Is there any role of a panel of genetic testing to identify, because this is a dreaded disease which occur. We not bother regarding FSGS and other things, but if TMA is identified pre-transplant, we'll be more careful. That is one question. Second question is, a TMA is clinically diagnosed. Is there any panel of tests you should recommend, genetic testing like with Sanger sequencer? Because whole genome sequencing and other thing may be a difficult, which is more costly. So any panel of genes are there where we can ask them to do this genetic testing? These 2, can you enlighten on this?
Right. So the first question, if I understood, was that if you have a pre-transplant patient during pre-transplant workup, you are not sure what the cause of kidney disease was, and you don't think it's one of those FSGS. Yes, definitely. And I will tell you that over the last 8 or 10 years, I have a cohort of about 85, 90 patients, majority of which have been identified during pre-transplant workup by doing this testing. And that is why I came up with my point about hypertension and preeclampsia. We've identified those patients which were labeled as hypertensive and that
some problem with her network. So I think we'll close the session and hand over the mic to the organizers.
Thank you, ma'am. That was a great talk. Thank you, chairpersons. We now move on to the last session before the oration. This session is on the hot topic of donor-derived cell-free DNA by Dr. Sylvie Shah. I request the chairpersons to kindly join us for the session. I hereby invite Dr. Amit Gupta, former professor and head of nephrology, SGPGI Lucknow, former president ISN and PDSI, and he also takes the credit for establishing the largest CAPD program in India and South Asia at SGPGI. Joining him will be Dr. Rajaram, senior consultant nephrologist at Mahavir Hospital, Hyderabad. I welcome Dr. Rajaram, sir, to kindly join us. Welcome, sir. I hand over the proceedings to the chairpersons, and I request Dr. Amit Gupta, sir, to kindly introduce the speaker.
Good evening to all of you, and thank you very much for having us on the program. And it takes me great pleasure to introduce Dr. Sylvie Shah, who is a physician scientist and an associate professor of medicine in the Division of Nephrology at the University of Cincinnati. Her research focuses essentially on kidney transplant and women's health in kidney disease and kidney health in cardiovascular disease. She has been a recipient of several research grants from the National Institutes of Health. She is an associate editor for the Advances in Chronic Kidney Disease journal and serves on the editorial board of several other nephrology journals like Kidney 360 and Kidney Medicine journals. And she has been a past counselor for women in nephrology and leads the American Society of Nephrology's Women Health and Research in Nephrology community. Dr. Shah would be speaking to us about a very important area which would help us in the diagnosis of acute rejections and the role of complement of the donor-derived DNA. So over to you, Dr. Sylvie Shah, for your talk.
Good afternoon, everybody. I'm Dr. Sylvie Shah. I'm an associate professor and a transplant nephrologist at the University of Cincinnati. And I would be talking about donor-derived cell-free DNA. Can it improve monitoring of RAP function? I would like to thank the organizing committee and Women in Nephrology India for having me, and I'm very excited to be a part of this conference. I have no relevant conflicts of interest. So these are the learning objectives of my talk. We would be briefly talking about incidence of graft failure in kidney transplant recipients, total cell-free DNA and donor-derived cell-free DNA, use of donor-derived cell-free DNA for diagnosis of allograft rejection, and advantages and limitations of donor-derived cell-free DNA in transplant surveillance. So this is the incidence of graft failure in kidney transplant recipients. About 10 to 20% of living and diseased donor transplanted kidneys fail within 5 years, and 30 to 50% of living and diseased donor transplanted kidneys fail within 10 years. And allograft failure is associated with increase in cost burden in transplant centers. However, there has been improvement in graft failure over graft survival over past 2 decades, mostly because of improvement in the immunosuppression therapy, which is available in the current times. So these are some of the current tools which are available for post-transplant surveillance for allograft failure. And the two most commonly non-invasive tools used in clinical practice is serum creatinine and donor-specific antibody. So although they have the advantage of being non-invasive, they tend to be less accurate for detection of rejection. Biopsy is a more invasive tool. However, it is also more accurate for detecting rejection among kidney transplant recipients. However, it does have the disadvantage of sampling errors and variable interpretation. So what is total cell-free DNA? Total cell-free DNA can be found in the circulation, or it can be found in other body fluids. And depending on the type of origin, it can either be a nuclear DNA, a mitochondrial DNA, or a metagenomic DNA. And cell-free DNA has been successfully used in the world of oncology to monitor progression of tumor cells and to monitor recurrence. Also, it has been successfully used in prenatal testing. So cell-free DNA is used for genetic testing. And the more recent and the upcoming use is for post-transplant surveillance, and that's what we would be discussing more. So what is donor-derived cell-free DNA? Cell-free DNA refers to the fragments of DNA in the circulation that originate from cells undergoing cell injury and death. And when donor kidney injury occurs, the donor kidney releases cell-free DNA into the plasma of the recipient, resulting into increased levels of donor-derived cell-free DNA. Donor-derived cell-free DNA can either be found in the circulation or it can be found in the urine. And as we can see in this figure, donor-derived cell-free DNA is depicted by the green color, and it can be seen in the blood after receiving a transplant, whether it's a kidney, heart, or lung. Also, it can be detected in urine, and it's mostly donor-derived urinary tract in patients with kidney transplant. The other route, the way it comes in urine is transrenal route, and it is filtered from the blood circulation through the glomerulus into the urine. And this again can be seen in patients with kidney transplant or with transplant of other grafts. So there is a single nucleotide polymorphism, which is also a common genetic variation, and DNA has 4 to 5 million SNPs. And this is, it's actually the panel of SNPs which is used to identify donor and recipient DNAs. And that is how the fraction of donor-derived cell-free DNA is quantified. And the percentage of donor-derived cell-free DNA is then elevated with allograft injury. And as we can see in this figure, this is a transplant recipient, and different SNPs are identified to differentiate recipient versus donor cell-free DNA. And donor cell-free DNA is represented by this black color, which is in low levels in a stable allograft. However, it increases with subclinical active injury, and it further increases significantly with clinical dysfunction and active injury. So let's talk about the utility of donor-derived cell-free DNA in patients with kidney transplant. And this is one of the first study which was published to see the use of donor-derived DNA, cell-free DNA among patients with kidney transplant. It was the DOT study, which was performed in the United States. It had 107 of for-cause biopsies with matched donor-derived cell-free DNA and a total of 27 rejection episodes, which were reported in this study. And they actually compared the donor-derived DNA with the serum creatinine to detect active rejection. And let's look at the panel on the left, which looks at donor-derived DNA between the two groups. So the median level of donor-derived DNA was much higher in patients with active rejection, 1.6%, as compared to patients with no active rejection, which was 0.3%. However, the median level of serum creatinine did not differ between the two groups with active rejection and no active rejection, basically implying that donor-derived cell-free DNA is more sensitive than serum creatinine to detect acute rejection. So next, they looked at the AUCs for these two different biomarkers, and donor-derived cell-free DNA had an AUC of 0.74 for detection of rejection, which is very good. However, serum creatinine did not perform well, and the AUC was only 0.54. And the bottom panel looks at the sensitivity, specificity, positive predictive value and negative predictive value of donor-derived cell-free DNA. And if we look at the cutoff of 1%, the specificity was around 85% and sensitivity was 60%. And again, if you look at the cutoff of 1% for the test had a very high negative predictive value of 84%. So basically, the DOT study showed that a cutoff of 1% can be used for diagnosis of acute rejection for cell-free DNA, and that's what we use in our clinical practice. They also looked at the median levels of donor-derived cell-free DNA for different types of rejection. So for antibody-mediated rejection, the level was 2.6%. For T-cell mediated rejection, grade 1B, the level was 1.2%, and the level was 0.3% for patients who did not have any histological rejection. So this was another very important study by Dr. Sigdal and group. It was done in UCSF in San Francisco, and they stratified the donor-derived cell-free DNA by the rejection status. So in their study, they had 217 biopsy matched samples with 38 showing active rejection, which is represented by these red dots, 72 showing borderline rejection, which is represented by these green dots, 25 showing other injury, which is represented by these dark green dots, and 82 82 showing stable allografts and no rejection, represented by these dark blue dots. And donor-derived cell-free DNA was processed from PCR, targeting about 13,000 SNPs. And what they reported was that the median level of donor-derived cell-free DNA was higher in biopsies with acute rejection, which was about 2.3%, and it was less than 1% in the other three categories. So for borderline rejection, it was 0.6. For other injury, it was 0.7%. And for stable allograft, it was about 0.4%. So cell-free DNA has high negative predictive value, and it can be used to rule out rejection. And this is actually a table which is looking at the rejection threshold and sensitivities and specificities and AUCs in different studies for cell-free DNA in solid organ transplants. And if we look at kidney transplant, we did briefly discuss these two studies, and both of them used a threshold of 1% for detection of rejection for donor-derived cell-free DNA. And if we notice, both of them had excellent AUC, so it's a very good marker to detect acute rejection. Although the specificity was not that great, it was only 60%, but the negative predictive value or specificity was very high. It was about 85%, which basically, it also helps us in ruling out rejection in patients with kidney transplant because of its high negative predictive value. And even in other solid organ transplants, including liver, heart, and lung, cell-free DNA, the EUCs for donor-derived cell-free DNA continued to be good, and they had high specificity and high negative predictive value. So this is a visual abstract showing comparing the two commercially available donor-derived cell-free DNA assays, which are available in the United States. So one is AlloSure and the other is Prospera. And I've used both of them. Our center was using Prospera till now, and now we are moving towards AlloSure just because of the ease of convenience of ordering it. And both of these tests use rejection detection at 1% threshold for donor-derived cell-free DNA. And in this study, they showed that the two tests did not differ between sensitivity, specificity, or area under curve. However, AlloSure did have a shorter turnaround time from blood draw. So the usual turnaround time is around 3 to 5 days for these tests, and AlloSure did better by 1 day. However, one thing which they did notice in the study was that Prospera did miss 2 cases of T-cell mediated rejection, even at a lower threshold of 0.5%. So till now, we talked about the utility of cell-free DNA in diagnosing acute rejection, in ruling out acute rejection. And next, this was the Admiral study, which was published this year, and they looked at the utility of cell-free DNA in monitoring the long-term survival and long-term allograft function. And this was an observational multi-center study. They had around 1,100 transplant recipients, and they used a cutoff of 0.5% for the donor-derived cell-free DNA. And what they showed was that the median level of donor-derived cell-free DNA was lower in patients with no rejection as compared to patients with rejection. And cell-free DNA was able to diagnose both clinical and subclinical rejection. The other thing they looked at was the GFR decline at 12 to 24 months. And what they showed was that the elevation of donor-derived cell-free DNA preceded the decline in GFR at 12 to 24 months, and this occurred by about 25%. So there was about 25% decline in their kidney function by 24 months, and that was preceded by an elevation in donor-derived cell-free DNA. And the other interesting thing was they looked at the occurrence of de novo DSA. So again, they showed what they showed was that the elevation of donor-derived DNA by more than 0.5% was associated with a 3-fold increase in formation of de novo DSAs 90 days after the cell-free DNA was done. So these are some of the advantages of cell-free DNA. So briefly, briefly we talked about its utility in different studies, which has shown this utility in diagnosing rejection and ruling out rejection and monitoring the long-term allograft function. So the first advantage is that it is non-invasive. The second thing is it's a screening tool. So its rise and its level precedes serum creatinine increase, and therefore it can be used for early detection. And also it has a very high negative predictive value, so it can be used for ruling out rejection. These are some of the limitations. So it's an expensive test. It's around $3,000 in the US. So mostly, most of the insurances do cover it, but it is still an expensive test. Also, it's a non-specific marker of kidney injuries. So an elevation in donor-derived cell-free DNA can also be seen with beacon nephropathy, glomerulonephritis, urinary tract infection, acute tubular necrosis, or CNI toxicity. It is not rejection specific. It does not differentiate between different types of rejection. So obviously the treatment becomes challenging. And in most of the cases, we would need a biopsy to confirm the type of rejection. It cannot be used with multi-organ transplants. So it cannot be used in patients who had history of bone marrow transplants or who have a combined liver or kidney transplant. Also, it cannot be used in pregnancy. We did have a couple of patients who were pregnant and who had elevated creatinine, and we did order cell-free DNA, and it was pretty high, and which is expected. So it cannot be used to detect rejection in pregnancy. So how can we use cell-free DNA now? I think one of the biggest advantages is that it eliminates biopsies due to high negative predictive value. It also assesses decision-making when biopsies are non-diagnostic. It can be used for surveillance after rejection treatment. It can be used in difficult to obtain biopsies, and it can be used for serial testing of high-risk patients. Thank you for your time, and I would like to thank my family, my mentors and collaborators from University of Cincinnati and our research team, and I'm open for questions.
Thank you, Dr. Shah, for this very interesting talk on the role of cell-free DNA in the diagnosis of rejection. And as you mentioned in your concluding slides, that even though this is a new and a non-invasive method, but the turnaround time takes about 3 to 5 days. So if you need to have an early diagnosis of rejection, which is essential in patients with renal transplant, would this be a choice of investigation to replace the biopsy, where you can get the report of the same day?
So yeah, that's a great question. So I usually don't use it in practice when I really want a biopsy and I'm really suspecting a rejection, because even if I order cell-free DNA, I would need a biopsy to confirm it and to tailor the rejection treatment, whether it's cellular, mixed, or antibody mediated. So I agree with you. I think when we are really suspecting rejection, better is to go with a biopsy. I think the test is mostly used in patients where we want to rule out rejection, especially a lot of like outpatients. I've ordered this test when I see like a slight increase in creatinine. They had a biopsy maybe a month back and it was, it did not show any rejection. So in that patient, we have ordered the biopsy in a patient which was actually refusing a biopsy, and she had elevated new DSAs. Her kidney, the way her kidney was placed, it was a difficult biopsy as well. So we ordered a cell-free DNA in that patient. It was high, and we empirically started antibody-mediated rejection treatment just at the overall scenario. So basically, in those cases, it is more useful. It is more like a screening test, and it helps to rule it out. But if I'm suspecting a rejection, I always go with biopsy. So I don't then order cell-free DNA.
Good. One thing I want to ask, because you said even in CNA toxicity, it goes up, along with, say, even in acute rejection, it goes up. So now the common clinical scenario, what we find is, say, if acute rejection or CNA toxicity is acute setting, wherein we want to differentiate either of these two. When you say this goes up even with CNIs, then we have to think a lot before ordering this test. And maybe I feel in the particularly you can monitor this DNA in asymptomatic patients. Maybe if its level going up, then though creatinine is normal, something is happening in the graft, then probably one may have to intervene that time. Whether that holds role for this test, because anyhow it takes about 5 days per week to get this investigation as far as you are concerned. So maybe in acute setting may not be of much use in that way. What is your
No, you're absolutely right. It cannot be, when it's a conflicting information, this test cannot be used. So especially if you have a PK, like it can be elevated with ATN, it can be elevated with CNI toxicity or beacon nephropathy, or any sort of allograft injury for that matter. So it can be, which occurs due to any other reason. So you're absolutely right. It doesn't differentiate. So when we really want to know the cause, especially for our patients, when they have delayed graft function in our practice or slow graft function, our protocol is to get a biopsy between 1 to 2 weeks. And we always get a biopsy. We may get a cell-free DNA to give us a better information, but it's not like something we rely on it, because biopsy is definitely diagnostic. So you are absolutely right. Regarding the turnover time, it's usually at our center is 3 to 5 days, but it can range between 2 to 5 depending on like where the test is performed, because it is sent through a courier. So some places may report it early as well, like within 2 days. But 3 to 5 is average at our center. So that is again regarding the time frame. But yeah, I agree with you. Like we cannot differentiate, and that's one of the challenges with the test.
The thing is, how do you see its future, considering the fact with so much of limitations?
Well, I really like it. I think it's one of the innovations in transplant. It is very expensive, so that is definitely a limitation factor, like $3,000 here. But most of the time, it's either covered by insurance or it gets absorbed by our centers, so patients don't have to pay for it. But I think it has great utility because, like it can help us ruling out maybe protocol biopsies. Our center doesn't do protocol biopsies, but some centers do protocol biopsies, so it can avoid that. A lot of centers do post-rejection biopsies, and our center is one of them. Like we are going away from it, but we still do it. And I think even in that scenario, instead of ordering a biopsy after treatment of rejection, we can just order a cell-free DNA and see how they do. So it does have utility. It cannot replace a biopsy, but I think with it being a high negative predictive value, it can definitely rule it out. So if it's low, it tells you, well, the patient does not have rejection. So if it is high, it obviously tells you something is going on. And whenever it's high in our patients, we always get a biopsy, unless patient is refusing or it's a high risk patient. So that's how we have used, and I really think it's one of the major innovations in transplant world.
I think the role is essentially where in patients where you're not very clear on a biopsy, there if you have a negative prediction by this test, that will help you rule out. There are two questions in the chat box for you. One is that is it increased in urinary tract infection? And the second question is the role of cell-free DNA in predicting T-cell mediated rejection.
So yes, it is increased in urinary tract infection. So any sort of injury to the kidney, donor kidney, it is increased, which can occur because of any reason, because that would increase donor-derived cell-free DNA, the way the test is designed. So it is increased in urinary tract infection if that's causing some sort of ATN or some sort of kidney injury. Not in all UTIs, only when it causes kidney injury, maybe pyelonephritis or severe UTI with sepsis. So that's the answer for that. And regarding the role of cell-free DNA in predicting T-cell mediated rejection, so I showed you a few studies, and the first study, the DART study, actually was not able to detect T-cell mediated rejection 1A grade,
it never reached the threshold, was still less than 1% for 1A detection of 1A rejection. For 1B, it was more than 1%. However, there were a couple of subsequent studies which was published, and they were able to detect T-cell mediated rejection 1A and 1B. However, it does not differentiate between T-cell rejection and B-cell, like antibody mediated rejection. So it really does not differentiate. So I think you can never rely on the test to make a diagnosis of rejection and just we have not been doing that. Like if cell-free DNA is high, we just don't start treatment for rejection. I just told you one case where we did because it was a high-risk patient, and for antibody-mediated, if you have presence of DSAs, that definitely helps you. But it cannot differentiate between rejection. So you would definitely need a biopsy to know what type of rejection you're treating.
Thank you. Thank you. Thank you so much, sir. Thank you, sir, Dr. Amit Gupta, sir. So it was such lovely discussion. We are little running behind the schedule about an hour's time, and we move on to the, thank you so much, Dr. Silvisha. I think it was an enlightening discussion as usual. Thank you, chairpersons, Professor Amit Gupta, sir, and Dr. Rajaram, sir, for joining us. We move on to the last session of today's conference, that is oration. Over to organizers. Yes. Thank you, ma'am, for that informative talk. We now move on to one of the most awaited sessions of the day. That is Dr. Vidya N. Acharya's oration speech by Dr. Angela Wang. I invite the chairpersons for this session, Dr. Anita Saxena, Associate Professor, Department of Nephrology, SGPGI Lucknow, who also established the Department of Renal Nutrition in SGPGI Lucknow, and Dr. Sukanya Govindam, ma'am, Consultant Pediatric Nephrologist, Mehta Children's Hospital, Chennai. I request Dr. Anita Saxena, ma'am, to kindly speak a few words and enlighten the audience on the vast multitude of achievements of Professor Dr. Vidya Acharya, ma'am, in the field of nephrology.
Well, thank you and good evening, ladies and gentlemen. At the very outset, I'd like to thank the organizers and the scientific committee of the first conference of WIN India, WINICON 2022, for having me here. It is indeed an honor for me to chair Dr. Vidya Acharya's oration, who is known all over the country as Mother of Nephrology, the First Lady Nephrologist of India. Dr. Vidya Acharya started her illustrious medical career completing her undergraduate and postgraduate studies from the prestigious St. GS Medical College and KEM Hyderabad Hospital, Mumbai. She dedicated herself completely to these institutions, where she joined as faculty and contributed immensely to the development of departments of medicine and nephrology. She ventured into a male-dominated world, and her entire journey was characterized by fearlessness and unflagging energy that ensured establishment of department that was the synergy of the world's eyes. She was responsible for establishment and development of the nephrology unit at the King Edward VII Memorial Hospital, and very first to start dialysis and transplantation facilities in Western India. She was one of the very few who helped formation and progress of the Indian Society of Nephrology, the Indian Society of Organ Transplantation, and held post of president in both these societies. She was also a founder member and past president of Hypertension Society of India. She was an active member of Education Committee, Hypertension and Kidney Disease Detection Committee of International Federation of Kidney Foundation. She was a popular teacher in medicine and science, having trained thousands of students at MBBS, hundreds of PG in MD, more than 200 students in the specialty of nephrology. Students trained and nurtured under her have achieved positions of prominence, and all her students stand witness to the care and love and attention showered on them. For all her contributions in the field of nephrology, She received numerous awards, including Lifetime Achievement Award from Indian Society of Nephrology and South Asia Region Pioneer Award from International Society of Nephrology. The Indian Society of Nephrology Western chapter has instituted an oration in her honor at its annual meeting. Madam will always be a guiding force and inspiration for a lot of women in India and abroad. This oration is being delivered by none other than a very renowned and decorated lady nephrologist with keen interest in renal nutrition, Professor Angela Moon Wong from Hong Kong. And she's been presented a plaque. Can we have the slide of the plaque, please? Can we have the slide of the plaque? Yes, and the plaque reads, this is Professor Vidyacharya Oration plaque, Women in Nephrology, India, when India, Professor Vidya Acharya Oration plaque is being delivered by Dr. Angela Yi Moon Wong, who is President of ISRNM, Council Member ISPD, Council Member ISN, and WINICON 2022 on the 13th day of August presents this, is being presented by NIMS Hyderabad. May I request my co-chair to Dr. Vijay K to kindly introduce Dr. Wong to the forum.
Dr. Vijay Kher was not able to join because of some issues, internet issues. Can I request Dr. Sukanya to kindly introduce the speaker, please?
Thank you very much. And at the outset, congrats to the organizers of WINICON 22 putting together such a wonderful program. And it is very well received and it's a super success, I believe. And it's my honor and privilege to be introducing the speaker for today for delivering the Vidya Acharya oration. And she's got an impressive bio, Dr. Angela Wang. And just reading it out to all of you here who are listening is in itself an inspiration to a young woman nephrologist like me. So here is her introduction. Dr. Wang is a staff nephrologist and clinician scientist working at the Queen Mary Hospital, University of Hong Kong, China. She is the current president of the International Society of Renal Nutrition and Metabolism. She holds various positions in many international societies. She is a council member of International Society of Peritoneal Dialysis, counselor of the ISN. She's deputy chair of ISN Education Working Group, and also she's part of the ISN North and East Asia Regional Board. She's been previous executive committee member of the KDIGO. She is also a committee member of the ISN Act and executive committee of the Song Initiative. She served as a working group member of multiple guideline societies, including the ISPD at various committees. She's also been impressive, most importantly, part of ISPD cardiovascular and metabolic guidelines in adult PD patients, the KDIGO anemia and CKD MPD guidelines, the KDOCI guidelines on nutrition in chronic kidney patients. She was also the steering member of several KDIGO controversies conference on dialysis practices, blood pressure and volume management, and CPG implementation on CKD MPD. She's also served as an editorial member of the Journal of American Society of Nephrology, Kidney International, Clinical Journal of American Society of Nephrology, NDT, and many more journals. And she was a previous associate editor of the AJKD. She's also received many awards. She's received the ISPD John Meher Award in 2006, Asian and Pacific Federation of Clinical Biochemistry Traveling Lecturer Award in 2011, the Joel D. Koppel Award of the United States National Kidney Foundation in 2018. She has an impressive array of presentations and publications, and she's very known and recognized for her excellent research in cardiovascular, metabolic, and nutritional complications in peritoneal dialysis and CKD. Such an impressive bio. Can't wait to hear from her. The floor is all open for Dr. Angela Wang for her oration. Thank you.
Good afternoon, ladies and gentlemen. First of all, I would like to thank the organizing committee for inviting me to present this Dr. Vian Achare's oration. It's been a great honor and privilege to present at this first annual conference of Women in Nephrology 2022 in India. The title of my talk is Nutrition Management in Chronic Kidney Disease. Think globally, act locally. My name is Angela Yimun Wang, and I'm from Hong Kong. Chronic kidney disease is estimated to be the 5th leading cause of death by 2040. And currently, there are 815 million people worldwide estimated to have some form of kidney disease. And data from 2010 estimated that 2.6 million adults receive dialysis or transplant worldwide. If you look at this more recent data from the Global Burden of Disease, Chronic Kidney Disease collaborations that were published in Lancet 2 years ago, you can appreciate that most of the burden of chronic kidney disease were concentrated in the 3 lowest quintiles of the social demographic index. And this observation didn't change in the last 27 years. Furthermore, when we look at the background chronic kidney disease, in fact, the global all-age prevalence of chronic kidney disease has increased 20.93% since the 1990s. And CKD resulted in 35.8 million disability adjusted life years in 2017, with diabetic nephropathy accounting for almost a third of the disability adjusted life years. And you can see this marked increase in the last 27 years. So in 2017, around 700 million cases of all-stage CKD were recorded for a global prevalence of 9.1%. We know chronic kidney disease increases the risk of cardiovascular disease mortality, and as the eGFR advanced, there is an increased risk of mortality. And likewise, if you have an increased albuminuria, this is also predictive of an increased risk of cardiovascular mortality. And that KDIGO has established this figure to show how the cardiovascular disease mortality is compounded by the combination of worsening eGFR and albuminuria. As we know, cardiovascular disease has a very close interactions with chronic kidney disease in that not only do they share some of the common risk factors, for instance, hypertension and diabetes, kind of non-communicable diseases, but also they have very common other risk factors and also dietary risk factors. In fact, we look at this recent analysis from the Global Burden of Disease, Chronic Kidney Disease collaborations that were published in Lancet. The age standardized rates of disability adjusted life years for chronic kidney disease were over 12,000, were over 1,250 in the oceanic region, and that was very high. So 1.4 million cardiovascular disease related deaths and 25 million cardiovascular disease disability adjusted life years were attributable to impaired kidney function, indicating how close cardiovascular disease is related to CKD. And here is this analysis that was published from the United States, looking at the different causes of death in relation to the associated risk factors. And you could appreciate chronic kidney disease was ranked 9th. But if you look at the associated risk factors, dietary risks was actually leading as the most significant factors associated with these top 10 causes of death. There is also this global burden disease diet collaborations analysis looking at mortality rate attributable diet in 195 countries between 1990 to 2017. And overall, there is 11 million deaths with 255 million disability adjusted life years that were attributable to dietary risk factors. And if you look at the leading risk factors that include diet high in sodium, diet low in whole grains, low in fruits, low in nuts and seeds, and low in vegetables or low in seafood omega-3 fatty acids. If you look at the disability adjusted life years, which more accurately reflects the situation, those that were attributable diet in 195 countries, again, if you look at the top few leading factors for the diet is low in whole grains, high in sodium, low in fruits, low in nuts and seeds, and low in vegetables, indicating the importance of diet in causing the disability adjusted life years globally. And shifting to a healthy diet has also been shown to be important to prevent the global burden of non-communicable diseases and also for sustainable planetary health. So this is one of the documents from the Eat Lancet 2.0 Commission showing how that the a planetary healthy diet potentially can reduce at least 22.4% of the global burden of disease and also preventing around 11 million adult deaths per year. So the World Kidney Day has developed this conceptual framework for living well with kidney diseases. And here you can see what impacts patients' life. And one crucial factor is the dietary restrictions or the lifestyle changes. And there is this interesting survey that were done by the IFKF WKA showing, trying to investigate factors that impact them from living well with kidney disease. And if you look at the 7 centers worldwide that have done this survey, among them, 5 of the centers select the dietary restrictions as one of the key factors that could impact patients living well with kidney diseases. And that accounted for around 24% up to 43% of the individuals that done the survey. So when patients ask about what I can do for myself to live well with kidney disease, among these top 5 things that patients assess, eat smart and eat well is actually ranked as one of the among the top 5 factors. On the other hand, we know patients that have chronic kidney disease, when they approach dialysis or when they're receiving dialysis, they actually have an increased risk of mortality due to the problem of protein energy wasting. And whether you assess it using serum albumin concentration, using serum creatinine as a marker of lean muscle mass, or protein energy wasting, using the subjective global assessment, you can appreciate how the worse nutritional status or more protein energy wasting is predictive of an increased risk of mortality. However, protein energy wasting syndrome is very complex in patients with chronic kidney disease, and that with a loss in residual kidney function or decline in kidney function in a non-dialysis stage, there is this whole host of metabolic derangements. And at the same time, there is the uremic metabolites and salt and fluid retention, as well as the comorbidities together with increased inflammation, and that could give rise to this protein energy wasting and cacaxic syndrome, which results in inflammation, hypercatabolism, muscle wasting, and fat loss. And this could actually lead to a whole host of adverse clinical outcomes, including cardiovascular adverse events, mortality, increased hospitalization, increased infection risk, and increased sarcopenia. And the end result is that this could impact patients' quality of life and impair patients' life participation, as well as leading to physical and functional deterioration and impairments. So the ISRNM has actually established this diagnostic criteria for protein energy wasting syndrome in kidney disease. And in essence, they recommend at least one biochemical indicator be included in making a clinical diagnosis of protein energy wasting. The other parameters include the unintentional weight loss, loss of muscle mass, as well as reduced dietary intake, which is unintentional. And some years ago, we developed this global estimation of the prevalence of protein energy wasting in kidney disease using this meta-analysis from contemporary observational studies. And in these studies, what we found when we stratified patients by the country's income, stratified the studies by the income of the income level of the countries, you can see the prevalence of protein energy wasting range from about 39% up to over 60%. And it also appears that the prevalence increases with worsening in the country's income level. So our previous studies have shown how the dialysis patients generally have a very much reduced energy and protein intake as compared to age and gender matched control subjects. And these patients are actually clinically stable when they have their intake pattern assessed. And not only do they reduce energy and protein intake, but you can appreciate that all the other vitamins, both water and fat-soluble vitamins, minerals, and the electrolytes, they are all reduced in the dialysis patients compared to healthy controls. And this is not surprising when you look at patients there of their appetite. So this is another study where we looked at patients with CKD with different stages. That is, that you move from stage 3 to stage 5 CKD, the appetite score actually worsens, and that there is a increased proportion of patients that have poor appetite. And also, when we look at the factors associated with poor appetite, other than worsening eGFR, in fact, the presence of cardiovascular disease and worsening ejection fraction, meaning more systolic dysfunction, is associated with worsening appetite. And that would no surprise be actually associated with reduced food intake. Cam Callender has also studied using different dialysis center cohorts data and show that the mortality rate was highest within the first 6 months of transition to dialysis. And that Elaine Koo has also shown that as CKD progresses, the detection of a longitudinal weight loss with an analyzed percentage weight change is predictive of an increased risk of mortality. And that in the adjusted model, it is over 50%, meaning how important nutrition status or maintaining the nutrition status is to the well-being of patients with CKD and approaching or transition to dialysis. So the reason being, patients who transition from non-dialysis CKD to end-stage kidney disease starting dialysis, they are under a whole host of metabolic derangements, and also they are subjected to a lot of mechanical stresses from the dialysis therapy, infection risk, hypercatabolisms or uremia, as well as worsening insulin resistance that could lead to metabolic instability and that increases their risk of protein energy wasting. On the other hand, we know that chronic kidney disease itself is a systemic disease where with the loss of kidney function, it is associated with a whole host of metabolic derangements, also bone and mineral disorder, as well as uremic toxins retention. And that all these actually could lead to epigenetic modification and increased inflammation, and that leads on to the development of cardiovascular disease. Even in dialysis patients, residual kidney function is crucial. And this is very, this was actually shown in a study, in some studies done from our group years ago, looking at the importance of residual kidney function in maintaining the uremic metabolic waste removal, also in removing sodium and fluid, phosphorus, and the reduction of residual kidney function also increases the onset of anemia, inflammation, and worst is the increased resting hypercatabolism. Because all these puts together increases cardiovascular comorbidity and increased risk of adverse outcomes. So here is the list of studies that we have conducted looking at contribution of residual kidney function to the overall nutrition status of PD patients. As outlined here, it reduces dietary energy protein intake and increased wasting, decreased micronutrient intake, increased inflammation, increased muscle wasting, and worst of all, it increases resting energy expenditure. So the loss of residual kidney function, in fact, may be central to the energy imbalance and protein energy wasting state in patients on dialysis. And that we have shown how the higher the resting energy expenditure, the greater is the risk of mortality and cardiovascular death. And that in fact, if you look at this multivariate modeling, residual kidney function, in fact, was the leading factor associated with resting energy expenditure. And that its significance outweighed other factors like cardiovascular disease, inflammation, and diabetes. Residual kidney function, even though there isn't usually a lot left in patients on dialysis, remains to play an important role in removing protein-bound solutes and metal molecules, and that peritoneal dialysis clearance cannot be considered equivalent. So therefore, to summarize, there are many important potential values of nutrition intervention in patients in CKD and those on long-term dialysis. There are kidney-specific risk factors in that it helps to retard CKD progression and preserve residual kidney function, and also prolong kidney survival in patients undergoing conservative kidney care or have no access to long-term dialysis. And it also is important in optimizing nutrition status and ameliorate protein energy wasting. But it is also important in ameliorate a whole host of metabolic derangements in patients with chronic kidney disease. It also helps to ameliorate various cardiovascular risk factors and ultimately improving patients' quality of life and also have better symptom management. So many years ago, in fact, Barry Brenner, back in the 1980s, in fact, I think it's in 1970s, they look at how protein intake, if you restrict protein intake, it has a beneficial effects on the kidney. So what they demonstrated is if you had ad libitum protein intake, that could lead to chronic vasodilation and glomerular hyperfiltration, as well as mesangial matrix overproduction. And all these injury could lead to glomerular sclerosis and manifest as increased albuminuria. So more recently, Cam Callender and Danique Fouque has actually again revisit the effects of low protein diet together with low sodium diet and reinforcing how important it is with a low protein diet in actually ameliorate the glomerular hypertension by vasoconstricting the afferent arteriole and dilating the efferent arteriole. And that this process actually enables the reduction in the mesangial injury, reducing the TGF-beta production, and reduce interstitial fibrosis, and that slows the progression of CKD. And that this early study from Barry Brenner's group and several others have actually pulled together into this Cochrane review, comparing the very low protein diet versus low or normal protein diet, with an outcome being end-stage kidney disease. And that all these studies summarized together have about 1,000 subjects with 500 in each groups, and that there is a significant reduction, about 36%, in reaching the outcome of end-stage kidney disease with the very low protein diet versus low or normal protein diet. And it is also based on this systematic review that 2 years ago, the Kidney Disease Outcomes Qualitative Initiative has developed this clinical practice guideline for nutrition in CKD and have provided this recommendation statement that for CKD 3 to 5 adults that are metabolically stable, they recommend protein restriction with or without keto as analogs, depending on the availability, patient preference, and clinician judgment, in order to reduce the risk for end-stage kidney disease or death, which was given a 1A, and the improved quality of life, which was given a 1C grading. And that the low protein diet was 0.55 to 0.6 gram protein per kilogram body weight per day, whereas a very low protein diet would be providing 0.28 to 0.43 grams of dietary protein per kilogram body weight per day. And we also now know that the low protein intake doesn't just act on the kidney to reduce proteinuria, reduce kidney death, but in fact, it has a whole host of, again, metabolic benefits associated with a low protein diet or keto as a supplemented very low protein diet. It actually ameliorates the derangements in the mineral bone disease, reducing phosphate, FGF23, and PTH. It improves lipids. It reduces the ADMA. It reduces uremic toxins, improves insulin sensitivity, reduces metabolic acidosis, and also, most important of all, one can maintain a nutrition status with a very low protein diet by supplementing with keto acids. There is also this very important study that were published in Nature some years ago, looking at how diet can reproducibly alter the human gut microbiota. So this is nicely shown in the panel, where you can see how a plant-based diet versus an animal-based diet can induces the microbiota very, very differently. And that as a result, it can significantly impacts the short chain fatty acids production from carbohydrates and amino acids fermentation. For someone taking a vegetarian diet or plant-based diet versus someone who are taking a animal-based diet. There is also this other study which looks at the role of gut microbiota in disease development. So here you have this germ-free mice that have very minimal weight gain. And when they are being fed, and in a conventional mice being fed a high-fat diet, they develop obese mice. And by transferring the feces from the obese mice into the less obese germ-free mice, actually these germ-free mice can develop obesity, suggesting that the metabolic syndrome can be transferred through the gut microbiota. And we now also know that gut microbiota is very important, and that in patients with chronic kidney disease, there is a significant perturbation in the intestinal gut microbiota, and that due to a variety of reasons. One is because of the uremic toxins. There is increased intestinal excretion of urea, as well as other uremic metabolites. There could be metabolic acidosis and also the reduced fiber intake in patients with chronic kidney disease, and that this would lead to a preponderance of the proteolytic bacteria and the shrinkage of the saccharolytic bacteria. And as a result, there was a reduction and alteration in this short chain fatty acids production. At the same time, there is this leaky guts in uremia, and that could lead to increased permeability of these pathobionts or the proteolytic bacteria, and that could actually stimulate an immune activation with resulting cardiovascular complications, infections. So here is a study done just a year ago from the hemodialysis patients, where they demonstrate patients who survived over 2 years follow-up versus those who didn't survive have a very unique and distinct gut microbiome composition. And here you can see this, these are the gut microbiota expression for those who survive versus those who actually didn't survive over the 2 years pattern, over the 2 years, and you can see a very distinct pattern between the two groups. And also there's another study looking at the nutrition status of subjects with the gut microbiota. Again, you can see very different gut microbiota profile for subjects who are protein energy wasted, denoted in the red bar, versus those who have normal nutrition. So indicating the gut microbiota may play a very important role in modifying the clinical outcomes and nutrition status of dialysis patients. So therefore, not only is the diet important, but also the gut microbiota under the modifying factors of the genes and the environment might actually determine disease phenotypes, in particular both kidney disease and cardiovascular disease. So here is this other studies that were looking at the contributions of gut microbiota to cardiovascular, kidney, and metabolic health. So if you had the dietary nutrients, carbohydrates, which were metabolized into the short chain fatty acids, and at the same time, the L-carnitine or the choline from the food, they are also metabolized into the trimethylamine, which gets metabolized further to the trimethylamine N oxide by the FMO3 enzymes, and that these TMAO actually can induces and develop cardiovascular disease, both atherosclerotic vascular disease, as well as chronic kidney disease with renal tubular interstitial fibrosis and injury. So here are some of the studies that look at how the serum TMAO is elevated in patients with chronic kidney disease and correlates with the coronary atherosclerosis burden, and that the circulating level of TMAO is strongly related to kidney function and is predictive of worse outcomes in patients with chronic kidney disease, other than increased cardiovascular events. More recently, there are also some data to show that the red meat intake, which actually contains a very abundant, very rich in TM, in this carnitine levels, actually can be metabolized into TMAO, and the TMAO-related metabolites can both predict an increased risk of end-stage kidney disease, but also incident cardiovascular disease. There is also very recent data to show that the gamma butyrylbetaine, which is an intermediate metabolite coming from the metabolism of L-carnitine to TMAO, is also pro-atherogenic. So what is more interesting is that recently there's this study showing how the microbial GBU gene cluster, in fact, this cluster can actually determine how the L-carnitine may be metabolized to this intermediate gamma butyrylbetaine into TMA and further into the TMAO. And that this intermediate gamma butyrylbetaine is also predictive of major adverse cardiovascular events over a prolonged duration of follow-up. So indicating how that the gene cluster is very crucial in linking cardiovascular disease risk that are associated with red meat consumption to microbiota L-carnitine catabolism. These findings suggest how important it is to study the nutrigenetics and the nutrigenomics in order to understand how the gut microbiota and the diet are linked with the cardiovascular disease as well as kidney disease. So therefore, not only is the red meat intake, in fact, with a healthy dietary pattern, therefore, there were previous studies examining the risk associated with all-cause mortality. And here is this study showing how having a healthy dietary pattern reduces the risk of all-cause mortality by about 27%. And more recently, there is this similar data to show how having high dietary vegetables and potassium intake actually reduces the risk of incident CKD by over 20%. And we also have similar data in the dialysis population examining fiber intake, showing how having high fiber intake is associated with a reduced risk of major adverse cardiovascular events. And interestingly, we also look at the protein to fiber ratio, and having a lower ratio actually is associated with a reduced having a lower ratio is associated with a reduced risk of major adverse cardiovascular events. The interesting thing is we examine the dietary fiber intake density, and that shows how having a lower density is predictive also of the major adverse cardiovascular events, indicating that the patients who are on dialysis generally consumed very low fruits and vegetables intake or fiber intake per unit nutrient densities. So I also want to emphasize that one of the very interesting findings we noted is if we stratify patients by their dietary fiber intake, we do see that those subjects who have lower fiber intake, in fact, they also had a higher cardiac troponin, NT-proBNP, a more left ventricular hypertrophy, and also more inflammation. So although we weren't able to elucidate a causal effect, but this cross-sectional association is interesting to further explore. So other than our study, in fact, there are numerous other studies subsequent to this, examining how fiber intake may relate to health outcomes, as outlined here. So essentially, what all these studies pull together show that the high fiber intake may be able to reduce the uremic toxins generation, reduce cardiovascular complications, as well as all-cause mortality, as well as reducing the incidence of CKD and reducing constipation. So what explain the benefits of fiber? In fact, it appears that the fiber may promote the saccharolytic bacteria, which promotes the production of short-chain fatty acids, and they are immunomodulatory. And also they can improve the intestinal barrier, reduce the permeability to the uremic toxins. And at the same time, because there is a reduction in the proteolytic bacteria, there is reduction in the uremic toxin metabolites production, and also that would lead on to a better preserved residual kidney function. So what is the recommended daily dietary fiber intake? So unfortunately, we don't have data to actually strongly recommend a level, but if we looked at the different guidelines or association that they recommended for the general population, generally one should reach over 25 to 30 grams in order to be considered sufficient. So there are other ancillary benefits with a high fiber diet intake or plant-based or Mediterranean diet. pattern in CKD is that it reduces the net endogenous acid production and reduces metabolic acidosis. And that could lead to potential beneficial effects on the metabolic profile, not only by decreasing bone reabsorption, decreased mineral bone disease, but also improve insulin sensitivity, reduce sarcopenia and muscle wasting, and also better preserved residual kidney function. And here is this systematic review done 2 years ago, looking at how treatment of metabolic acidosis with either oral alkaline or using dietary intervention by promoting more fruits and vegetables intake. Indeed, all these studies are very consistent in showing that there is a slowing in the rates of eGFR decline and also reduced risk of end-stage kidney disease, and that this was highly significant. So therefore, several different guideline bodies, including the KDOQI, KDIGO, and more recently, the European Renal Association, has given similar recommendations despite the lack of randomized controlled trial data. And in that, all these different associations or guideline bodies recommended that patients with chronic kidney disease should consume a diet that are high in vegetables, fruits, whole grains, fiber, legumes, and plant-based proteins, unsaturated fats and nuts, and low in processed meats, refined carbohydrates, and sweetened beverages. And Yare actually suggested Mediterranean diet as the diet for choice for patients with CKD. So we have some to study from the general population looking at the Mediterranean diet and how effective it is in improving clinical outcomes of patients and reducing the risk of cardiovascular disease. However, we don't have similar data in the renal population. So our group has actually done a cross-sectional examination looking at the Mediterranean diet score in incident dialysis patients, and you can see how big the gap is for the Chinese population. Because if you look at the orange bar, which means not adhere to the Mediterranean dietary pattern, you can see that the adherence is very poor, in particular in terms of the beans, the peas, or the whole grains. In fact, almost all these patients weren't following the Mediterranean diet score pattern. And also that the adherence to the red meat is also rather poor. And if we break down into those with atherosclerotic vascular disease and those who didn't have atherosclerotic vascular disease, we see the significant difference between those who have atherosclerotic vascular disease versus those who didn't in terms of the vegetables intake. So therefore, to conclude my talk, we do need a personalized nutrition management in patients with kidney disease. We need to adopt a patient-centered approach because there is no one-size-fits-all, and also a multidisciplinary approach. It is clearly important to define a personalized goal for nutrition management, and we must choose a diet patient prefers or one that bothers patient the least. And the new concept is that we need to reduce the restrictions in food choice and rather acting on reducing frequency of consumptions, allowing liberalization for patients to enjoy 1 to 3 unrestricted meals per week. And most important of all, we do need to assess baseline nutrition status, estimate their energy needs and protein needs, determine if there are any additional metabolic stress that may subject patients to an increased risk of protein energy wasting. And that for all patients with kidney disease, we need to promote a healthy dietary pattern, avoid processed foods, and also provide local adaptation for the dietary prescription. So here is what we would recommend for a healthy eating plate. And one important consideration when we deliver personalized nutrition management, as I've illustrated, is that we need to take into consideration of how the diet and the genes interacts and how the genes regulates, and also the expression of the various metabolites as well as the gut microbiota profile, and that would result or determine the nutritional phenotype of our patients. And also we need to utilize this information in order to develop precision nutrition care, and that this is actually the future for precision nutrition management. Last but not the least, I would also like to quickly shift my talk to briefly mention about this project, which we did ISRNM with ISN on assessing global kidney nutrition care, and the finding of which is very important. So the project is to essentially to examine the availability and capacity of kidney nutrition care across the world, And essentially, we developed a survey and distributed it to 182 affiliated countries, of which 155 countries answered. And the result is that 48% of the countries have dietitians to provide kidney counseling, and that 23% of low-income countries never have dietary counseling, and that 41% of the countries didn't have formal assessment of kidney nutrition. We also noted that there are very infrequent communications between dietitians and nephrologists, in that only in 60% of the countries would they communicated sometimes on kidney nutrition care. So to summarize the findings from these survey is that there are very significant heterogeneity and gaps in global kidney nutrition care, service capacity, availability, cost coverage, and that results in suboptimal kidney nutrition care in many parts of the world, especially in lower income countries. We also see significant global shortage of dietitians or renal dietitian expertise, and many patients with CKD who need nutrition intervention either don't receive it or receive suboptimal therapy with inadequate monitoring. And there are also deficiencies in interdisciplinary communication on kidney nutrition care delivery, especially in low-income countries. These data call for a concerted effort to improve access to kidney nutrition care and to improve global advocacy for government allocation of resources and prioritization of kidney nutrition care service, given their importance. We do need to increase training of dietitians, renal dietitians, as well as nephrologists, and provide training to personnel who provide kidney nutrition care in emerging settings. And that we also need to promote more structured interdisciplinary communication between nephrologists and dietitians to improve global kidney nutrition care. So to conclude my talk, dietary factors in nutrition intervention play a very fundamental and crucial role in early prevent and reduce the global burden of non-communicable diseases and the huge burden of CKD and related cardiovascular and metabolic complications. A healthy dietary pattern should be actively promoted and implemented in all patients with kidney disease as part of the standard kidney care. We need to adopt a person-centered, individualized approach with shared decision-making approach in the delivery of kidney nutrition care. And we observe a huge gap in global kidney nutrition care, and we need global advocacy and a concerted efforts to improve global access to kidney nutrition care, especially for low resources settings. With this, I would like to acknowledge the support from ISN and the ISRNM, and also funding support for this GKHA from the University of Alberta, as well as from ISRNM using a Fresenius Kabi educational grant. Thank you very much for your kind attention. And thank you for inviting me to deliver this oration.
Right. Thank you, Dr. Wong, for that excellent, outstanding, and authoritative oration. As is customary, no questions are allowed in oration, but I'd like to say that Dr. Wong has very nicely summarized the approach to a kidney patient, how we can maintain the nutritional status of the patient with dietary and lifestyle modifications, particularly her emphasis on the role of gut microbiota, along with the evidence of interventions that can reverse metabolic syndrome, and her particularly the impact of dietary fiber on the outcomes of CKD. And lastly, the patient-centered approach for improving the outcomes of CKD. Now it's over to Dr. Sukanya.
Thank you, Dr. Anita, for summarizing it so well. And Dr. Wang, congrats once again for delivering a wonderful, wonderful talk. And it was enlightening and more inspiring. And also thanks for sharing some of your work with us. I think you would like to say a few words to the audience, so please go ahead. Yeah.
Thank you so much, Anita, and also Sukanya. It's really a tremendous honor and pleasure to present at this year's WIN meeting and at this Professor V.N. Achara's oration. And I really also want to take this opportunity to thank the organizing committee for inviting me to give this oration. I would also like to acknowledge my research team and collaborators, of which I'm sharing a slide in my over 20 years of career in nephrology, both from the Chinese University of Hong Kong and also currently from the University of Hong Kong. Without all my research team and collaborators' support and working, all the work that I've presented would not have been possible. I would also like to take this opportunity to thank the International Society of Renal Nutrition and Metabolism for giving me the opportunity to work with the society for almost 10 years now. And I've learned a lot tremendously through working in the society. And again, I would like to thank everyone who work on this society that have made it to today's. So I also want to thank Anita for all your support and also the Indian Society of Nephrology for all the support. And thank you, everyone. It's been a great pleasure and no honor. And it's also a very memorable event for me. And I'm also very honored to receive the plaque from you. Thank you so much, everyone.
Thank you. Thank you, Dr. Wang. What a fitting end to today's session. Thank you very much. And over to the organizers now. Thank you.
Thank you. Thank you so much. It was a lovely session that was organized by that was conducted by the chairpersons as well as the speaker, Dr. Wang, who has been here struggling and coordinating with us since the evening. Thank you so much for being with us. And it was a great oration. Thank you so much. So we come to the end of the first day. It has been a spectacular show by the Win India. We move on to the second day's program, which again is little packed with the CPC panel discussions and the symposia as well as inaugural function. And before we wind up, a couple of announcements. There's a quiz session which will be conducted in the Hall A for all the students of nephrology, trainees of nephrology. The registration is free. You can join for the quiz session in Hall A. And the inaugural session will be conducted tomorrow from between 10 to 10:30. And there is a simultaneous session that would go on in the Hall B, that's the Learning Center in Exams Institute. To start with, in Hall B, we have the oral paper presentations, about 26 in number, and followed by the technician session, which will be an appraisal session for all the stakeholders, that is the dialysis nursing staff who are there. So we'll be doing that in the afternoon session. So tomorrow also, I'm sure we are going to deliver an exciting and an amazing and a brilliant session as well. So thank you so much. Thank you, everyone, the virtual joiners as well as the physical presence of the audience. Thank you, everyone, and good night. Thank you so much.
Bye-bye, Anita.